Hi everyone, a very good evening to all of you. Welcome to the LRR INI-CET Psychiatry session. I hope all of you are doing really good. So quickly let me know in the chat box if I am audible and visible to all so that we are able to start the session. So I hope this is good to go. All of you can hear me and see me. So let's start the session. So before starting the session, let us discuss few points before the session only. So in this session of the LRR INI-CET session Psychiatry, we are going to discuss some important high yielding topics. Also we'll discuss the previous year topics which have been asked so many times in the exam. Not only that, we'll also discuss some new updates. We'll talk about some new drugs and FQs. I always say future questions, some potential new questions also we're going to discuss. Now very important is to participate in the session. So try to answer whatever question we are discussing. Any doubts you are having, try to put them in the chat box. So see, I always say in my classes to all my students, it's always good to be wrong in the class than to be wrong in the exam. So even if you're guessing, you're second guessing the answer, try to write in the chat box so that even if you're wrong, you will remember always that what was the wrong answer you have marked and what is the correct answer as well. So it will be very beneficial if you are actively participating in the chat box. Also in the end, I'll give you some additional slides, some important points which have been asked or maybe asked in the INI-CET exam. So I'll discuss those additional points as well in the end. Don't worry about the PDF. PDF will be shared to all of you. So you'll be getting a link after the session in the description of this video. You will see a link and you will get the PDF. So don't worry about the PDF. So roughly we are going to have around 3.5 sessions and we are going to discuss some important points about psychiatry. So let's start the session. Let's start with the first question. See if we can answer this question. So we are starting with the very important topic of the MSc. See, the question is a 32-year-old man with schizophrenia. So the diagnosis they have given you in the question, it is schizophrenia. And the patient says, I know I have a problem, something is wrong with my mind, but honestly I think this started because my colleagues are constantly plotting against me and creating stress. That's why I am hearing these voices. Which of the following best describe the grades of insight? So what is insight? Insight is the awareness of illness. And typically we talk about 5 grades or levels of insight. So what is this? So can you appreciate here, the patient says that I know I'm having a problem, so he is acknowledging. See, when we are talking about insight, we're talking about insight of the mental illness. So here the patient is acknowledging that there is some problem in his mind. So what are the grades of insight? See, the 5 grades of insight. See, there is first grade is grade 1. So there is no grade 0. So remember, the lowest grade of insight is grade 1, where the patient completely denies an illness. So this patient may say, no, I'm not having any problem. So then we'll say it is grade 1. What is grade 2? Here there is slight awareness. So patient may say, yes, I'm having some problem. Then patient may deny completely in the same interview only. So can we say that there is slight awareness? So the awareness of the illness is increasing. Then what is grade 3? In grade 3 there is awareness of the illness, but here the patient is attributing it to some other factors. For example, patient may attribute to some external factors, or maybe to some physical factors around, or maybe to some medical problems he is maybe having, or may say I don't know because of what reason, maybe because of some unknown reason I am having this illness. So can you appreciate in the question, the patient is attributing the illness to some other factors. Here he is attributing it to some stress at work. So here the answer is grade 3. But let's complete this grading. Next is grade 4. Grade 4 is the intellectual insight. See, as the name suggests, intellectually patient is aware, yes, I am having a problem. So patient knows that the awareness is there, it is because of my irrational feelings or emotion, but he is not applying this knowledge to change the behavior. Sometimes you know that you have to study for the exam. So intellectually you are aware, but you are not applying that knowledge, you are not studying. So then we'll say it is grade 4, that is intellectual insight. What is the highest grade of insight? If that is asked, remember it is grade 5. It is true emotional insight. Here the patient is aware that the illness is due to own irrational feelings or emotion, and now the patient is applying this knowledge to change the behavior. So patient is taking medications regularly, he is going for the therapy sessions, he is also following the lifestyle changes which have been advised by the doctor. So then we say it is true emotional insight. So for example, you know that you should study for the exam and now also you are studying. So then we'll say it is true emotional insight. So here the answer is option C, that is grade 3. I hope it is clear to everyone. Let's now discuss the next question. A 24-year-old man is observed during the interview to have minimal facial expression. There is monotonous speech and little emotional reactivity even while describing emotionally charged events of his life. which of the following is the incorrect statement about this finding? So when I'll discussing these questions, I'll also try to identify some keywords. So whenever you are attempting any question, try to identify these keywords. Can you appreciate here, we are talking about affect. So in MSc, what is affect? We know what is mood. Mood is the persistent pervasive emotional state, emotions which the patient is feeling from within. उसे कहते हैं mood. What is affect? Affect is the expression of emotion. हमारे जो emotions हैं, they are expressed in our face, in our body language. So that is affect. Affect is something you are going to observe as a doctor. So tell me which of the following is an incorrect statement. Now can you say what is this abnormality? So we are talking about abnormality of affect. Can you appreciate that even while discussing some charged up emotion of his life, for example, we are discussing some sad moments of his life. Let us say recently somebody died in his family, or let us say we are discussing some happy moments of his life. Recently he was promoted, he became a father, but there is no change in the emotion. The patient is appearing like this. There is no change in the affect. So remember, you always run psychiatry from the name. So what is this known as? This is known as flat affect. Like in ECG, what is, when the person is dead, how is the ECG finding? It is flat line. So what is flat affect? Flat affect means as if the emotions are dead. There are no changes in the affect. So can I say it is flat affect? Yes. It can be seen in schizophrenia. In fact, we know that flat affect is one of the negative symptoms of schizophrenia. So please remember, it is not an affective symptom. It is a negative symptom of schizophrenia, which we are going to discuss. Also remember, it may be associated, so we know it is a negative symptom, and negative symptom may be associated with decrease of dopamine in the mesocortical pathway. So the incorrect statement here is very good. It is option D. So these were some important points about flat affect. Also, can you tell me another important abnormality of affect? What is labile affect? See, again, remember things from the name itself. So what is the meaning of lability in English? Something which is rapidly changing. So this is labile affect, rapid and abrupt changes of emotion. So I'm talking to a patient, I have not cracked any joke. The patient has not cracked any joke. Nothing funny has happened around, but within few seconds the patient starts laughing. Then within few seconds he starts crying, then again starts laughing. Can you appreciate without any reason there is rapid and abrupt changes of emotion? This is known as labile affect. Whereas in flat affect, we were giving him stimulus, happy stimulus, sad stimulus, there were no changes in the affect. Also, can you tell me two important conditions where you may see labile affect? Very good. So where we can see labile affect, one is mania, very good. You call it mania or bipolar disorder, I'll take both the answers. Can you tell me one more condition where you can see labile affect? Also, it can be seen in organic mental disorder. Now let's discuss the next question, and this topic is very important. Nearly in every exam you will see questions being asked from this topic of thought. So the question is, match the types of delusion with their correct description. So let me see if you can answer this question. So on one end, in one column there are types of delusion, and on the other column B there are some descriptions. So what is delusion of grandeur? So what is delusion of grandeur? Here the person, delusion of grandiosity, patient have false big beliefs. So patient is making some false big claims that I am the richest person on the planet. So yes, delusion of grandeur is patient is believing one is rich. What is delusion of persecution? In delusion of persecution, person believes somebody is trying to harm him or somebody is trying to kill him. What is nihilistic delusion? In nihilistic delusion, patient believes that he does not exist, or people around him does not exist, or the world does not exist. And lastly, also remember delusion of influence. In fact, this question was asked. Sometimes such newer terms may be asked in the exam, but don't be afraid. Always try to just see the name and you will understand what is the meaning of this delusion. So what is delusion of influence, beta? Here the patient believes that his thoughts or actions, they are controlled or influenced by others. So what is the right answer? The right answer is option A. In fact, let's discuss this topic of thought. See, we have divided the difficulties or abnormalities of thought into 4 domains. So what are the 4 domains of abnormalities of thought? One is flow or stream, second is content, third is form, and fourth is possession. Now tell me, delusion comes under which of the following categories? Remember, delusion is an abnormality of content of thought. So here there is problem in the content. So whatever the patient is thinking, the problem is in its content. And what is delusion? Please remember, we always discuss this point. Delusion is a psychotic symptom. So it can be seen in psychotic disorders like schizophrenia, delusional disorder, even in other conditions it can be seen. So what is delusion? Delusion is a false, fixed, firm idea or belief So patient is having a false belief in his mind which is held with extraordinary conviction. For example, a patient claims my neighbor wants to kill me. So this is a false thought. Family member says, sir, no, it is not true. But this is a thought which is fixed in his mind. No matter what evidence you try to give, the patient is totally convinced what I'm thinking is right. So this is classically what is delusion of persecution. So please remember, delusion of persecution is in fact the most common delusion in psychiatric disorder. Now also when we discuss about delusion, we also say this, that delusions are not explained, they are unexplained by the social cultural background. Now can you tell me this point in the definition of delusion? This helps us differentiate delusion from which another important entity. So here I am saying that delusion, they are not explained by the social cultural background. We know in certain societies there are certain beliefs. So some people in some societies believe that if a black cat crosses their way, something bad will happen. काली बिल्ली ने रास्ता काट दिया तो कुछ अपशगुन हो जाएगा. They believe this so strongly that they may not move until somebody else crosses by. So this also appears to be a false belief held with extraordinary conviction. But can I say that that belief is explained by the social cultural background? So then we don't call it delusion, we call that as superstition. So very important, remember, the last line in the definition helps us differentiate delusion from superstition. Delusion, they are unexplained by the social cultural background. So let's quickly discuss some of the important delusions. So one is delusion of persecution, which is the most common delusion. Please remember, it is not always, the patient does not always believe somebody wants to kill me, somebody wants to harm me. For example, a 16-year-old girl says that the school principal along with the teachers, they want to fail me in the exam. So again, this is a classical example of delusion of persecution. What is delusion of reference? Can you tell me what is delusion of reference? As the name suggests, patient thinks whatever is happening around him is in reference to me. So patient may claim that people are talking about me or somebody is spying on me. So that is delusion of reference. Delusion of grandiosity, we have just discussed. Patient make false big claims. Patient may say I am the king of the world, as if I am God. Or patient may say that, Prime Minister asked me how should I run the country. I made Donald Trump the president of USA again, although his neighbor does not know him, but he is making such false big claim. This is delusion of grandiosity. We have discussed that delusion is a psychotic symptom. It can be seen in psychotic disorder. Sometimes it can also be seen in other condition. For example, delusion of grandiosity may be seen in which condition? Important condition like mania. So sometimes even in mania, patient may develop psychotic symptoms. What is delusion of nihilism or delusion of negation? As the name suggests, here the patient is denying existence of his body or is denying existence of the people around, or may say that sir, this world is a dead world. ये मरे हुए लोगों की दुनिया है. So this is delusion of nihilism. Also remember, there is something known as Cotard syndrome. So see, in delusion of nihilism, can I say the person has become extremely negative? So it can also be seen in conditions like depression. Even in depression, sometimes psychotic symptoms may occur. So what is Cotard syndrome? Cotard syndrome is a term which is used when a person with depression develops delusion of nihilism, and in fact this is a PYQ which has been asked in INI-CET exam. A very interesting question was asked. The question was that a patient has depression and patient claims that I don't have a head, so what is the point of eating anything? Which delusion is seen? And both options, let us say A was delusion of nihilism and option B Cotard syndrome, both were given. So tell me in the chat box, beta, what you think would be the right answer of that question. So they had given a question of a patient with depression having delusion of nihilism, and the question was which of the following delusion is seen. Tell me what would be the right answer. Was it delusion of nihilism or was it Cotard syndrome? So please remember, please be very careful. Sometimes I always say this point that your exam is not just about the medical knowledge, but also sometimes they ask English, language related question. So here the question is not that what is the phenomena seen here, the question is which delusion is seen. So there the answer was beta delusion of nihilism. So please read the last line very carefully in the question what they are asking. Let's discuss some other important delusion. Beta, one delusion is Othello syndrome, also known as delusion of infidelity, also known as morbid jealousy. So what is the meaning of infidelity? The meaning of infidelity is patient thinks my partner or spouse is having an affair. So this is where the person may claim that my partner is cheating. Everybody is trying to convince him otherwise, no, your partner is fidel. There is no, point of any cheating involved, but the person is convinced, no, my partner is cheating. So this is Othello syndrome or delusion of infidelity or morbid jealousy. Now also, if the question they want to just increase the level of the question, they may just ask you which substance the patient may be consuming. sometimes chronic consumption of one substance may lead to this delusion. So can you tell me which substance we are talking about? Very good, beta. The answer is alcohol. Sometimes patient consuming alcohol for a long time may develop this delusion. Let's discuss another delusion which has different names. That is de-Clermont syndrome, also known as delusion of love, also known as erotomania. Now what is love? Of course, I am not asking the philosophical definition, very difficult to define what is love. But when you say love, you say I love that person. But here in delusion of love, patient says someone else is in love with me. So patient may claim that he is mad about me, वो मेरा दीवाना है. So this is delusion of love or erotomania or de-Clermont syndrome. For example, a 25-year-old female claims that the superstar Salman Khan is in love with her. So she may claim that जो मूवी आई थी, नई मूवी उनकी आई थी, किसी का भाई किसी की जान, उसमें वो जो जान है वो मैं थी. The Big Boss show which Salman Khan hosts, in that the eyes of the Big Boss are telling me that he is looking for me. Although the actor might have never met this person, but the patient claims that someone else is in love with her. So this is classically, remember, delusion of love. Also remember these names. Sometimes they may use these names in the options. Let's also discuss another important syndrome in delusion, delusional misidentification syndrome. See, always see the name. What do you mean by misidentification? So there is problem in identity of the other person. So two important syndrome we'll discuss, beta. One is Capgras syndrome. Don't mug up anything. Let's just remember Capgras syndrome from the name itself. See, so Capgras syndrome, remember it from the name. C for close, P for person, replaced by stranger. So patient has this belief that someone closely related to me has been replaced by a stranger. For example, let us say we had a patient, Mr. Cap for Capgras. He was admitted with us having schizophrenia, and he claims that his actual wife who came to meet him in the hospital, he says that you're looking like my wife, but you're not my wife. You are a hospital nurse in disguise. So can you appreciate here, the patient is claiming a close person, here in this case wife, has been replaced by exact double. So what is this phenomena, beta? Please remember, this is Capgras syndrome. Also tell me one important dementia cause which we will discuss later. Can you tell me which important dementia may also be associated with this Capgras syndrome? Tell me which important dementia. You may see Capgras syndrome. So patient may present with Capgras syndrome in that dementia. Remember, very good, we will discuss about this Lewy body disease. There we will discuss that Capgras syndrome may occur as a supportive feature of Lewy body disease. Let's discuss just the opposite of Capgras syndrome, which is Fregoli syndrome. See, in Fregoli syndrome, the person claims that a familiar person, now he is claiming someone he knows is imposing as a stranger, उसके सामने stranger बन के आ रहे हैं. So let us say there is a person, let's call him Mr. Freg for Fregoli. He was walking and he sees a stranger on the street, let's call him S1. So he's never met this person before. So he sees a stranger, he says, you're looking like a stranger, but you're not a stranger, you are my wife in disguise. What are you doing here? Go back to home, go back to home. He goes forward and he sees another stranger, let's call him S2. Again, by seeing the stranger, he says, you're looking like a stranger, but you're not a stranger, you are my wife in disguise, let's go home, let's go home. So here he thinks that a familiar person, in this case his wife, can take up, shape of another person and can also have multiple appearances. So this is Fregoli syndrome. Just like this image, you can see the person is changing the mask. So this is Fregoli syndrome. Again, please try to see, I'll give you one more trick to remember. Whenever you get confused, always try to see in the question the person is fighting with whom. So can I say in Capgras syndrome, C for Capgras, the patient is fighting with the close person only. So remember, in Capgras syndrome, the person is fighting with the close person. While in Fregoli syndrome, can you tell me with whom he is fighting, with the close person or with the stranger? He is fighting with the strangers. So can you appreciate, here he is arguing with the stranger, na, you are looking like a stranger, but you are not a stranger, you are a familiar person, I know. So this is Fregoli syndrome. I hope this is clear to everyone. Very important, sometimes question may be asked like this in the exam. So these were some important points about the delusion. Let's discuss the next question. So delusion is a very important topic. Please revise carefully. A 24-year-old male is brought by his family with decreased need for sleep. There is increased energy and excessive talking. During the interview, the patient says, "Doctor, I am feeling great, great like a king, king of the ring. Ring reminds me of weddings. Weddings are fun like cricket matches. Matches I used to play in college. College days were the best. What is the most appropriate description of this thought process? So can you tell me which abnormality of thought can you appreciate here? So here they are giving a lot of clues. Can you appreciate here? These symptoms again are suggesting that patient may be having mania. And here patient is saying a lot of things and things are not making much sense, but can you see that there are certain connection between the thoughts? Very good. So here the answer is flight of ideas. Very good. So let's discuss some other abnormalities of the thought. So next important domain we'll discuss is flow or stream. So normally thoughts are flowing in our mind, है ना? आप अगर बैठोगे silently आप देखोगे आपके mind में thoughts are flowing in the mind. So there may be abnormalities in the flow. One is when the speed of the thought may increase. So thoughts are coming very fast, but again just see the name. Flight of ideas. The name is telling you as if the ideas are on a flight. So patient is saying a lot of things very fast because the speed is increased. And patient may say things not making much sense and ultimately he will not answer your question. So we say that the goal is not reached. And very interestingly, when you will listen to what the patient is saying, you will see that thoughts may be connected. They may be connected by chance. So patient may say like this, my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So one thought may be connected by other by chance factor. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे, something like this. Or the thoughts may be connected by what is known as clang association or rhyming words. So patient may speak like this. Birds can sing, I am the king, phone goes tring tring, the weather is spraying, bring 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 bring. So patient is saying things not making much sense, but there is some connection. So can you appreciate in this question, you can find a lot of chance association as well as clang association seen in this question, and patient what he's saying is not making much sense. So this is, remember, flight of ideas. Even if speed is not mentioned in the question, please remember here they have mentioned the patient is talking excessively. Even if the speed is not mentioned, you can still identify flight of ideas by seeing some connections in the thought. So here the answer is flight of ideas. We will discuss some of these other abnormalities, but a tangentiality is an abnormality of form, and loosening of association also is an abnormality of form. Remember, sometimes there is some confusion between loosening of association and flight of ideas. See, one difference is that in loosening of association the speed will be normal, while in flight of ideas we know that the speed is increased. Suppose they have not mentioned in the question that there is some problem in the speed, that is not given. Still, can you appreciate, you will be able to identify flight of ideas because you will see some connection between the thoughts. And also we will discuss what is perseveration. So perseveration again is an abnormality of flow or stream. So let's complete this list. Let's discuss some other abnormalities. Next is circumstantiality. But please remember, in circumstantiality क्या होता है? The speed is reduced. So patient's thoughts are coming slowly. So patient may be speaking slowly, but very importantly in circumstantiality you will see patient may give unnecessary or trivial information. So suppose you ask patient a question, patient will speak about some unnecessary or trivial information, things which you have not asked for, but ultimately the patient will answer your question, so the goal is reached. Suppose somebody wants to go from A to B, rather than going directly, the patient may go like this, giving unnecessary information, trivial information, but reaching the goal. For example, I always discuss this example. Suppose you ask a patient, who is your favorite actress? So the patient may start like this, sir, Alia Bhatt acts very well. I have seen most of her movies. I was upset for a few days when I heard she is getting married, but may God bless her. Sir, Katrina Kaif is also a wonderful actress. I was upset for a few days when I heard she is getting married. May God bless her. Even Kareena Kapoor is a wonderful actress. I have seen her movie starting from Refugee. I was upset for a few days when I heard she is getting married. May God bless her. My favorite actress is Kiara Advani. So can you appreciate, patient has given unnecessary trivial information, but things are making sense. So again, important differences in flight of ideas, you will see that whatever the patient is saying may not be making much sense. In circumstantiality, patient is saying things making sense, but they are unnecessary, and ultimately he is answering the question. So this is circumstantiality. Also lastly, beta, what is perseveration? In fact, before that, let's discuss this question. A 58-year-old man with a history of head injury is brought for evaluation. During the interview, the doctor asks, what is your name? Patient says, my name is Mukesh. Where are you right now? He says Mukesh. What did you eat today? He says Mukesh. So can you tell me which of the following abnormalities is seen in this question? Let's see what is the abnormality. sometimes you will see these terms may appear very similar. So let's try to identify the abnormality here. Very good. So can I say here, initially this answer that his name is Mukesh was correct, but now he stuck at one answer. In all the remaining question, he is giving the same answer. So can I say he stuck at one answer, he is not able to go forward? Again, it's a problem of flow. So there is in fact problem of continuity, he is not able to go forward. So what is perseveration? Remember 3 P's. P for perseveration, the thought persists beyond the point of relevance. So can I say initially when he said my name is Mukesh, that is relevant, but now this thought is persisting beyond the point of relevance. So in the question they may just tell you patient is answering all the question with the same words or same phrases, then you are thinking of perseveration. But also remember, see what is echolalia? We will discuss this in catatonia. As the name suggests, echo means to repeat, lalia means word. Whatever you are saying, the patient is repeating the same word. What is your name? Patient says, what is your name? What do you do? What do you do? Where do you live? Where do you live? This is echolalia. And we'll discuss what is verbigeration. Verbigeration again is an abnormality of form of thought. In verbigeration, better please remember there is senseless repetition of words. Senselessly, patient is just repeating some words. I am banana black. I am banana black. I am banana black. So patient may be repeating some words, phrases or sounds which are senseless repetition. So please remember the difference is in perseveration. Initially what the patient was saying was making sense, was meaningful, but now it is repeated beyond the point of relevance. Let me ask you a question. But a patient says, I want to go home, home, home. Can you tell me what is this? What is this? This is an example of perseveration or verbigeration. So let's try to answer this question. Such questions may be asked. But please see here, when he says I want to go home is making some sense, but then he is repeating that last word again and again. So there are certain forms of perseveration also. But can I say here, initially it seems to be relevant and now it is being repeated beyond the point of relevance. So here again the answer is perseveration. I hope this is clear to everyone. Very, very important. Please be very careful. They may ask such newer question in the exam. Let's now discuss the next question. A 30-year-old male is admitted in the psychiatry ward for psychotic behavior. So there are some clues also given in the question. Over the past 8 months, the patient's mother says that the son is speaking things like he knows the USA president and the patient is the one who is actually running the country. So he is making such claims. Also, when he spoke, his sentences did not always seem to have any connection with each other. So there may not be logical connection between his sentences. He is using terms like pret, nit, wit, kit, fitlo, which is not making any sense. So there are some new words also which he is using. He is claiming to be followed by terrorist groups to kill him. Which of the following symptom is not seen? You have to tell me which symptom is not seen here. So can I say neologism? Again we'll discuss. Neo means new, logism means words. So patient may use some new words whose derivation you are not able to understand. So yes, there is neologism present. Loosening of association, yes, patient is saying sentences which are not having a proper logical connection. Delusion of grandiosity, here he is claiming that he is the one who is running the country USA. So he is making such false big claims. Yes, there is no perseveration. Can you also tell me, let me ask you one more question. Can you tell me any other phenomena which also is seen here? Can you tell me another important phenomena, one more phenomena which is being seen here in the question? So what is this? Patient is claiming that he's been followed by terrorist groups to kill him. What is this phenomena? So he's having a false belief somebody wants to harm him or kill him. So this is, remember, delusion of persecution. So there is no perseveration seen in the question. So very good. So let's discuss some abnormalities of form. So in the abnormalities of form, beta, form means organization. Normally you will appreciate that any thought which is coming in your mind, but that has organization. There is a logical connection. So you will see any thought you pick up, it will have a start, it will have a middle part and it will have an end. Any thought you are having, it will have a logical connection. But when we say that there is abnormality of form, we call in fact that as formal thought disorder. So as the name suggests, formal means it is abnormality of form. So formal thought disorder means the thoughts are organized or disorganized. Remember, it means that there is disorganization of thought. And in fact, remember, many of these formal thought disorders may be seen in conditions such as schizophrenia. In fact, we'll discuss when I'll talk about the symptoms of schizophrenia, you will see that these formal thought disorders can be seen in schizophrenia. So let us again see the terms. One is loosening of association. As the name suggests, the association between the thoughts has loosened up. So there is breakdown in the logical connection between the thought. For example, if you ask a person who is having loosening of association, what will you do if you want to have food outside? So patient may speak like this, sir, I will come back, I will order food, I will book a cab, I will reach cafe, black umbrella. So you will say that, sir, words are making sense, but I am not able to understand what he is trying to say. So that is loosening of association. Remember, in flight of ideas, we know the speed is increased, but sometimes they may not mention speed. How will you differentiate? See, in flight of ideas we discussed, there will be some connections. Next is derailment. Again, very interesting. Always remember the name, derailment. What do you mean by derail? A train is moving on track, suddenly it gets derailed. So person is going on the track, he is going on the topic for some time and suddenly he changes the track. Suddenly you will see he uses or he talks about some new topic. For example, this person I am talking to, I ask him what you will do if you want to have food outside. So for some time patient will be on track, sir, I will book a cab, I will reach cafe, and suddenly he will say, sir, IPL matches have started, I am rooting for my favorite team in the IPL and I hope that wins. So can I say this is derailment, also known as knight's move thinking. In the chessboard, how does a knight or horse move? It goes straight and suddenly takes a right or left. So this is what is happening in derailment. But again, it is clear to everyone, na? Sometimes they will ask such question, jumping off the track, that patient is on the topic for some time, suddenly changes the track, then you will think of derailment. What is tangentiality? Again, just remember the name. What is a tangent to a circle? In school days, teacher would ask you to draw a tangent. So tangent is a line which touches the circle at one point, it goes away. So what is happening in tangentiality? Patient just touches the topic and goes away. Does he answer your question? But in tangentiality, tell me the goal is reached or not. Does a tangent ever return to a circle? No. So remember, the goal is not reached. Differentiated from circumstantiality. In circumstantiality, patient was giving unnecessary information but reaching the goal. While in tangentiality, he just touches the topic and goes away and does not answer back the question. So let's ask this patient the same question which we asked from circumstantiality wala patient. Who is your favorite actress? So patient may just touch the topic, sir, I like Indian movies, especially the dances. In fact, Shahid Kapoor dances very well. I am also planning to take up orthopedics, which he took when he did the movie Kabir Singh. In that, the person Kabir Singh, he took orthopedics. So can you appreciate, he just touched that topic and he went away. Has he answered back the question? No. So this is tangentiality. Also, can you differentiate between derailment and tangentiality? But very important to call derailment, it should be evident that the person is on the topic for some time and suddenly changes the topic, and there is no relation between what he is now speaking and what he was speaking earlier. While in tangentiality, from the beginning he just touched the topic and he goes away. So please see the differences between these terms, very important. Neologism we have just discussed. Patient is using some new words, and also we have discussed verbigeration, that is senseless repetition of words. This is a very important table. You will see many questions being asked from disorders of thought. Lastly, we know there is abnormality of possession. We will continue with abnormality of possession. Just remember one point. One of the abnormalities of possession is, better remember, obsession. See, for all practical purposes, remember obsession is an abnormality of possession. It is also rhyming, so remember obsession, which we will discuss in OCD, it's an abnormality of possession. This question has been asked in INI-CET before. They have given a question of OCD and asked it's an abnormality of flow, form, content, possession. So the answer was abnormality of possession of thought. Also there is thought alienation. Also we will discuss thought alienation phenomena, that is also an abnormality of possession. We will discuss this when we will talk about the SFRS in schizophrenia. I hope this is clear to everyone. I hope this is clear. Let's discuss few more other terms. Next is hallucination. But please remember, hallucination is an abnormality of perception. Hallucination is an abnormality of perception. What is perception? So perception is how we perceive the external world, external environment. So you can hear me, you can see me, you can smell things, you can taste things, and also there is a sense of touch. So this is how we perceive the external environment. Suppose a patient comes and says, sir, on the screen along your left side, I can also see one more person sitting in the class. Sir, he is wearing white hat, he has a mustache and he is wearing white shirt. Can you see any other person other than me in the session right now on the screen? I hope no. But he is able to see. So can I say he is able to see? That means there is some problem in the perception. Now one important abnormality in perception, better remember, is hallucination. Just like we discussed in delusion, remember in hallucination also, remember it's a psychotic symptom. So it can be seen in psychotic disorders like schizophrenia, and also it can be seen in other conditions as well. So remember, it's a psychotic symptom. It's a false perception but without any real object. So there is no real object but person is able to see someone. Also remember, it occurs in the outer objective space. So he is able to see it in the outside world, in the external space. So that is hallucination. In fact, have you seen this movie? Classical example of hallucination. In this movie, Lage Raho Munna Bhai. Munna Bhai can see and hear Mahatma Gandhi. You know Mahatma Gandhi is no more with us, but unko Mahatma Gandhi dikhai de rahe hain, sunai de rahe hain. His friend is trying to convince, no, there is no Mahatma Gandhi, but is he able to convince him? No. Because Munna Bhai says, I can see and I can hear Mahatma Gandhi clearly. It is not under my control. It is coming and going on its own, and it is being appreciated or experienced in the outer objective space. So this is a classical example of hallucination. But before discussing the types of hallucination, can you tell me what is the difference between hallucination and pseudo hallucination? Pseudo hallucination also has similar characteristics as hallucination. It is also a false perception without real object. It is also very clear. It is also independent of patient's will. Can you tell me one important difference between hallucination and pseudo hallucination? Let me see if you can answer this question. But please remember, pseudo hallucination patient experience in the inner subjective space. So patient may say, I can see someone but inside my mind. I can hear some voices but coming from within, from my mind. So then you will call it as pseudo hallucination. Such questions have been asked in the exam, so please be very careful. Very good. Now just like we discussed, there are types of delusions, also there are types of hallucination. One is auditory hallucination. Here the person can hear things which others cannot hear. In fact, this is the most common hallucination in psychiatric disorder. Most common delusion कौन सा था? Delusion of persecution. Most common hallucination कौन सा है? Auditory hallucination. Please highlight visual hallucination, very important. So visual hallucination में patient is seeing things not seen by others. It could be any object like a bottle, it could be some animal like a cat, or maybe a human figure. The person is seeing something not seen by others. See, whenever in the question they give you visual hallucination, we know hallucination is a psychotic symptom. It can be seen in psychotic disorder like schizophrenia. But can you tell me one important condition which should come to your mind when they give visual hallucination beta in the question? Let me see if you can answer this question. Which one important diagnosis should come to your mind? Very good. In organic mental disorders, even in schizophrenia it can be seen, but in organic mental disorder, these hallucination can be seen. In fact, if I ask you most common hallucination in organic mental disorder, then you will say it is visual hallucination. So try to see if any organic mental disorder is given in the question. Next is tactile hallucination. So patient is having some touch sensation. So patient may say, I can feel insects crawling under my skin. So please take a blade, please make an incision and take out these insects. So this is tactile hallucination, also known as beta formication, also known as cocaine bugs or magnum bugs. Why it is known as cocaine bugs? Can anybody tell me why cocaine bugs? Because they may be seen with cocaine users. A patient comes to us with tachycardia, tachypnea and scratch marks. Which substance is he consuming? Let me see if you can answer this question. So patient comes to us. So tachycardia, tachypnea, why we'll discuss, because cocaine is a stimulant, and scratch marks are telling us why it is occurring, because patient may be having these hallucinations. Next is olfactory hallucination. Patient is having some smell, others cannot smell anything. And gustatory, patient is having some taste sensation. There is no food on his tongue, but usko kuch taste sensation aa raha hai. Again, they can occur in schizophrenia. Can anybody tell me in which important lobe abnormality also you may see olfactory gustatory hallucination? So let's see if you can answer this question, beta. They may just give you this question that patient had a road traffic accident, a head injury, admitted in the hospital, and patient has developed these olfactory gustatory hallucination. So which area you are suspecting? Very good. In temporal lobe disorders, very good, like temporal lobe epilepsy or temporal lobe tumor or trauma. Very good. Let us discuss one special hallucination also. See, a patient says whenever he turns on the radio, he sees color in the air. Now the color in the air, what he is seeing, others cannot see. Remember, this is which hallucination? Visual hallucination. So patient says whenever I turn on the radio, so the radio, in fact, beta, you can also hear. So this is a auditory real stimulus, and that is producing as a reflex a hallucination in different or same modality in a different modality beta. So which is this special hallucination? Very good. This is reflex hallucination, also known as morbid synesthesia. This is a PYQ asked in AIIMS before. What is another name for morbid synesthesia beta? It is reflex hallucination. Also, can you tell me any substance with which it may be associated with? Can you tell me any substance? Remember hallucinogens like LSD, lysergic acid diethylamide. So it may be associated with hallucinogen like LSD. But what is, somebody has mentioned beta, functional hallucination. What is functional hallucination? In functional hallucination also a real object is required to produce a hallucination, but it is in different or same modality. In functional hallucination beta, remember it is in the same modality. For example, a patient says, whenever I turn on the radio, I also hear a voice of a man coming from outside the room which others cannot hear. So here I can say that a auditory stimulus is producing a auditory hallucination, same modality wala hallucination, then I'll call it as functional hallucination. So please remember this point, very good. Let us now discuss this question. So we have discussed some important points from the MSc, but please be very careful. Usually one of the question is expected to be asked from the MSc, especially remember the topic of thought and perception. Let's now discuss this question. So now we are entering the disorder wala domain. So we know olden days the psychiatric disorders were divided into organic mental disorders and functional disorders beta. Functional disorders further are divided into neuroses and psychosis. In fact, when we talked about INICET, can you tell me INICET is present where? In neurosis or psychosis? Can anybody tell me? INICET is present in neurosis or psychosis? Usually is present in neurosis, absent in psychosis. As the name suggests beta, psychotic symptoms like delusions, hallucinations, they are usually absent in neurosis, present in psychosis. Okay, so these are some points. So let's now discuss the organic disorder. So see this question, a 72-year-old man is admitted in the hospital for pneumonia. So they have given some medical illness. On the third day of admission, he becomes restless, disoriented, confused and tries to pull out his IV line. He also reports of seeing small animals crawling on the walls. So again, what is this phenomena? He is able to see small animals crawling on the wall beta. What is this phenomena? This phenomena is visual hallucination. His symptoms fluctuate throughout the day and there is worsening of symptoms at the night time. His attention is impaired and is usually unable to maintain a conversation. Because of impaired attention, he is not able to maintain a conversation. What is the likely diagnosis? Very good. But what is the right answer? The right answer is yes. In fact, it is delirium. Can you tell me why it is hyperactive delirium? Because sometimes these terms may be given in the question. They may give you in the question just to confuse you, hyperactive or hypoactive delirium. Can you tell me it is hyper or hypoactive delirium beta? Try to see, the patient is restless, there is increase in the psychomotor activity, he is trying to remove the IV line. So there is increase in the psychomotor activity. So this is in fact hyperactive delirium. And in fact when we talk about delirium, we discuss delirium usually has an acute onset. They may give you some risk factor in the question, like here they have given you a risk factor beta like pneumonia. They may also give you some surgical illness in the question, patient had some surgical illness or patient had some operation, patient 2 days 3 days after the operation in the post operative period, or they may give you condition like patient had a RTA. So they may give you some of these important risk factor. But can anybody tell me why you have made the diagnosis of delirium beta? What is the one important point mentioned in the question which is telling us that patient is having delirium? You should also know what is important point to say it is delirium. So can you appreciate here, patient is disoriented, patient is confused. This is telling us there is impairment of consciousness. In fact, whenever we talk about organic mental disorder, we discuss this point. So organic mental disorder, in fact in the newer classification, both DSM-5 as well as in ICD-11, beta they have used a new name, neurocognitive disorder. See, as the name suggests, the patient is having a cause. So organic disorder, we say there is a cause, so there is a cause. So neuro, this term is telling us there is a cause and there is impairment of cognitive functions. Now very important, whenever we talk about delirium beta, we always say that there is impairment of consciousness. Somewhere in the question they tell you that consciousness of the patient, awareness of self or surroundings is impaired, then you are thinking of delirium. And we have also discussed this trick, remember this trick, ACDC. Somewhere in the question they tell you that there is altered sensorium और देर इज क्लाउडिंग ऑफ कॉन्शियसनेस, बेटा पेशेंट के क्लियर कॉन्शियसनेस में अब क्लाउड्स बादल आ गए हैं, अब वो क्लियर नहीं रहा. और दे में टेल यू पेशेंट इज डिसओरिएंटेड टाइम प्लेस और पर्सन. पेशेंट हॉस्पिटल में एडमिटेड है बट पेशेंट सेज आई एम एट माई होम, सो दे मे गिव यू दिस क्लिनिकल situation also, or they may just tell you patient is confused. So this is telling me that there is impairment of consciousness. I'm thinking of delirium. Since we're talking about neurocognitive disorder, of course even the cognition is also affected. So there may be impairment of memory, language impairment may be there, even perceptual abnormalities may be there. So can you tell me important perceptual abnormality you can see commonly in these patients? Which perceptual abnormality you can see? Also given in the question. So can I say visual hallucination, beta? Please remember. So always remember this, in delirium we say both consciousness and cognition are impaired. So very important point, highlight this, that in delirium the consciousness is impaired. Very important. Also remember one important scale we'll discuss, important assessment tool, that is CAM, that is confusion assessment method. Confusion assessment method, but that is used for assessing delirium. See, as the name suggests, confusion, we know confusion is seen in delirium, so CAM, it is used in assessing delirium. Also when we talk about patient having delirium, बेटा अगर किसी patient को जिसको delirium है और हमने अगर EEG किया, बेटा what is EEG? Let me write it here below. Suppose a patient has delirium और हमने EEG किया. Can you tell me what is the finding in EEG? EEG is electroencephalogram. So just like ECG measures the cardiac activity of the heart, EEG measures the electrical activity of the brain. So can you tell me what is the EEG finding? Very good. There will be diffuse slowing of the cortical background activity, but whatever may be the cause. It may be because of head injury, maybe because of infection, maybe because of hyponatremia, whatever may be the cause of delirium, you will see diffuse slowing in the EEG. But there is one exception, beta. There is one important exception, one important cause of delirium. You will see there is increase in the activity, fast activity seen. Can you tell me which cause of delirium I am talking about? Sometimes delirium can also occur because of beta alcohol withdrawal. Very important, delirium can also occur because of alcohol withdrawal. In alcohol withdrawal delirium, which is also known as delirium tremens, even in benzodiazepine withdrawal also patient may have delirium. In such a delirium you will see that the EEG activity is increased. So this may be asked in the question as well. Lastly, but if I ask you about the treatment, what is the treatment for delirium? Again, very important, in the treatment we always say that identify the cause and treat the cause. So I will do relevant investigation to find out the cause. As a psychiatrist, beta, again if I am asked what is the drug of choice or what is the treatment for delirium, sometimes in delirium you will see like this patient is very agitated. So patient may be having agitation or patient may be having delusion, hallucination. So beta, what we can give? We can give low dose of antipsychotics, and remember antipsychotic haloperidol is the most common. We can also use other antipsychotics like olanzapine, and even other antipsychotics can be used. But if they ask you one antipsychotic, then you can go with haloperidol, which is most commonly used. Also we can use benzodiazepines, but benzodiazepines like diazepam, lorazepam. See, in delirium I am saying that there is diffuse slowing on the EEG, or benzodiazepines can, benzodiazepines are CNS suppressant, so sometimes they can even worsen delirium. So benzodiazepine when we are using, we have to be very careful. We can use benzodiazepine, for example patient is having agitation, so we can use low dose of benzodiazepine, but remember sometimes benzodiazepine क्या कर सकता है, वो वर्सन भी कर सकता है डिलीरियम को. बट अगर मैं आपसे पूछूं benzodiazepine is the drug of choice बेटा for one particular delirium, कौन सा, for which particular cause of delirium, वहाँ पे हम बोल रहे हैं benzodiazepine drug of choice है. Again remember here the answer is delirium tremens. We'll discuss this point, delirium tremens, alcohol withdrawal में drug of choice कौन सी होती है, benzodiazepine. देखो दोनों अलग अलग क्वेश्चन है, अगर पूछें drug of choice for delirium specifically, then you can go with antipsychotic like haloperidol is most common. If they ask you drug of choice for delirium tremens, then you will choose benzodiazepine. I hope this is clear to everyone. Please be very careful when you are asked such question. So these were some important points about delirium. Let's now talk about beta dementia. Dementia, again a very important topic, you know, especially in the upcoming exam you will see many questions they may just ask from this topic of dementia. So dementia, again remember in dementia it's also a neurocognitive disorder. We say that consciousness here is intact, there is impairment of cognition. See, in delirium both consciousness and cognition are impaired, while in dementia we are saying it is only the cognition which is affected. For example, patient may have amnesia. Beta, what is amnesia? Can anybody tell me? हाँ, जो term delirium tremens है बेटा, that is the particular cause of delirium associated with alcohol withdrawal. उसे कहते हैं delirium tremens because उसमें alcohol withdrawal के other symptoms भी हैं, जैसे tremors are there, so other alcohol withdrawal symptoms are also present. What is amnesia? So amnesia beta, there is impairment of memory. So there is cognitive impairment, so memory may be affected. Beta, what is aphasia? What is aphasia? In aphasia there is language may be affected. Family member may tell you that he is not able to use words properly. What is apraxia? But apraxia means movement. So apraxia means there is impairment of fine learned movements. So in the question they may tell you patient is not able to comb his hair, he is not able to button unbutton the clothes, he is not able to tie and tie the shoelaces, not able to type on the typewriter. So there is some problem in the fine learned movement. What is agnosia? Patient is not able to identify objects. Like whenever you are doing a CNS examination, but in CNS examination you show some objects to the person and ask to identify. I asked this patient to identify this object, he is not able to identify. So this is agnosia. Sometimes patient is not able to identify the faces. Can you tell me what is the term we use for that condition when the patient is not able to identify the faces? Remember, that is known as prosapognosia. Prosapognosia. See, again in the name agnosia is coming, patient is not able to identify the faces. That is prosapognosia. So sometimes they may just ask you question on these terms as well. So in dementia we are saying that there is only cognitive impairment. Then let's complete this table. Beta, what is amnestic disorder? See here, as the name suggests, out of the cognitive functions here only there is problem in memory. So then we call it as amnestic disorder. So there is just impairment of memory. Again there may be many causes of amnestic disorder, can be CNS causes like किसी को seizure हो गए या trauma हो गया, CNS trauma is there or infection is there. Even there are certain systemic causes. Can you tell me one important cause beta of amnestic disorder related with alcohol, which I will discuss again later on? Okay, can you tell me any important syndrome associated with alcohol where you will see patient has developed amnesia, amnestic disorder? Yes, that is Korsakoff syndrome. Very good. We will discuss in Korsakoff syndrome, patient has amnesia. In fact, that is alcohol induced amnestic disorder. Actual culprit or cause is not alcohol, but it is because of deficiency of vitamin B1 or thiamine, which we will discuss. I hope this table is clear to everyone. You are able to differentiate what is delirium, dementia, amnestic disorder. Also answer this question beta, a close differential diagnosis of delirium. See, sometimes in the question they will give you this history, that sudden onset of symptoms which can also occur in delirium. They may give you a history of fever. Fever sometimes may tell you that patient may be having some organic condition, and patient has developed delusions, hallucination, which can also occur in delirium. So can I say this is a one possible differential diagnosis could be delirium? Can you tell me another important differential diagnosis beta here? Anyone? When this clinical picture is given beta, what this may also suggest you, remember even in acute psychosis, patient may have a history of fever at the onset. How will you differentiate? Again remember, we know delirium means impairment of consciousness. Somewhere in the question if they tell you that consciousness is impaired, then you are thinking of delirium. Otherwise you may call it as acute psychosis. Acute psychosis means symptoms similar to schizophrenia, but the duration is less. I hope this point is also clear to everyone. Very good. Yes, we will discuss beta Korsakoff syndrome. Yes, it is anterograde amnesia more than retrograde amnesia. Very good. We will talk about that point. So here again please see this question. Even acute stress disorder may have sudden onset, even acute psychosis, even mania may have a shorter duration of symptom, but here the diagnosis is it is hyperactive delirium. I hope this is clear to everyone. Let's now discuss few questions about dementia. Now dementia, usually we say there is progressive cognitive impairment. So many of the causes of dementia, they are progressive. But there are some reversible causes. Beta, nearly we say around 10 to 15% of causes of dementia, they may have a reversible cause. So you have to identify which of the following are reversible causes. Very good. So normal pressure hydrocephalus is a reversible cause. Hyperthyroidism, they are reversible causes. Lewy body dementia, it is not a reversible cause, it is usually a progressive condition, neurodegenerative disorder. Vitamin B12 deficiency, yes, that is also one of the reversible causes. So here the answer is A, B, D. Please be very careful. Sometimes in a hurry you may just mark A, B, C. No, it is A, B, D. So always read all the options carefully before answering the question. So let's discuss this very important slide. You have been asked many questions beta from this table. So we have around 10 to 15% of causes of dementia which are reversible. So there are certain neurosurgical conditions like SDH, subdural hemorrhage hematoma. So they may give you a clinical picture, and they may also give you a CT scan or an MRI. They may give you an imaging, and that is showing you subdural hemorrhage. Again, you treat this, dementia would be reversed. A brain tumor or an abscess may also cause cognitive impairment. Again, you treat it, it may be reversed. NPH is what? Normal pressure hydrocephalus, beta classical triad of cognitive impairment. There is also gait abnormality or magnetic gait is seen, and also urinary incontinence. So Hakim's triad or Adam's triad, a classical triad may be given. So one is neurosurgical causes. Then even infection like encephalitis, meningitis, that can also cause dementia. Very important, please highlight this metabolic causes. Certain deficiencies like vitamin B12, if they ask you one deficiency, very important, remember vitamin B12. Even other deficiencies like niacin, folate, and even thiamine deficiency can cause dementia. You correct the deficiency, dementia may be reversed. Also remember certain endocrinal abnormality, very important, hypothyroidism, again asked in the exam. Even other abnormalities like hyperthyroidism, even hyperparathyroidism, they are also associated with reversible causes of dementia. But can anybody tell me any one important substance patient is consuming for so much time and patient develops dementia, and you ask the person to stop that substance within a year, even जो brain में changes थे वो भी reverse हो सकते हैं. कौन से substance की हम बात कर रहे हैं? Remember alcohol. See, alcohol can also cause reversible dementia. Many of those dementias may be reversed. They have asked question better directly from this table. If they want to ask a new question, somewhere in the question beta they will give you a history of cognitive impairment. So cognitive impairment हो रहा है, that means you are thinking of dementia, and they may just ask you which of the following investigation you would do in this patient. So they may just give you some hint that you are trying to rule out reversible causes of dementia. So the options are brain imaging. One option may be check the vitamin B12 levels. Another option may be check the thyroid function test, and one option may be option D, all. So what all investigation would you like to do in this case? Such clinical question also may be framed from this table. So yes, we may do brain imaging if neurosurgical causes are suspected. We may also check vitamin B12 levels. We may also check the thyroid function test. So yes, the answer would be then all. So please be very careful. Very good. So this is a very important table. Please revise this. Let's now discuss a very important cause of dementia. See, if I ask you beta most common overall cause of dementia कौन सा होता है? What is the most common overall cause of dementia? Can anybody tell me? What is the most common cause, overall cause of dementia? Remember, that is Alzheimer's disease. Can anybody tell me what is the second most common cause of dementia now? Earlier it used to be vascular dementia. Now vascular dementia is number 3. So what is the dementia I am talking about? That is Lewy body disease. Please remember this. They may just ask you most common cause of dementia, and they may not give you Alzheimer's disease in the option. Then remember, the second most common cause is Lewy body disease. Now vascular dementia में quickly let's discuss few points. Just tell me how is the onset. Usually dementia का onset कैसा होता है? Is it insidious or is it sudden? Usually you will see that dementias like Alzheimer's disease have a slow onset. But in vascular dementia there is a acute sudden onset because there is some vascular injury. So there is acute onset. And also tell me a pattern which is seen in vascular dementia beta. A classical presentation pattern sometimes may be seen in vascular dementia. Remember PrepLadder, step ladder. Remember step ladder pattern may be seen in vascular dementia. Step ladder pattern of dementia may be seen in, very good, yes, in vascular dementia. So let's now discuss this question, a very important topic, Lewy body dementia or disease. A 72-year-old man is brought by his wife with complaints of fluctuating confusion or cognition, you can say, visual hallucinations and recent behavioral changes. He often insists that his wife has been replaced by an identical looking imposter and refuses to interact with her. On examination, he has mild rigidity bradykinesia which has developed since past few months. Finding is seen in the brain which is shown below. So there is some finding also beta that has been shown. Which of the following is incorrect statement about this condition? So this is a clinical picture beta which has been given. Now can you identify beta what is this? There is a pink core surrounded by a halo. Beta ये कौन सी bodies हैं, can anybody identify this? What is this bodies? These are Lewy bodies. You know, such questions also may be asked. So pathology and psychiatry integrated question may be asked. You have to tell me which of the following is incorrect statement. See, you have to tell me incorrect statement, beta. I just tried to make this question slightly difficult. Not very difficult, of course. I'm sure you can all answer this question very good. Yes. So can I say Capgras syndrome है ना, यहाँ पे मिल रहा है identical looking imposter. So he is saying that his wife has been replaced by a stranger who is identical imposter. So Capgras syndrome, in fact, we know is a supportive feature. REM sleep behavior disorder can be seen. In fact, this is a very important point which I will discuss, which can come as a potential new question or as a FQ. Now you have to tell me, is it Lewy body disease or is it Parkinson disease? See, let's first talk about the Lewy body disease or dementia due to Lewy body. What are the core features? But there are now 4 core features which we discuss with the mnemonic CVMR. So there is a person, Mr. Lewy, he goes to a body for interview and the interviewer asks Mr. Lewy, show your CV, Mr. So what is CC? It is dementia. So there is fluctuating cognition. So patient is having impairment of cognition, that is also fluctuating. So there is variation in attention, alertness. But we have already discussed now, visual hallucination are more common. Remember, visual hallucination are more common and they are in the core feature of Lewy body disease. See, when we talk about dementia, we say some have cortical, some are cortical dementia causes, some are subcortical dementia causes. But we know Lewy body disease, it is a mixed dementia. So here you will see both the cortical features. When the cortex is involved, you will see cognitive impairment. But जब सब cortex involved होता है, you will also see some motor abnormality. So here M is motor features of Parkinsonism like tremors, rigidity, bradykinesia. And what is R? This is a new core feature which has been added, that is REM sleep behavior disorder. Normally in REM what happens to the tone? Normally beta REM में हम बात करेंगे, there is atonia. The muscle tone is in a state of paralysis. तो normally जब हम REM में होते हैं, the body does not move. But if this atonia is not achieved, we know in REM we are seeing dreams which are remembered. So patient may start acting out those dreams. So patient may have kicking, punching movements when he is in REM. So that is known as REM sleep behavior disorder. Please be very careful. They may just give you this clinical picture. A person in sleep in REM is having such movements. Normally we know in REM there are no movements, but he is having movements in REM. Which dementia you may be suspecting? Again, the answer would be Lewy body dementia. So these are the core features. Then patient may also have certain supportive features. They may have severe neuroleptic, means antipsychotic sensitivity. So they may have higher risk of developing EPS, which we will discuss. Patient may even have repeated false syncope. There may be transient loss of consciousness, severe autonomic dysfunction. But there may also be systematized delusion like delusion of persecution. और कौन सा delusion हो सकता है? Remember, Capgras syndrome भी मिल सकता है. Sometimes patient may present to us with Capgras syndrome, और अब डिटेल में हिस्ट्री लो, patient may actually be having Lewy body dementia. And as the name suggests, बेटा पैथोलॉजी में क्या मिल सकता है? These are Lewy bodies. These are alpha synuclein deposits which can be seen in Lewy body dementia. Also remember, ये Lewy bodies और कहाँ मिल सकती हैं? Can anybody tell me बेटा where else you can find these Lewy bodies? Anybody? These can also be seen in Parkinson disease. Very very interesting. In Parkinson disease dementia, see, Parkinson disease can also cause dementia, and Parkinson disease dementia is a subcortical cause of dementia. उसमें भी ये फीचर्स बेटा मिल सकते हैं, साथ में Lewy bodies मिल सकती हैं. तो Lewy body dementia का close differential diagnosis कौन सा है? Parkinson disease. We'll discuss how to differentiate. Also, when we do FDG PET imaging, when we do this beta, what we may see posterior cingulate island sign. So there is hypometabolism in the occipital area and there is relative sparing of the cingulate cortex. Especially in the initial phases, this may be seen, and this may help initially to differentiate Lewy body disease from Alzheimer's disease sometimes. Let's now come to that question. I hope this slide is clear to everyone now. Some potential questions may be asked from this slide. So please be very careful, revise this when you are revising for the exam. But now tell me, so we can say that Lewy body disease and Parkinson disease dementia, beta these are close differential diagnosis of each other because दोनों में वो features हो सकते हैं. अब differentiate कैसे करोगे? Remember, Parkinson disease dementia ये कौन सा dementia है? ये subcortical dementia है. तो यहाँ पे subcortex पहले involve होगा. You will see motor features will come first, followed by cognitive symptom. In fact, in neurology we use a 1 year criteria. That motor symptoms के शुरू होने के after 1 year the cognitive symptoms would occur. While in Lewy body dementia, both cortex and subcortex are involved, so cognitive symptom would be present initially plus minus motor features. Motor features may occur initially or may occur after some time. So can you appreciate in this question, initially patient was having cognitive symptoms and later on patient has also developed these motor symptoms. So now can you tell me what is the diagnosis? So you will say yes sir, it appears to be Lewy body disease. So the incorrect statement is option D. I hope this is clear to everyone. Very important to remember Lewy body dementia. Let's now answer this question. A 70-year-old male presents with symptoms of difficulty remembering using tools like screwdriver, makes grammatical mistakes while speaking. These symptoms have been present for the last 2 years. Which of the following is incorrect about the drugs used to treat this condition? First tell me what is the diagnosis you are suspecting. But always in the question हमेशा try to identify the clinical picture. देखो elderly person है and is having difficulty remembering, so it seems to be having amnesia, is not able to use tools, so can I say there is problem in learned movement, so apraxia is there, is also having a lot of grammatical mistakes while speaking, so there is aphasia. So patient is having a lot of these cognitive impairment and 2 years, so it appears to be insidious onset of dementia. Most likely patient may be having Alzheimer disease. So what is the incorrect statement about the drugs which we use? So let us now talk about the drugs. Again a very important hot topic for your exams, better drugs used for dementia. So in dementia, let's try to remember the mechanism of action of drugs with the etiology. So let's for example talk about Alzheimer disease beta. In Alzheimer disease we know one important neurotransmitter, if they ask you, it is acetylcholine, and there is decrease of acetylcholine. So what is the important drug we use? That is choline esterase inhibitors. As the name suggests, they inhibit this enzyme acetylcholine esterase enzyme. Now normally acetylcholine is broken down into acetyl-CoA plus choline by this enzyme. But अगर हमने इस enzyme को inhibit कर दिया, so what will happen? There will be increase of acetylcholine which is required. So always try to remember the mechanism of action of the drugs with etiology. So we are saying कि acetylcholine कम हो रहा है dementia में, like Alzheimer's disease में, तो what we are doing, we are trying to increase. So remember some of these drugs, very important. One is, first is Tacrin. Now we don't use Tacrin much nowadays, but can anybody tell me why? So again some pharma question may also be asked. हम Tacrin को क्यों नहीं use करते? Because of one important side effect, it is hepatotoxicity. So it is hepatotoxic. Let's discuss some of the other drugs. One is donepezil, rivastigmine, galantamine. But when we give these drugs, patient may also develop GI side effect. In fact, this is a INI-CET का question. A patient when started on these cholinesterase inhibitors, the patient developed GI side effects. Now out of these drugs only उन्होंने पूछा था इनमें से ही कौन सी ड्रग फिर से आप यूज कर सकते हो. So I am asking you indirectly, बेटा इनमें से क्या कोई ड्रग है? Any of these drugs which I can use other than oral route? This was the very good. Rivastigmine, remember it can be given as transdermal patch. Very good. So the answer was rivastigmine. In fact, remember one more update now. There is a new drug, benzgalantamine. This is a oral drug. So see, they have already asked question on GI side effect. This is a oral drug, but remember which has less GI side effect. Okay, so it's a prodrug of galantamine. So this is a new drug which has been developed, which has less GI side effect. So next time they may just ask you this question also. So first is acetylcholine cholinesterase inhibitor. This is the first category of drug, but again these drugs don't cure the illness, they just slow down the disease progress. Second drug which we will discuss, better remember there is one more neurotransmitter, remember glutamate. देखो glutamate क्या है? If I ask you from your biochemistry knowledge, you will say sir glutamate is a inhibitor or excitatory neurotransmitter. It is a excitatory neurotransmitter, and glutamate initially beta is increased. So excess of glutamate क्या करता है? It causes the excitatory damage to the neurons. And one important drug, remember, is memantine. So they may just ask you the mechanism of action of memantine. Remember it is a NMDA antagonist. In fact, this NMDA receptor, which neurotransmitter beta acts on these NMDA receptor? It is the glutamate. So can I say, I am saying that glutamate is increased, so I am using NMDA antagonist. And it is usually used in moderate to severe cases. And sometimes we can combine memantine with cholinesterase inhibitors like donepezil. So these are two drugs. Remember, they don't cure the illness, but they slow down the disease progression. In fact, now there is a new category of drug, but this may come as a potential new question now. FDA has approved a newer category of drugs, that is the monoclonal antibody. See, these are monoclonal antibodies. So what do antibodies do? They go in the brain and they bind to an antigen. So they bind to, in fact, remember, A beta deposits. Up till now the first two categories बेटा जो हमने डिस्कस किए थे, they can be used in different causes of dementia, but monoclonal antibodies better, they are used only for one particular cause of dementia. We know that these A beta deposits, they occur in Alzheimer disease. So remember, they are used for especially mild cases of Alzheimer disease only, not for any other cause of dementia. So very important point, remember this. So these monoclonal antibodies, they go and bind to these A beta deposits and help in their clearance. So this is the mechanism of action of these monoclonal antibodies, and there are three important approved drugs which you can remember from the name itself of Alzheimer disease. So one is starting with A, one is with L, and one is with D. So first is aducanumab. Mab means monoclonal antibody. So can you remember the name? Yes, you can. Aducanumab. Another is lecanemab. Can you remember the name? Yes, you can. And one is donanemab. So remember, these are monoclonal antibodies. Also, when we are giving these monoclonal antibodies, they are usually given, in fact they are given by IV infusion. One important side effect which can occur, so repeated MRI are also being done for this important side effect, that is ARIA, that is amyloid related imaging abnormalities, they can occur in the patient. So please remember this as well. Sometimes they may just ask you this question, what is this ARIA, amyloid related imaging abnormalities. I hope this table is clear to everyone. This is a very important table. They may just ask you newer questions also from this table. So let's now come to this. You have to tell me which of the following is incorrect, but please read it carefully. Especially in INI-CET, you will see a lot of questions will be from match the following, or they may just ask you which of the following is not true. Rivastigmine is available as transdermal patch, it is correct. Memantine is a NMD antagonist, correct. Lecanemab may be associated with ARIA, yes. Donanemab, it is not a cholinesterase inhibitor, it is also a monoclonal antibody. So right answer is option D. Let's now discuss some questions from the topic. So we have discussed some important points about organic mental disorder. Now let's talk about some important points from the psychotic disorders. A 30-year-old male reports of having stabbing sensations in his stomach for the past few months. These sensations occur intermittently in the daytime and would lead to a lot of distress. He told his wife to distance herself from the new neighbors, as he claimed that they have hidden an electronic chip in their house which is sending signals and causing this pain. You have to tell me what is this phenomena, what is the likely phenomena. So can you tell me what is the likely phenomena? See, again, always remember it from the name. So patient is having some somatic sensation, so some bodily sensation he is having, which he says is because of some external agency. So just remember the name, you will be able to understand very good. It is somatic passivity. But a passivity, remember, whenever they use this term passivity, that is telling you it is because of some external agency. So somatic bodily sensation which is because of some external agency. So this is somatic passivity. In fact, they may just ask you question from the history of schizophrenia. So let's talk about Schneider's first rank symptoms, that is SFRS. So, before the concept of schizophrenia was more clearer, in the history we talk about Schneider who gave certain symptoms. So, let's talk about these first rank symptoms, 11 SFRS given by Schneider. So, let us see the first three. Patient is having audible thoughts or thought echo. But here the patient may say that I am able to hear my own thoughts. उसको अपने ही thoughts सुनाई दे रहे हैं. In fact, this is an example of first person auditory hallucination. Or patient may say he can hear voices discussing about the patient. So patient may say, if this is the patient may say, sir, I can hear few voices which are talking to each other and they are discussing about me. In fact, this is an example of third person auditory hallucination. And patient may also claim that he can hear voices commenting on one's action or giving a running commentary. So patient may say, sir, जो भी मैं कर रहा हूँ, whatever I am doing, एक running commentary चल रही है उसकी, या voice is giving a running commentary in the background. Again, it's an example of third person auditory hallucination. So can I say the first three are auditory hallucinations? But tell me it is true or false. Auditory hallucination is SFRS. But they may just ask you some question from this also. I'll tell you what kind of question may be asked. But before this, tell me, auditory hallucination are SFRS, true or false? Tell me, is it true or a false statement? Let me see if we can answer this question. But true or false? But I can say it is partially true, because not all the auditory hallucinations are SFRS. Only these three particular auditory hallucinations are SFRS. Partially true I can say. But please remember this. देखो, Now we know that any hallucination can occur in schizophrenia. The current concept is any hallucination can occur, but if they want to ask question from the historical aspect, they may give you 4 types of auditory hallucination and they may ask you which of the following is more likely suggestive of schizophrenia. So please see in the question if they have mentioned any of these auditory hallucination, then you may mark that. So first 3 are some auditory hallucination, next 3 thought insertion. Patient is experiencing that somebody is inserting thoughts in my mind. Thought withdrawal, patient says somebody is withdrawing away my thought. Or thought broadcast, patient says मेरे जो thoughts हैं they are getting broadcasted outside. In fact, this thought alienation phenomena, this is known as thought alienation phenomena, also known as passivity phenomena. But again passivity का मतलब क्या है? It is under someone else's control. So this is also known as passivity of thought. Okay, so remember these are again where we have discussed these 3. Can anybody tell me where usually we discuss these thought insertion, withdrawal, broadcast? Remember we discuss it under the possession of thought. So under possession, one is obsession and also this thought alienation phenomena. So these are the first 6. Now let me ask you one question. They may just ask you this question, but try to answer this question. A patient says, sir, in the television the news anchor is giving me some secret message. So the question is, but a patient says that the news anchor in the TV is giving me secret message. What is this phenomena? Can anybody tell me better what is this likely phenomena? There are 2 separate questions, so I am trying to just clear this doubt also. So tell me what is this example of? Patient claims that the news anchor on the television is giving him some secret message. तो ये क्या एग्जाम्पल आपको लग रहा है बेटा? दिस इज एग्जाम्पल ऑफ व्हाट? वेरी गुड. कौन सा डिल्यूजन लग रहा है बेटा? वेरी गुड. दिस इज डिल्यूजन ऑफ रेफरेंस. पेशेंट को लग रहा है थिंग्स अराउंड हिम आर इन रेफरेंस टू हिम. सो दिस इज डिल्यूजन ऑफ रेफरेंस. Another question, patient says that the news anchor on the TV is telling my thoughts to others, to other people. ये कौन सा फिनोमिना है? But I hope this is clear ना? Here the patient says कि जो मेरे thoughts हैं they are being told to all the other people by the news anchor. My thoughts are getting broadcasted outside. Then you will think of thought broadcast. I hope this is clear to everyone na? So please try to identify the phenomena in the question. Very good. I hope this is clear. Very good. Next 3 are made phenomena beta, which you can remember with the mnemonic IFA. So Bollywood में IFA words होते हैं. So remember made impulses. What are impulses? Impulses are urges. So patient says, sir, I am having some urges in my mind. I am having repeated urges to get up. But sir, these are not mine. Somebody is putting these urges in me. So I am made to experience this. So that is why it is known as made phenomena. What is made feelings or made affect? Patient is crying in the ward. आप जाके पूछते हो what happened? Patient says, sir, this feeling of crying is not mine. Somebody is making me have these feelings. So this is made feelings. Made action. One patient slapped another patient in the ward. You went and asked what happened, why have you slapped him? You know what the patient says, sir, this action of slapping, this act is not done by me. Somebody has made me do this. So ये क्या है? Made act. So patient experiences that impulses, feelings or urge. Somebody else is making him experience it. So these are the made phenomena. Let's discuss the last 2 beta. They may just ask you question on these last 2. One is somatic passivity. As the example we discussed, beta, patient comes to us, Mr. Bholu comes to us with pain in the abdomen, but he says this pain is because of the radio waves sent by the alien. So ये क्या है? Somatic passivity. Again just see the name, delusional perception. This question was asked recently in one of the exams. Delusional perception में बेटा patient के mind में there is a delusion which has developed after a normal perception, after experiencing a normal perception, patient के mind में delusion आ गया. So this is delusional perception. The question which was asked was that a patient sees that the birds are flapping their wings. तो उसको birds दिख रहे हैं flapping the wing, and what he says that it is God is sending him signal to run away. So can I say a normal perception has led to development of a delusion? तो ये phenomena क्या है बेटा? This is delusional perception. I hope this is clear to everyone. So here the answer is somatic passivity. So please be very careful. A lot of questions are being asked nowadays from the history also. I hope this is clear to everyone, right? Now also tell me beta, let's discuss one more point in the history. Can anybody tell me who coined the term schizophrenia? Can anybody tell me who coined the term schizophrenia? The term schizophrenia was coined by Eugene Bleuler. So one important contribution of Bleuler is he coined the term schizophrenia. What is another important contribution which can be asked in the exam? Beta, he also gave what is known as Bleuler's 4A's. So tell me, what are the Bleuler 4A symptoms? So one is loosening of association. So association abnormalities are there. So one is loosening of association. We have discussed loosening of association can be seen in schizophrenia. Another is affective abnormalities, affective flattening, flat affect again can also be seen in schizophrenia. Next is, remember, autism. But here autism does not mean that childhood wala autism. Autism here means patient is having fantasy thinking or illogical thinking. Patient is having illogical thinking. Again, this is a PYQ. But illogical thinking means you will not be able to see a logic in the thinking. For example, this question was asked that a patient says Lord Hanuman was a celibate. He was a brahmachari, a celibate. I am also a celibate. That means I am Lord Hanuman. What is this phenomena? This is autistic thinking, which was asked in the exam. And one more A, remember, is ambivalence. But they may just ask you question on ambivalence also. Ambivalence ka matlab kya hai? Sometimes when you are not able to decide, you say, sir, I am being very ambivalent. What dress should I wear, red dress or white dress? I am being very ambivalent. So ambivalence ka matlab hai not able to decide. So there is a pen on the table and patient is staring on this pen for hours and hours, thinking in his mind, should I pick it up or not? So ये क्या है? Ambivalence. I hope this is clear to everyone. So please be very careful. When you see the terms in the question, then you are able to identify. So please be very careful. Let's now talk about the diagnosis of schizophrenia. So diagnosis of schizophrenia we discussed with this name of the movie Dhadkan. So don't worry if you have not watched the movie. In the movie nobody was having schizophrenia, but from the name of the movie we can remember the symptoms of schizophrenia. So D for remember delusion. Which delusion? Any delusion. But most common delusion kaun sa hai? Delusion of persecution. HA is hallucination, but again which hallucination? Any hallucination. But most common hallucination kaun sa hoga schizophrenia mein? Remember auditory hallucination. D for remember disorganized speech. Beta disorganized speech ya disorganized thinking, all those formal thought disorders can be seen. Then K you can remember with C catatonic symptoms, and N for remember negative symptoms. I hope this is clear now. Please remember the sequence also, and these are the 5 symptoms of schizophrenia as per DSM-5. Let's discuss the remaining 2 symptoms. So beta, what are negative symptoms? So let's discuss some of the negative symptoms. First is anhedonia. Anhedonia in fact can also occur in depression. It can also occur in schizophrenia. Anhedonia का मतलब है decrease interest. पेशेंट का इंटरेस्ट कम हो जाता है, जिन चीज़ों में पहले उसको इंटरेस्ट प्लेजर आता था, दैट इंटरेस्ट हैज रिड्यूस्ड. ए वॉल्यूशन. बेटा वॉल्यूशन मीन्स विल पावर. So there is a decrease in willpower, decrease in motivation. Patient is just lying down on the bed throughout the day, not showing any will. Next is alogia. बेटा logia, neologism means logia मतलब word, alogia मतलब patient is speaking very less, decrease in speech. Next is affective flattening. We have already discussed na, flat affect. So there is decrease in expression. And last is remember asociality. Remember it is not antisocial. Asocial means less social. So there is decrease in the socialization. We have already covered this point now that affective flattening is a negative symptom of schizophrenia. But why we are calling them as negative symptoms? Because can I say everything is getting minus na? सब कुछ reduce हो रहा है, negative हो रहा है. So these are the negative symptoms of schizophrenia. What are the positive or psychotic symptoms? These are the positive or the psychotic symptom which we have covered. Now let's talk about the catatonic symptom, then I'll come back to this criteria. So let's see this question now. A 25-year-old male with a history of psychosis is brought to emergency department. He is mute, he is immobile, exhibits waxy flexibility. Patient presents with the presentation shown in the image below. So there is an image also. Can you appreciate patient is maintaining such abnormal posture? He has not eaten, drunk water for 24 hours. Vital signs although are stable. Most appropriate first line medical management क्या होगी इस patient को? So can I say the patient is having catatonia? So catatonic symptoms I say when the patient is having 3 or more of the catatonic symptoms. So patient is mute, there is mutism. Patient is immobile, patient is not moving. Waxy flexibility. But what is waxy flexibility? Bending like a wax candle. So suppose when I am trying to bend this wax candle, there will be initial resistance. After that I can bend the way I want. So that is waxy flexibility. Remember there is initial resistance. Very good. I am very happy all of you are answering correctly. But can you tell me patient is maintaining such abnormal posture? So either it could be catalepsy or cataplexy. Tell me, is it catalepsy or cataplexy? Remember, it is catalepsy or it can be posturing. Posturing. Remember, cataplexy is seen in narcolepsy. तो कैसे याद करोगे? Narcolepsy में catalepsy नहीं मिलता, उल्टा मिलता cataplexy. So catalepsy and posturing means patient is having some abnormal posture. दोनों में difference क्या है बेटा? Catalepsy is a passive phenomena. Suppose somebody else made the patient get into this posture, but अब patient maintain कर रहा है, तो ये हो गया catalepsy. Posturing means active phenomena. Patient himself came into this posture, अब उसको maintain करके रख रहा है. So this could be posturing. So if they tell you that patient himself came into this posture, then I am thinking of posturing. So we have identified patient को catatonia है बेटा. What is the first line treatment of catatonia? Remember, it is lorazepam. So the first line treatment of catatonia is lorazepam. It can be given IV or it can also be given IM or even oral. And if they ask you what is the best treatment, lorazepam is not working, benzodiazepine like lorazepam is not working, then we can go ahead with ECT. But first line management क्या होगा? That will be lorazepam. I hope this is clear to everyone. There are so many other catatonic symptoms. For example, echo. We have already discussed beta. Echolalia means he is repeating the words echo. Praxia. Praxia means movement. Whatever movement you are doing, like you are writing something with a pen and paper, patient के पास ना pen है ना paper है, but patient may also start having these movement. So that is echopraxia. He may copy the movements. So these are some of the catatonic symptoms, and the first line treatment very good is lorazepam. So let's now come back to the diagnosis. To make the diagnosis of schizophrenia, beta, out of these 5, 2 or more symptoms should be present, but there is a catch. At least one symptom should be present out of the first 3. पहले 3 में से एक symptom होना चाहिए, and total at least 2 or more symptoms should be there. According to DSM-5, the total duration of disturbance should be 6 months. And what is the duration criteria beta? According to ICD-11, it is 1 month. So please remember this. If nothing is mentioned, you can go ahead with DSM-5. और अगर symptoms is less than this duration, then क्या diagnosis बनाओगे? Then diagnosis would be acute psychosis. I hope this is clear to everyone. You can make the diagnosis of schizophrenia beta, very important. Let's now discuss this very important topic. See, a lot of question from psychiatry beta, they are coming from psychopharmacology. And this is one of the potential question which they ask again and again. So please be very careful. Don't make any mistake in solving these questions. A 40-year-old male with schizophrenia, बेटा देखो history में schizophrenia दिया हुआ है, there is a psychotic illness. He is on haloperidol. So haloperidol, we know it is a first generation antipsychotic for 5 days. He is brought to the emergency department with high fever, generalized rigidity, altered sensorium. On examination, there is diaphoresis, he is sweating a lot, pulse is 120 per minute, BP is fluctuating, reflexes are normal, creatinine kinase levels are markedly elevated. What you are suspecting and what is the next level of step of management? देखो, a lot of the time you will see there are 2 layered questions. 2 layered means first they will ask you, you have to in your mind have to make a diagnosis, and then the next question would be what is the management. So a lot of times beta, first try to identify the condition. Very good, all of you are answering it correctly beta. It is what? It is NMS, very good. Stop haloperidol, you have to stop the antipsychotic and start dantrolene. बेटा अगर ये दोनों अलग अलग होते, सपोज ये दोनों अलग अलग ऑप्शन होता कि स्टॉप हैलोपेरिडोल वन ऑप्शन है और स्टार्ट डैंट्रोलिन अलग ऑप्शन है, तो क्या आंसर मार्क करते? देन यू वुड हैव प्रेफर्ड स्टॉपिंग हैलोपेरिडोल. दिस इज वेरी गुड. दिस इज NMS, न्यूरोलेप्टिक मैलिग्नेंट सिंड्रोम. इनफैक्ट लेट्स डिस्कस दिस table of EPS. EPS is a very important topic, and we have remembered the EPS with the mnemonic DP at night. In the medical colleges there is dance party at night. So D for dystonia, there is contraction of a group of muscle, sudden contraction. In fact it is acute dystonia, but it is one of the earliest EPS. मतलब antipsychotic शुरू होने के within few minutes also this can occur. So there is a sudden contraction of a group of muscles. So patient may come like this in the emergency, that my eyes are deviated to one side. So there is oculogyric crisis, or the patient is not able to move the neck. The neck is twisted to one side. There is torticollis. Sometimes there may even be laryngospasm. So remember, patient may come to the emergency with a lot of distress. What is the drug of choice? But if I ask you, they may give you this clinical presentation, ask you the treatment. Remember, the drug of choice is anticholinergic drugs. We may in fact use parenteral drugs like promethazine, benztropine. So please remember, see, EPS is occurring because of D2 antagonism. D2 antagonism. See, the mechanism of action, one of the mechanism of antipsychotic is D2 antagonism. And if they cause D2 antagonism in other pathways like the nigrostriatal pathway, So that can cause EPS. So please remember this. So can I say these anticholinergic drugs, so these are muscarinic antagonist drugs? Beta, this question again was asked in the INI-CET exam. So can I say, देखो, I am saying that EPS like acute dystonia beta is occurring because of D2 antagonism in the nigrostriatal pathway. I want to block the D2 receptor in the mesolimbic pathway जो positive symptoms कर रहे हैं, but it can also block the dopamine in this tract beta nigrostriatal pathway and it is causing EPS. So can I say ये जो M1 antagonism ये drugs कर रही हैं, can I say in a way they are increasing dopamine in this tract ना? So this question was asked. So sometimes they will ask question on match the following, match the drug with the mechanism. So please be very careful. So remember this point. Next is P. Beta, P for Parkinsonism, pseudo Parkinsonism or drug induced Parkinsonism. A young patient on antipsychotic presents with tremors, rigidity, there is bradykinesia. So it is drug induced or pseudo Parkinsonism. Again the treatment would be, remember, anticholinergic drug. Here we can also use oral drugs like trihexyphenidyl. But sometimes in long term, so I am giving antipsychotic for a long duration. Please remember, patient may even have perioral tremors. So such vertical tremors like you see in rabbits, so that is known as rabbit syndrome. But please remember, rabbit syndrome is an example of drug induced Parkinsonism and not tardive dyskinesia. We will discuss tardive dyskinesia. वहाँ पे भी आप देखोगे perioral movements मिल रही हैं, but these perioral tremors which are occurring, that is drug induced Parkinsonism. So again the treatment would be anticholinergic drug. So you should know the difference because the treatment is also different. So this rabbit syndrome, it is drug induced Parkinsonism. DP at बेटा A से क्या, akathisia. Akathisia का मतलब क्या होता है, restlessness. Patient is very restless. In fact ये सबसे ज़्यादा common, most common EPS है. So they may give you this clinical picture that patient is on antipsychotics and patient comes to you and says, sir ma'am I am feeling very restless, मुझे अंदर से बड़ा restless, घबराहट फील हो रही है. And objectively जब आप पेशेंट को देख रहे हो, patient is not able to stay still, continuously is moving around, he is pacing in the ward, he is changing his foot again and again. So there is restlessness which is also seen objectively also. So this is akathisia. बेटा आपने diagnosis बनाया akathisia का. Tell me what is the drug of choice for akathisia. Remember it is beta blockers like propranolol. Very good. Next is at. बेटा T से है tardive. Tardive means after long term use of antipsychotic, patient may have some dyskinetic movement like lip smacking या chewing movement like this, or there may be tongue protrusion movement, or there may be coriform hand movements, piano playing like movement, or even pelvic thrusting can occur. So after patient on antipsychotic for months or years having such abnormal movement, then I am thinking of tardive dyskinesia. And what is the treatment? We use VMAT2 inhibitor. This question was recently asked in one of the exams. Valbenazine, deutetrabenazine. And last is N. N is neuroleptic malignant syndrome. Beta malignant का मतलब क्या है? Remember it is not benign, it is an emergency. It's a medical emergency. Very very important. So patient may come with high temperature, increase in the CPK level, muscle rigidity. Patient may have other symptoms like mentioned in the question, sweating, confusion, increased TLC count may occur. There may also be increase in the liver function test. So now I'm thinking of NMS. If they ask you about a first step in the management, please always be careful. The first step would be to stop antipsychotic. Drug of choice, if they ask you, it is dantrolene. Even dopamine agonists like amantadine, bromocriptine can also be used. So please be very careful. History of and dopamine antagonist is given like an antipsychotic in the question. Patient presents with such clinical picture, then think of which EPS they are asking and what is the treatment. So let's come back to this question, but I hope this is clear to everyone now. So remember the answer will be option B. Can anybody tell me another psychiatric emergency we give cyproheptadine? Can you tell me another psychopharmacology emergency में, which is that emergency I am talking about beta, where we may use drugs like cyproheptadine or serotonin antagonist? Can you tell me, because sometimes they will give you this confusing clinical picture ना, patient को fever है, rigidity है. So there is one important psychiatric emergency beta where you, हाँ, very good, serotonin syndrome, very good, serotonin syndrome. देखो as the name suggests, serotonin syndrome में they will give you a history of some serotonergic drugs like SSRIs या antidepressant. Many of the antidepressants they will give you in the history have been on the patient is on antidepressant and maybe on combination. or some drugs which are increasing serotonin levels. So patient may have serotonin syndrome, where we can use drugs like cyproheptadine. Please remember, in serotonin syndrome, usually you will see there is hyperreflexia, there is increase in the reflexes. They may give you in the question there is myoclonus, and also they may give you GI symptoms like there is diarrhea. Okay, all these points again, see the clinical picture, whether the patient is on antipsychotic, dopamine antagonist, or patient is on serotonergic drug. See the clinical picture, identify it, then go with the management. I hope this is clear to everyone na? Haan. So always be very careful. We'll also discuss kabhi lithium ki picture may also be very similar, but we'll discuss what are the important signs and symptoms of lithium toxicity. Wahan pe history mein they will give you patient is on lithium. So please try to see the clinical picture carefully. Now let's talk about some questions on antipsychotics. A 52-year-old obese male with type 2 diabetes presents with schizophrenia beta, primarily showing negative symptoms like social withdrawal, lack of motivation. Which antipsychotic medication is most appropriate choice for the treatment? We know we have first generation antipsychotic beta and second generation antipsychotic. Na? First generation we know they are D2 antagonist, while second generation we know they are D2 and 5-HT2. रिमेंबर दोनों 2 हैं बट इट इज 2A, A से याद रखो एटिपिकल या सेकेंड जनरेशन एंटागोनिस्ट. एंड वी ऑल्सो हैव लर्न दिस पॉइंट बेटा दैट द first generation they are more useful for positive symptoms, while second generation they are useful both for positive and negative symptom. So can I say, so we can say that haloperidol and chlorpromazine may not be of much use, they are first generation antipsychotic. अब मुझे बताओ aripiprazole, olanzapine में से कौन सी drug use करोगे? Very interesting. Sometimes, so we usually say that if nothing is given, then you can prefer second generation over first generation. We know first generation has more risk of EPS is more, while second generation has less risk. Also we know metabolic, बेटा metabolic side effects कहाँ पे ज़्यादा होते हैं? Metabolic side effects are more with first generation या second generation. They are usually more with second generation and usually less with first generation, but there are some exceptions which I will discuss. तो देखो, we have ruled out C and D, and out of A and B, which drug will you use? Very good. We know olanzapine is one of the drugs notorious to cause weight gain as a side effect. So here in the question, beta, aripiprazole is one of the second generation antipsychotic which has low risk of weight gain. We will talk about all those points. So I hope this point is clear. Na? Sometimes simple points like patient is obese, patient has type 2 diabetes, these are pointing towards that you will use drugs which have less side effects of metabolic syndrome. So let's talk about some of these drugs. So in the typical or the first generation antipsychotic, but the first drug is haloperidol. Remember, haloperidol has maximum EPS. Another drug is chlorpromazine. See, chlorpromazine is also first generation, so it is also D2 antagonist, but it also blocks muscarinic receptors, alpha receptor and H receptor. What are H receptor? Histaminic receptors. In fact, this question was asked in INI-CET before, that chlorpromazine blocks D2, M1, alpha, H all. It blocks all. मैकेनिज्म ऑफ एक्शन D2 ब्लॉकेज से होते हैं, बाकी सारे क्या कॉज करेंगे बेटा? साइड इफेक्ट्स करेंगे. सो एंटी कोलिनर्जिक साइड इफेक्ट्स विल अकर इफ द कोलिनर्जिक रिसेप्टर्स आर ब्लॉक्ड. अल्फा रिसेप्टर ब्लॉक हो गए, पेशेंट में प्रेजेंट विद हाइपोटेंशन. एच रिसेप्टर बेटा अगर ब्लॉक हो गए, पेशेंट में प्रेजेंट विद सिडेशन एज अ साइड इफेक्ट. ऑल्सो रिमेंबर वेट गेन. सी, chlorpromazine is a first generation antipsychotic, but it also has a moderate risk of weight gain. Another potential MCQ beta, this can be combined with ophthalmology. So there may be a ophthalmology psychiatry integrated question. A patient comes with problem in vision and there are some deposits on the cornea and on the lens. Which drug the patient is on? So remember C for chlorpromazine, they may also give you this image. So remember C for corneal and even lenticular deposits. So posterior cornea or anterior lens pe there may be deposits with chlorpromazine. Let's discuss one more drug beta, thioridazine. Remember thioridazine में R आ रहा है ना, so remember it can also cause a ocular side effect, that is retinal pigmentation. One more R, remember, rise, increase in the QT interval. See, we have discussed that maximum EPS किस drug का होता है बेटा first generation में? haloperidol का. Which drug has least EPS in first generation? Remember, it is thioridazine. Again, thioridazine is also a drug which has been asked in the exam, so please be very careful. Let's now talk about the atypical or the second generation antipsychotic. One is olanzapine. Beta O is olanzapine. Remember, O say obesity. One of the important side effect is weight gain. In fact, there are two drugs which have high risk of weight gain. One is clozapine, which I'll discuss, and another is olanzapine. If they ask you one, then you can choose clozapine. Next is risperidone. But usually we discuss that EPS is more with first generation than second generation. But out of the second generation, remember, risperidone is one of the drugs which has maximum EPS. Also, it can cause increase in the prolactin level. But antipsychotics can also cause hyperprolactinemia. And again, risperidone is one of the drugs because hyperprolactinemia is also occurring because of D2 blockage. Let's now discuss this very important drug, beta, that is aripiprazole. Important because for MCQs. See, normally we have discussed the mechanism of action of these antipsychotics, but aripiprazole ka, can anybody tell me, beta, what is the mechanism of action? It is a partial D2 agonist. Also remember, beta, A to Z. See, I'll give you a trick, beta, remember, at least remember these two drugs, A to Z. A for aripiprazole, Z for ziprasidone. They have low risk of weight gain. So if they ask you, beta, chlorpromazine जो कि फर्स्ट जनरेशन है और एरिपिप्राजोल जिप्रासिडोन वो सेकेंड जनरेशन है, इनमें से लो रिस्क ऑफ वेट गेन किसका होगा? रिमेंबर, एरिपिप्राजोल जिप्रासिडोन का. Also remember aripiprazole, this is a potential new question. It also has a low risk of hyperprolactinemia. But please remember this point also. So they may just give you a question in which a female presents to you in the OPD with galactorrhea, with amenorrhea. So there is galactorrhea, there is amenorrhea. Patient is on antipsychotic. So this can occur because of hyperprolactinemia. Which drug now we can use? So one of the drugs we can use is aripiprazole. Also remember ziprasidone का एक और point याद रखो बेटा, it also has a increase of QT interval as a side effect. I hope this is clear to everyone. So please try to see the clinical picture, see if they have mentioned any clues in the question, and then choose the drug. Let's now talk about another very important drug, that is clozapine. So you have seen many questions on clozapine beta recently in different exams. Clozapine is also a second generation antipsychotic. In fact, it blocks D4 more than D2. Usually जो EPS होता है that occurs because of D2 blockage. So remember, in the second generation, clozapine is one of the drugs which has low EPS risk. Now when do we use clozapine? बेटा clozapine को क्या हम किसी भी patient में दे सकते हैं? नहीं. Remember, clozapine is used for treatment resistant schizophrenia. मतलब कि if there is no response to at least 2 antipsychotics, then I am thinking of clozapine. So clozapine, I can say it is one of the most effective antipsychotics, but I am not using it as the first option. When the patient is not showing response or is having treatment resistant schizophrenia, then I am using clozapine. क्यों? ऐसा हम क्यों कर रहे हैं बेटा? Because clozapine has some serious side effects which I will discuss. Also remember beta, clozapine is one of the antipsychotics which have anti-suicidal property. Again, nowadays questions are asked on which of the following drugs have anti-suicidal property. So one of the drugs in antipsychotic category कौन सा beta remember is clozapine. In the end I will give you that list also. So let's first talk about the most common side effect. One of the most common side effect is beta sedation. Patient can also develop cialorrhea. There is hypersalivation. They may just ask you this question कि patient clozapine पर है, उसको hypersalivation हो रहा है. When he wakes up in the morning, पूरा जो pillow है वो wet है. This occurs because of decrease in the swallowing beta. Rather than starting any drug first, what one practical method you can use, just tell the patient to put a towel over the pillow. Okay, one of the reasons is he's getting embarrassed, the pillow is all wet because of this hypersalivation. So one practical method is you can ask him to put a towel over the pillow. Then some other side effect like hypotension can occur, weight gain we have already discussed. Even remember C for clozapine, C for constipation can occur because it also has anticholinergic property or side effects. Let's now talk about some serious side effect. Very important topic, very good. The trick is SAM. I am very happy you remember this trick SAM. One is seizures. Patient on clozapine can develop seizure. बेटा इसमें treat कैसे करोगे? Give anti-epileptic drug, then again you can restart clozapine. Agranulocytosis, very important. So देखो clinical picture में क्या दिया होगा? Patient on clozapine comes to you with fever, sore throat, tachycardia. So I am suspecting infection. Infection could occur because of decrease of WBC or ANC. So what next step you will do? You will check the counts. You will check these WBC, ANC. If the levels are reduced, then you have to stop the drug. In fact, this is such a serious side effect beta. When we are giving patient clozapine, we have to monitor for the first 6 months. Every week we have to check the counts. Then for the next 6 months, every 2 weeks. And उसके बाद जब तक the patient is on clozapine, we have to check it after every month. M for myocarditis. But a patient is on clozapine, comes to you with there is chest pain, there is tachycardia, there is abnormal ECG. Then you are thinking of myocarditis. Again, we have to stop clozapine. So remember these clinical pictures, patient on clozapine, try to identify what side effect they are talking about. Also let's discuss bit of an FQ which we discussed. This may come sooner or later in the exams. Patient is on clozapine, patient ko ho gaya seizure. Tell me one important anti-epileptic drug you will not give is contraindicated with clozapine. Can you tell me beta C for clozapine, C for contraindicated, remember carbamazepine, because we know in pharma we read that carbamazepine can cause bone marrow suppression. Beta ye bhi counts kam karega, clozapine is also reducing the count. Don't give a patient a drug which also is decreasing a count when he is on clozapine because it's a lethal combination. I hope this is clear to everyone now. Very good. Let's now discuss this question. A patient with diagnosis of schizophrenia was started on risperidone. बेटा risperidone क्या है, आइडेंटिफाई करो, ये है सेकेंड जनरेशन एंटीसाइकोटिक. तो क्वेश्चन में हमेशा ट्राई टू आइडेंटिफाई द कैटेगरी ऑफ ड्रग देर आस्किंग. पेशेंट्स को स्किजोफ्रेनिया है, दे हैव गिवन सेकेंड जनरेशन एंटीसाइकोटिक, improved symptoms on 3 milligram per day, but patient refuses to take medication and there was a relapse of symptoms. Sometimes because we know medication have to be given for a longer duration, patient may have developed some side effects, so patient is refusing to take the treatment. But what will be the next step in the management? Very good. देखो, we cannot stop antipsychotic because we know first episode में for how long you have to give antipsychotic after improvement, after patient has subsided, the symptoms have subsided, we have to give the treatment for at least 1 to 2 years. और second episode या उससे ज़्यादा में we may have to give it for 5 years or maybe indefinite for a longer duration. तो I cannot stop antipsychotic, patient को तो symptoms हैं. But a CBT will not be able to manage the symptoms of schizophrenia. Yes, we can use CBT when the symptoms of schizophrenia manage to manage some of the other symptoms. Syrup में again patient orally नहीं ले रहा ना. So then we have depot antipsychotics or long acting injectable antipsychotics. ये intramuscular injection है बेटा. In the PDF ना I will also share a list of some drugs which we have remembered with the mnemonic na Fiziparo. कुछ first generation और second generation की drugs हैं. So I will share that list also, but remember some of the antipsychotics they can be given through IM injectable. And can you tell me which technique we use? What is the technique? So I'll give you this list now. I'll just show this list. So we have some of these drugs. So some of the drugs of first generation antipsychotic, remember ये ना oil based preparation होती हैं. So we first have to give a test dose. While जो second generation है they are aqueous based, so no test dose is required. So please remember this point also. So some of these drugs with the mnemonic Fizi, PH and Paro. So these are the drugs which are available. Very good. जो technique हम देते हैं to prevent the leakage is Z-track technique. बेटा sometimes suppose patient is very agitated, आपने IM injection देना था and suddenly the drug actually has entered the blood circulation. So there will be drastic effects would be there because I want the drug to be released slowly from the IM site. But sometimes suppose the patient, the drug has entered the blood, so patient may even develop post injection syndrome, delirium, sedation can occur. So when we are giving these drugs, we have to keep the patient for few hours under observation, then we ask the patient to go. So please remember this. Usually patient having poor compliance, but a patient oral medication nahi le raha, so I can use these depot preparation. So in an indirect way or direct way, question may be asked about these depot antipsychotics. So please be very careful. Let's discuss now some questions. So we have discussed some important points about the psychotic disorders, especially schizophrenia. Let's now talk about mood disorders. Again in mood disorders, questions on specifiers and questions on the antidepressants and mood stabilizer have been asked again and again. So please be very careful, especially बेटा specifiers पे ना बहुत questions आ रहे हैं. So let's try to discuss some of the specifiers first. Beta, all of us know how to make a diagnosis of, I hope all of us know how to make a diagnosis of depression. Can you tell me in the chat box what is the mnemonic we use to make a diagnosis of depression? Can you tell me beta what is the mnemonic we use to make a diagnosis of depression? The mnemonic is SIGE CAPS, right? CAPS with double S. And what is the duration of symptoms? So depression, remember mood disorder है ना, तो key feature, one of the key feature is sad mood. The mood is low and I is decreased interest and some of the other symptoms may be present. And the symptoms should be present बेटा for at least 2 weeks. देखो point याद रखना है कि mood disorder में abnormality of mood is the key point, very very important. So patient का mood abnormal है, along with that patient is having other symptoms. So a female was brought to psychiatrist 3 weeks after her delivery. She is appearing sad, irritable, decreased interest and having suicidal thoughts. Which of the following beta is incorrect about her condition? You have to tell me, देखो incorrect. Sometimes you may know some data, समटाइम्स यू मे नॉट नो सम डाटा, बट स्पेशली INI-CET में आप देखोगे ना कुछ ऑप्शंस में ना डाटा दिया होगा. So that is why deliberately I am giving these questions so that you are able to cope up with these questions. In fact, let's discuss first this table. So let's in fact talk about, so one specifier which we are discussing is beta postpartum depression, but let's discuss all these abnormalities which can occur or related with pregnancy and delivery and psychiatry. So first is postpartum blues. Beta blues का मतलब क्या है? In the movies when somebody has a breakup, in the background there is a song, feeling blue, feeling blue. So blue means sadness. See, it can be seen in up to 80% of the females after the delivery. Onset usually occur within few days after the delivery, and the symptoms may last for days to weeks. So they are transient and mild mood symptoms like sadness, tearfulness, and also other symptoms like decreased sleep. But transient का मतलब क्या है? The symptoms usually they have a spontaneous recovery. So within few days or weeks the symptom would improve. So remember, there is no specific treatment required, no treatment is required, only supportive care. So patient को within few days of delivery mild symptoms हो रहे हैं, then you are thinking of postpartum blues. Depression का मतलब patient has now developed depression. Again, see, it is seen in 10 to 15% of the females during pregnancy or within 6 weeks of delivery. Beta DSM-5 says 4 weeks, ICD says 6 weeks, so I have taken 6 weeks. After delivery patient को depression हो गया. बेटा हाउ वुड यू डिफरेंशिएट ब्लूज फ्रॉम डिप्रेशन बेस्ड ऑन द सिम्टम? बेटा क्वेश्चन में दिया हुआ है कि पेशेंट को सुसाइडल थॉट्स हो रहे हैं, या पेशेंट को एक्सेसिव गिल्ट हो रहा है, या पेशेंट को एनिडोनिया है. सो दिस इज अगेन टेलिंग यू इट इज नो लॉन्गर ब्लूज, नाउ इट इज postpartum depression. Would you treat postpartum depression? Yes. So in the management beta we will discuss, one is we have drugs like SSRIs, and in therapy we have CBT. Also there are some new drugs which are approved for postpartum depression specifically. These are, remember, these are GABA A modulators. Also remember the name. So I am discussing some relatively newer drugs which they may ask. One is brexanolone, beta दोनों nolone है, and zuranolone. Brexanolone is a IV drug while zuranolone is a oral drug. So please remember this, very good. So they've asked question on blues, they've asked question on postpartum depression. Let's also discuss postpartum psychosis. See, this is even less prevalent, 1 to 2 per 1000 childbirths. Here patient may have symptoms, some vague symptoms like irritability, sleep problem. Within few weeks of delivery, patient may initially have these vague symptoms, but psychotic symptoms would develop now, delusions and hallucination, which may be related with the baby. For example, the patient says this baby is not mine, or I have not delivered any baby. So delusions towards the baby, or may say that I am hearing voices telling me to kill the baby. So there may be hallucinations also. So this is postpartum psychosis. But remember here, lithium has shown good results. It's a mood stabilizer, and also antipsychotics can be used. I hope this is clear to everyone now. This is a very important table. Please be very careful. So let's come back to this question. So here, can you first tell me the diagnosis? What is the diagnosis? If you are able to make the diagnosis, the answer would become very simple. So can I say, beta, patient within 3 weeks of delivery, patient has developed such symptoms, suicidal thoughts are there, decreased interest. So this is postpartum depression. Even if you don't know other options, you have to tell me the incorrect statement. Na? So we know it is not postpartum blues, it is postpartum depression. Yes, it is seen in 10 to 15% of the women, strongly associated with, yes, sometimes you will see family history में mood disorder है. Also in the, when the patient has postpartum depression, it may increase the risk of bipolar disorder. So this female has a higher risk of developing mania or hypomania in the future. So it may be turned to bipolar disorder. I hope this is clear na? So answer is, incorrect statement is option D. Let's discuss the next question. A 25-year-old female presented to the OPD with symptoms present since adolescence. She complains of low mood, lethargy, sleep disturbances. She reports of pushing herself every day to go to work. She has completed her graduation and now she is working as an assistant manager in a multinational company. You have to tell me the likely diagnosis. Can I say here, now can you tell me, has there anything mentioned about the duration in the question? Beta, please remember this point that in psychiatric question, a duration is a keyword. I change the duration, the diagnosis would change. So tell me, sometimes they may just directly tell you the duration, or sometimes in an indirect way they will tell you the duration. So can you appreciate, beta, she is a 25-year-old female and symptoms are present since adolescence. So symptoms are present for a long duration. So mild depressive symptoms present for a long duration. देखो mild हैं symptoms. Also can you appreciate, देखो functional impairment, beta, how you can say these are milder symptoms. Functional impairment ज़्यादा है या कम है? So in the question they're telling you, despite the symptoms, she is able to complete the graduation, working in the company, she is able to push herself. So can I say functional impairment कम हो रही है? So this is a classical case of dysthymia, very important. So dysthymia, patient has mild depressive symptoms and the symptoms are not enough to make a diagnosis of a depressive episode. And duration is 2 years in adults, and in children we say it is 1 year. And since symptoms are mild, beta, functional impairment is not severe. Like in this diagram, see this. Suppose ये 2 years की duration है. Yes beta, it would be helpful even for other examinees also. Yes, in fact, you know, these questions have been asked in different exams. So can I say if this patient touches this line, beta, he is qualifying for an episode of depression. So can I say beta patient को mild symptoms है but present for a long duration, इसे कहते हैं हम dysthymia. So remember, in fact, dysthymia in DSM-5 is now known as persistent depressive disorder. So एक correct name दिया है ना, it's a depressive disorder present for a longer duration. What is double depression beta? If it is asked, what is double depression ना? डबल डिप्रेशन का मतलब है सपोज दिस पेशेंट जिसको डिस्थाइमिया था अब इवेंचुअली उसको एक डिप्रेसिव एपिसोड भी हो गया, तो इस कॉम्बिनेशन को हम कहते हैं डबल डिप्रेशन. देखो अगर मैं आपसे पूछूं ट्रीटमेंट, सी नॉर्मली वी टॉक अबाउट द ट्रीटमेंट ऑफ डिप्रेशन, वी से एंटी डिप्रेसेंट्स प्लस माइनस CBT व्हिच इज थेरेपी. बट अगर माइल्ड सिम्टम्स होते हैं देन वी चूज CBT, सो यू कैन यूज CBT एंड ऑल्सो इफ रिक्वायर्ड SSRIs may also be given. Okay, so this is about dysthymia. So I hope this is clear to everyone now beta. Such questions may be asked in the exam. Now let's talk about the other specifiers which have been mentioned. See, what is recurrent depressive disorder? Recurrent का मतलब क्या है? If there are 2 or more episodes of depression. बेटा suppose patient को एक बार episode हुआ तो diagnosis हम बनाएंगे major depressive disorder, है ना. अगर patient को let us say दूसरी बार episode हुआ then the diagnosis would be recurrent depressive disorder. And remember बीच में patient should be normal for at least more than 2 months, then only I will consider this as a new episode. I hope this is clear to everyone now. So then we call it as recurrent depressive disorder. Let's discuss but a few more specifiers. Nowadays you will see many questions but have been asked on these specifiers. So let's discuss few more specifier. One is melancholic depression. देखो melancholic depression, in fact remember it is a more severe form of depression. And how to remember? Just see the name melancholic. See, so we will see in melancholic depression, M से melancholic depression में you will see a lot of E's and a lot of L's. There is loss of pleasure to all the activities. बेटा patient को सारी activities में जो pleasure था वो loss हो गया. Loss of reactivity to all the pleasurable stimuli. So this is again hinting towards more severe depression. A lot of E's you will see. Patient is having empty mood, बड़ा severe sad mood है patient का. There is profound despondency. Early morning awakening, बेटा patient says कि I wake up 2 hours before my normal time. Also मेरा जो mood है worse in the morning होता है. Patient is having excessive guilt, eating less, there is weight loss. So all these points are suggesting towards melancholic depression. But remember in depression there is increased risk of suicide, especially in melancholic depression the risk of suicide may be increased. Next is atypical depression. बेटा देखो atypical depression, the name is telling us that the symptoms are what is not typically seen with depression. So उससे थोड़े हटके हैं, atypical है. And the mnemonic is my will high. Normally depression में अगर मैं पूछूं will कैसी होती है, you will say it is low. So ये atypical depression है, so I made this mnemonic my will high. So what is M? M is mood reactivity. Normally patient with depression goes in a party, he will still feel sad. But यहाँ पे क्या हो रहा है, atypical depression में the mood brightens in a positive response. So for some time the patient mood will brighten up. W, देखो normally we know depression में weight loss होता है, appetite कम होती है, it can also increase, but ये atypical है तो यहाँ पे there is more of weight gain. H for hypersomnia. बेटा normally depression में there is insomnia, hypersomnia in some cases, but here it is atypical, so there is hypersomnia. I is interpersonal rejection sensitivity. Patient is very sensitive to rejection. A friend did not picked up the call, तो patient में से अरे I think he does not want to be my friend anymore. तो patient is having interpersonal rejection sensitivity. There is laden paralysis. Patient says that my arms, मेरे जो limbs हैं, they appear very heavy. I am not able to move. So there is laden paralysis. So this is atypical depression. Beta in atypical depression, drugs like SSRIs, SNRI, and drugs like MAO inhibitors can be used. Remember, TCAs have not shown good results in atypical depression. This is also a previous AIMS question. Lastly, let's also talk about beta seasonal pattern. Seasonal pattern में क्या हो रहा है? Patient is having depression in a particular time of the year. So patient says, let us say patient को depression बार in winters हो रही है. So then this is seasonal pattern or depression with seasonal pattern. But please remember this, if somewhere in the question they tell you कि patient को उस season में एक stressor भी present है, like हर बार winter में he becomes unemployed, बेटा अगर कोई stressor दिया हुआ है ना, then it will not be seasonal pattern. Then you will say that maybe it is because of the stressor and not because of the change of season. Also remember, beta in seasonal pattern, light therapy has shown good results. We make the patient sit in front of a source of light few hours every day. So this is seasonal pattern. So please be very careful. हाँ अगर stressor दिया तो बार बार हो रहा है, very good. The answer would be recurrent depression and not seasonal pattern. Very good. So I hope this question is clear to everyone ना. So यहाँ पे answer है dysthymia. Let's now discuss this question. Again many questions on antidepressant. Please revise antidepressants carefully. Let's discuss few points about the antidepressants. 25-year-old female patient diagnosed with PCOS has been brought to the psychiatrist with complaint of low mood, decreased interest, lethargy, disturbed sleep and anxiety. The doctor is planning to start an antidepressant. Which of the following statement beta is incorrect? You have to tell me the incorrect statement. Beta this can be used even for FMG students also, yes. For other exam students also, yes. So I'll also discuss few more points in the end also, which have been asked especially in INI-CET also. Very good beta. Please remember, देखो SSRI, SNRIs we know they can cause sexual dysfunction, and also remember bupropion, which is a NDRI, very important drug. One of the side effects of bupropion we'll discuss is seizure, and even mirtazapine, they have less sexual side effects. So a patient on antidepressant develop sexual side effects, so we can use bupropion, mirtazapine, which have less risk of sexual side effects. HAM-D, I'll discuss in the end. I'll give you a slide with some of the scales we use for some disorders. HAM-D, Hamilton Rating Scale of Depression, is used for assessment of depression. But a paroxetine, see, usually SSRIs can be given in pregnancy, but remember, P for paroxetine, P for pregnancy, it is contraindicated because it is teratogenic, it can cause cardiovascular defect. Very good. So please remember, this is incorrect statement. So the answer is option C. See, this is a new update in Harrison, so this can come as a medicine or even a obs-gynae question, that when you are making a diagnosis of PCOS, when you are evaluating this patient, so now in the Harrison latest edition it says that you should also screen the patient for depression and anxiety during the making diagnosis and also in the follow-ups, because many times we see that patient may also have these symptoms with PCOS. So here the answer is, beta incorrect statement kya hai? It is paroxetine. Very good. Also remember one more point beta. Tell me bupropion, I am saying that one of the side effect of bupropion is seizure. Can you tell me, again an FQ, can you tell me some condition in which bupropion is contraindicated? So can you tell me B से bupropion, मतलब कोई condition जिसमें risk of seizure is there, in psychiatry you will not give bupropion. So can you tell me B से bupropion, B से one is bulimia nervosa. In bulimia nervosa we'll discuss, patient may do repeated vomiting, self-induced vomiting, so say electrolyte imbalance हो सकता है. Even in anorexia nervosa, beta patient is eating very less, so there can be electrolyte imbalance and risk of seizure may be increased. Very good. So please be very careful. We'll talk about all those points. So let's discuss now the next question. You have to tell me incorrect statement. See, you will see nowadays many questions on new drugs have been asked. So I have compiled some of these new drugs in this one slide only, and let's try to answer some questions. You have to tell me the incorrect statement. So already the answer I am sure we have already discussed na. Incorrect, so we definitely know zuranolone is a oral drug है ना, not a IV drug, which is used for postpartum depression. देखो ketamine is a anesthetic agent, it is a NMD antagonist, which is also being studied for depression. Remember ketamine and also its S enantiomer S ketamine, but they have rapid onset of action. Normally when we talk about antidepressants, we say they take time. In fact, this is a PYQ, beta INI-CET का भी recently asked question है, which of the following drug has rapid onset of action? One of the option was ketamine. And S-ketamine, in fact, it has been approved for treatment of treatment-resistant depression, and S-ketamine is available also as nasal spray. Also remember, we have talked about antipsychotic with anti-suicidal property, clozapine. Remember ketamine, S-ketamine, they have anti-suicidal property. This may come as a next question. In fact, S-ketamine has been approved for treatment of patient with depression with suicidal thoughts or suicidal risk. ऑल्सो रिमेंबर अनदर लेटेस्ट एंटीडिप्रेसेंट बेटा जेपीरोन. देखो जेपीरोन में लास्ट में 1 आ रहा है ना, सो रिमेंबर इट इज अ agonist, partial agonist of 5-HT1A. Okay, please remember this. Okay, so I have discussed some points about these newer drugs. Also remember when we are giving Gepiron, remember ECG. So just remember ECG. So we have to do repeated ECG. So just remember this trick, Gepiron mein ECG, because it can increase the QT interval. Okay, so please remember this point. Very good. I hope this is clear to everyone now. Please remember also in TCA beta, please remember in TCA toxicity we have discussed so many times, questions have been asked. Can you tell me? So we know TCA toxicity mein there can be CNS, CVS and ANS effects. So there can be coma, convulsion, confusion, increase in the QRS interval, there can be arrhythmias. Beta ANS mein very important hyperthermia and meiosis या midriasis. This question is asked again and again. Meiosis या midriasis? Remember midriasis can occur. Okay, and what is the treatment? Very good, sodium bicarbonate. Hemodialysis is useful or not much useful for TCA toxicity? Beta, please remember hemodialysis is not much of use in the management of TCA toxicity like amitriptyline toxicity because they have high volume of distribution. Okay, so this may also come as a new question. Very good. Let's now talk about this. So we've talked about some important points about depression. Let's now talk about bipolar disorder. A 30-year-old female is brought with symptoms of excessive talking, decreased sleep, over grooming, excessive spending for 2 weeks. On asking any question, the patient becomes irritable and angry. बेटा देखो यहाँ पे mood symptom भी mentioned है. There is no history of any previous psychiatric symptom. What is the likely diagnosis? देखो it is not cyclothymia ना. Cyclothymia we will when you talk about dysthymia, remember cyclothymia is a milder form of bipolar disorder जिसकी duration should be at least 2 years. यहाँ पे तो 2 weeks की duration है. Also it is not rapid cycling which I will discuss separately. अब आपको मुझे ये बताना है कि ये bipolar 1 है या bipolar 2 है. देखो when we talk about mania and hypomania, but let's talk about mania and hypomania. So when we talk about mania and hypomania, see the symptoms of mania we know they should occur for at least 1 week, and symptoms of hypomania the duration should be at least 4 days. So this we know duration, minimum duration should be this. And to remember the symptoms of mania we have used this trick na, me dig fast. Again remember mood either is very happy or the patient mood is irritable and energy levels are high. These 2 symptoms along with this 3 or more symptoms present for at least 1 week. Hypomania may be better, remember symptoms are similar to mania but not severe enough to call it as impairment, much impairment in functioning. Also remember in hypomania na, you will never get psychotic symptoms. Sometimes mania may patient may also develop delusions, hallucination, they can occur but hypomania में नहीं होगा. Also there will never be need of hospitalization. Also remember but a flight of ideas usually is not seen with hypomania, it is more associated with mania. So these are some points of differences. So these are the points of differences we have discussed about mania and hypomania. We know what is bipolar 1 disorder. बेटा अगर patient को एक episode of mania हो जाए तो हम उसे कहेंगे bipolar 1 disorder. Patient may also have depression, may also even have episodes of hypomania. जबकि bipolar 2 disorder we say patient has depression plus hypomania and no mania. Then उसको हम कहते हैं bipolar 2 disorder. Let's now come back to this question. Very good. बेटा आपको मुझे ये बताना है कि यहाँ पे patient को option B है या option C है. देखो if you are thinking about mania या hypomania ना, then you may not be able to answer this question because in this question they have not mentioned much differences or some points to differentiate between the two, but still you can make the diagnosis. देखो can I call it as bipolar 2 disorder? For bipolar 2 disorder बेटा क्या सिर्फ अगर मैं इसको hypomania consider करता हूँ, can I call it bipolar 2 disorder? नहीं, because in the history there should be an episode of depression, so this also is ruled out. So I am considering कि this is a manic episode, so patient is having bipolar 1 disorder with current episode mania. Please be very careful with such questions. Okay, I hope this is clear to everyone. And also remember beta in the management beta tell me what are the drugs in the management of mania, hypomania, what drugs we use. So we have three drugs. One is antipsychotic, another is lithium and one is valproate. But if nothing is mentioned now, then you will go with antipsychotic, especially second generation antipsychotics may be preferred. So antipsychotics are used If that is not given, antipsychotics are not given, then you can nowadays you can choose valproate, because valproate has a rapid onset of action. If nothing is mentioned out of lithium valproate, then you can go with valproate. But of course, if they have given you certain other hints, then you can choose the drug according to those hints. Like rapid cycling, I will discuss, valproate is drug one of the choice. Also now tell me beta pregnancy में कौन सा drug use करोगे? Very good. Can you tell me beta pregnancy में which drug will you use? पेशेंट प्रेग्नेंट है, पेशेंट को मेनिया हो गया, तीनों ऑप्शन में दिया, अगेन एंटीसाइकोटिक्स बेटा आर प्रेफर्ड. देन लिथियम, इफ एंटीसाइकोटिक इज नॉट गिवन इन द ऑप्शन, यू कैन स्टिल कंसीडर लिथियम. बट लिथियम का क्या होता है टेरेटोजेनिक इफेक्ट? दिस हैज बीन आस्क्ड सो मेनी टाइम्स. रिमेंबर एब्स्टीन एनोमली. ओके, एब्स्टीन एनोमली विच इज अ कार्डियोवैस्कुलर डिफेक्ट. ट्राई not to give or to avoid, अगर कोई ऑप्शन नहीं है then we may give, but try to avoid valproate because it can cause neural tube defect. All these teratogenic effect beta, these have been mentioned, these have been asked in the exam, so very good, please remember this point, very good. I hope this is clear to everyone. अच्छा, also remember this point beta, suppose अगर patient हमारे पास mania या hypomania में आया है और उससे पहले लेट अस से फॉर डिप्रेशन पेशेंट वाज ऑन एंटी डिप्रेसेंट, इस पेशेंट को बेटा अगर मैनेज करना होगा तो हमें मेनिक एपिसोड को मैनेज तो करना है. बट अगर आपसे पूछते हैं बेटा पहला स्टेप क्या होगा, कैन एनीबडी टेल मी स्टेप 1 क्या होगा? बिफोर स्टार्टिंग एनी ऑफ दीज ड्रग्स व्हाट वुड यू लाइक टू डू? बेटा पहला स्टेप होगा टू स्टॉप एंटी डिप्रेसेंट, बिकॉज एंटी डिप्रेसेंट क्या कर रही है बेटा, इट इज एलिवेटिंग द मूड इज ऑलरेडी टू मच एलिवेटेड. I hope this point is also clear to everyone. Very good. So please be very careful. Let's answer this question now. A 36-year-old woman, so I'm trying to just complicate this picture. This is a question, but again such type of two-layered question may be asked in the exam. So I have connected a lot of dots and framed this question. 36-year-old woman with bipolar disorder has been started on lithium for the past 2 years. Over the last 1 year, patient has 5 or more episodes alternating between depression, mania, hypomania. So beta isko kya kahenge? Can you tell me what is this known as? This is rapid cycling bipolar disorder na. Rapidly बार patient is cycling up and down na, rapid cycling bipolar disorder हो गया. She complains of fatigue, weight gain and cold intolerance. Appears sluggish also. Elevated TSH भी है. Which of the following is the most likely contributing factor to the rapid cycling? Very good. देखो, rapid cycling bipolar disorder, all of us know that if the patient is having 4 or more episodes in 1 year, है ना, तो patient has rapid cycling. We also know that rapid cycling has some risk factors, like it is more common in females than male. This has been asked previously in your exams. Also some of the other risk factors like hypothyroidism is there beta. Also other risk factors are there. For example, patient is using certain substances like alcohol, sedative, tranquilizers, and there are so many other risk factors. Also remember, in fact, it is more common in bipolar 2 than bipolar 1 disorder. Now can I say here, patient on lithium, we will discuss side effects of lithium beta. One of the side effects of lithium in endocrinal side effects is hypothyroidism. तो पेशेंट लिथियम ले रहा था, पेशेंट को हाइपोथायरॉयडिज्म हो गया, एंड वी नो हाइपोथायरॉयडिज्म कैन कॉज रैपिड साइक्लिंग. सो हियर यस, वन ऑफ द reasons could be lithium induced hypothyroidism. So indirectly they may just ask you that patient को on lithium develops rapid cycling bipolar disorder, what investigation would you like to do? So you would like to check the thyroid function test. So this is how also the question may be framed. So please be very careful, the dots may be connected like this. Okay, and tell me in the treatment of rapid cycling beta, this question has been asked in some other exam. Very good, it is valproate, which is one of the drugs which is used, and nowadays even lamotrigine. Very good, even lamotrigine is being used in the management of rapid cycling bipolar disorder. Very good. So here the answer is option B. Very good. Let's see this question now. So now let's talk about some neurotic disorders beta. Let's now talk about neurotic disorders, and in neurotic disorders the first disorder beta which we will cover, we will talk about the anxiety disorders. Okay, so let's now talk about the anxiety disorder. So answer this question. A patient is brought with symptoms of anxiety, palpitation, sweating, breathlessness, chest pain, feeling that she might have a heart attack, or there is a feeling of impending doom. Patient को ऐसे episodes हो रहे हैं, 5 to 6 episodes in a month, lasting for 30 minutes each, present for 6 months. What is the diagnosis? But classically patient is having panic attack, so this is panic disorder. So remember, when we talk about the anxiety disorders, we have divided them into 3 categories beta. One is panic disorder, जिसमें patient को suddenly episodes of anxiety, and very important is feeling of impending doom. Patient को लगता है ऐसा कि I am about to die. मुझे कुछ होने वाला है. And these episodes, remember, they are unexpected. अलग टाइम पे अलग अलग जगह पे they can occur. They may last for few minutes. So this is panic disorder. Then one is phobias. Beta phobias, or you can remember situational anxiety. Anxiety is occurring in particular situation. So 3 phobias beta, that is agoraphobia, specific phobia and social phobia. And one is generalized anxiety disorder. देखो यहाँ पे the anxiety is now generalized. It is persistent anxiety. It is now occurring in all small situation. Very important point for GAD beta remember is patient is having excessive worries. Patient को anxiety है of panic attack then panic disorder. Patient is having anxiety beta in particular situation then I'm thinking of phobias. And if patient has generalized anxiety, हर छोटी छोटी बातों पे patient को persistent worries हैं, excessive worries हैं, then I'm thinking of GAD. I hope you will be able to differentiate the three. Also remember all these anxiety disorders are more common in females than males, but there is one exception. बेटा कौन सी exception है? Remember social phobia. Social phobia is more common in males? No, it is in fact equally prevalent. Remember it is equally prevalent in males and females. So यहाँ पे answer है panic disorder. Let's now discuss this question. A 32-year-old woman presents with 1-year history of avoiding going outside alone. She reports intense anxiety in crowded places, in public transport or standing in queues. She fears she may suddenly develop palpitation, feel dizzy or lose control in public and no one would be able to help her. Because of this she now prefers staying home. You know, sometimes patient may become homebound. Can you appreciate because of this anxiety patient has become homebound unless accompanied by husband. So you have to tell me the diagnosis. Beta, what is the diagnosis? Very good. The diagnosis here is agoraphobia. Beta, we have learnt there are 5 situations now. For example, patient is while using public transport, in open spaces, in closed spaces, when patient is in crowd or standing in a line, or patient is out of the house alone. If patient is having anxiety between 2 or more of these situations, very important point. अगर 2 or more situation में होगा then you are thinking of agoraphobia. अगर suppose they just tell you that patient is having anxiety in a lift, then what would be the diagnosis बेटा? अगर सिर्फ एक situation में anxiety होगी then you are thinking of specific phobia. Please remember here, now I am thinking of agoraphobia. And remember treatment for agoraphobia, for specific phobia. देखो patient is having anxiety in a particular situation ना, so tell me therapy is useful या drugs are useful? Tell me therapy या drugs? हाँ, अगर एक सिचुएशन क्लोज सिचुएशन में हो रहा है देन यू आर थिंकिंग ऑफ स्पेसिफिक फोबिया. कौन सा? क्लॉस्ट्रोफोबिया. वेरी गुड बेटा. टेल मी इफ आई एम ट्रीटिंग दिस पेशेंट विद अगोराफोबिया या स्पेसिफिक फोबिया, रिमेंबर वी यूज बिहेवियर थेरेपी एंड स्पेशली वन इंपॉर्टेंट बिहेवियर थेरेपी दैट इज सिस्टमैटिक डिसेंसिटाइजेशन. फॉर सोशल फोबिया वेयर पेशेंट इज एंजाइटी इन सोशल सिचुएशंस, बेटा देयर वी कैन यूज थेरेपी दैट इज CBT. ओके, सो प्लीज रिमेंबर दिस पॉइंट. आई होप दिस इज क्लियर टू एवरीवन. हाँ, let's now discuss this question. A 28-year-old woman as working as data analyst reports to a psychiatrist for treatment. She reports that she has been given a promotion in her company but she is reluctant to take it as she requires frequent meetings with the staff and the company heads. But she gets anxious, has palpitation in such interactions and fears blurting out something irrational or may become totally blank. Beta, what is the likely diagnosis? Beta, can I say यहाँ पे पेशेंट को एंजाइटी हो रही है इन अ पर्टिकुलर सिचुएशन ना, सो कैन आई से पेशेंट इज हैविंग एंजाइटी इन अ सोशल सिचुएशन. सो दिस इज सोशल एंजाइटी डिसऑर्डर और सोशल फोबिया. वेरी गुड. सो प्लीज बी वेरी केयरफुल. यहाँ पे इट इज नॉट GAD. इन GAD में तो क्या होगा, हर सिचुएशन में पेशेंट इज एंशियस. ओके, स्मॉल सिचुएशन में डेली पेशेंट इज एंशियस persistently. Here patient is anxious only in social situation. Actual fear is not of this situation. Remember here in the question they mentioned it is fear what if I do something which will embarrass me in front of others. But actual fear क्या है? Fear of embarrassment. Okay, so this is social anxiety disorder. I hope this is clear to everyone. Now please be very careful. Such newer questions may also be framed. देखो question पढ़ के you may not be able to get to the answer sometimes. So see all the options. Try to rule out the option and get to the right answer. Let's now discuss this question. Again, this is an important topic. Nowadays you will see many questions. So in the neurotic disorders we have covered anxiety disorders. Let's now talk about trauma or stress related disorders. So the question is, a 30-year-old woman is brought by her family 1 week after being involved in a building collapse. She was physically unharmed but since the incident she appears emotionally numb and says she feels detached from reality. She has difficulty recalling parts of the event, avoid discussions about it, has poor sleep with irritability. You have to tell me the most likely diagnosis. Very good, but please remember, can I say it is a very serious trauma or stressor, and after this trauma, see, we have divided the trauma or stressor beta based on the severity. It could be a severe trauma like patient was kidnapped or patient had a serious accident, there was a war patient has experienced. It could be PTSD, post-traumatic stress disorder, या ASD. And how we differentiate? Beta, very good, we differentiate based on the duration. PTSD मतलब 1 month or more duration, ASD is less than 1 month. And we have discussed na with the mnemonic mahi wale symptoms na, especially so M is mood and cognitive symptoms can be there. Very important, patient now tries to avoid things related with the trauma. Patient can have hyperarousal symptoms जैसे poor concentration है, sleep problem, and again one more is eye intrusion symptom. Patient may have flashback, distressing dreams of that incident. So especially remember the AI wale symptom na. After a major trauma, they have given these MAHI wale symptoms, MAHI wale symptoms. Then I am thinking of these two categories. But in the treatment, we can use therapy like cognitive behavior therapy. So remember, अगर therapy of choice या treatment of choice पूछें, it is CBT. We can also use one more therapy, that is EMDR. That is eye movement desensitization and reprocessing therapy. But remember, therapy of choice is CBT. And also drugs like SSRIs can be used. But can you appreciate यहाँ पे patient has mood symptoms, patient has other symptoms, patient is now avoiding discussion. Okay, so patient is having avoidance symptoms after a serious trauma, duration is less than 1 month. So answer यहाँ पे क्या होगा बेटा? यहाँ पे होगा acute stress disorder. Okay, please remember this. I hope this is clear to everyone. देखो, what is this phenomena? Can anybody tell me? Detached from reality. But sometimes such symptoms can also occur. Patient may say that, sir, I feel that things around me are unreal. So there may be detachment from reality. इसको क्या कहते हैं बेटा? Derealization, है ना? Patient may also have detachment from self, depersonalization. Such symptoms may also occur. But see the entire picture, see the duration, then answer the questions. Okay, I hope this is clear na? हाँ. PTSD between 1 month or more. It would be 1 month or more. Then I am thinking of PTSD. Okay. Now let's come to this question. A 25-year-old software engineer visits a psychiatrist. He is suffering from low mood, decreased concentration and sleep problem due to stress in his current job for the past 3 months. He cannot work properly and having difficulty to balance family and work. He has no prior psychiatric history. What is the likely diagnosis? But tell me, very good. It is not generalized anxiety disorder because here anxiety is only related with the work. It is not ASD, it is not PTSD because those mahi wale symptoms are not there. Stressor is not very severe also. It is adjustment disorder. Very good. See, adjustment disorder when the stressor is mild or moderate stressors. Such stressors which we all also experience in a day-to-day life, like कोई medical illness हो गई, mild illness हो गई, या there is some financial issue. So patient may develop बेटा adjustment disorder. देखो नाम से ही पता चल रहा है, difficulty in adjusting to the new situation. Somebody has lost the job, somebody has shifted to a new place. So patient has mild behavioral emotional symptoms and we say it is diagnosis of exclusion. मतलब rule out other condition. If nothing is getting fulfilled, then I am thinking of adjustment disorder. Like in this scenario, but I am not able to see any of these diagnoses, so I am now thinking of adjustment disorder. There is also a stressor, there is stress in the current job. So this is adjustment disorder. Please be very careful. Just try to see. Similar question like dysthymia can also be asked. So always rule out the options and get to the right answer. Let's answer this question now. A female patient having reports to the psychiatrist with having a long history of checking ritual. She reports, for instance, that she has to check her car door multiple times and that has caused damage to the door handle despite that she is not able to stop it. She reports that because of this habit she has lost many jobs as she would reach office late and also has constrained relationship with her fiancé. She recognizes the irrational nature of her thoughts and the symptoms are worsening for the past few months. You have to tell me incorrect statement beta about this condition. Very good. So diagnosis क्या है यहाँ पे? I am very happy you made the diagnosis of OCD. So we know in OCD patient has obsessions beta and patient has compulsions. So some patient may have only obsessions, some patient may have only compulsions and many patients may have both obsessions and compulsions. Obsessions beta can be of various types and we know the different characteristic of obsession with the mnemonic ROSI. So patient has recurrent thoughts or images or impulses. So patient may say, sir, 2 hours, 4 hours every day these thoughts are occurring. Patient knows that these are his own thoughts वेरी इंपॉर्टेंट बेटा, प्लीज हाईलाइट, पेशेंट को पता है कि ये सेंसलेस हैं, गलत थॉट्स हैं, बट पेशेंट इज नॉट एबल टू रेजिस्ट देम, सो ये इररेजिस्टेबल है. एंड कंपल्शन का मतलब दीज आर रिपीटेटिव एक्ट्स. So patient may now start doing some acts. Remember, it could be motor acts. So patient may start washing hands, let us say, but they can also be even mental acts. बेटा mental acts का मतलब है patient अपने mind में भी हो सकता है कुछ acts कर रहा हो, मतलब he's counting something in his mind or he's chanting some mantra in his mind. So mental act भी हो सकता है जो आपको दिखाई ना दे, but mentally he's performing some act. We know there are different types of बेटा obsession. हाँ remember, और ये किसकी, वेरी गुड, दिस इज एबनॉर्मैलिटी ऑफ पोजेशन, वेरी गुड. सो दिस इन फैक्ट हैज बीन आस्क्ड इन योर INI-CET एग्जाम वंस. बेटा ऑल्सो रिमेंबर दिस टेबल, डिफरेंट टाइप्स ऑफ ऑब्सेशन एंड कंपल्शंस. मोस्ट कॉमन ऑब्सेशन कंटैमिनेशन है. सेकेंड मोस्ट कॉमन इज पैथोलॉजिकल डाउट, लाइक इन दिस केस ना, पेशेंट को बार बार डाउट आ रहा है कि मैंने डोर को, हैंडल को लॉक किया नहीं किया, लाइट को स्विच ऑफ किया नहीं किया. हाउसवाइफ कम्स आउट ऑफ द किचन एंड हैज डाउट्स that whether I've turned off the gas now. Patient says, sir, I remember I've done this because ये senseless है, मुझे याद है, but ये irrational thoughts बार बार आ रहे हैं. Patient is having obsession of symmetry, precision, सब कुछ symmetrical होना चाहिए. If the pen is like this, somebody has changed the direction, oh my god, symmetry is gone. Patient may have aggressive obsession, sir, मुझे बार बार thoughts आ रहे हैं to slap the person standing in front of me. No sir, I don't want to do this. I'm not that kind of a person. So this is aggressive obsession. But please remember sexual obsession. In fact, sexual OCD में patient may having thoughts of touching the opposite gender inappropriately. बेटा इसको paraphilia frotteurism. बेटा paraphilias is a very important topic. Please revise paraphilias. You will see many questions from paraphilias. See, frotteurism में T for दो T आ रहे हैं ना, यहाँ पे patient in frotteurism is touching the opposite gender inappropriately. फ्रॉट्यूरिज्म को और सेक्सुअल ओसीडी को कैसे डिफरेंशिएट करोगे बेटा, दिस में बी आस्क्ड इन द एग्जाम, वेरी गुड. इन फ्रॉट्यूरिज्म आल्सो पेशेंट में बी रबिंग और टचिंग द पर्सन इनअप्रोप्रिएटली. बेटा कैसे डिफरेंशिएट करोगे, वेरी गुड. देखो फ्रॉट्यूरिज्म ये एक पैराफीलिया है, वहां पे पेशेंट वांट्स टू डू दैट, पेशेंट को सेक्सुअल ग्रेटिफिकेशन मिल रहा है, बट यहाँ पे रिमेंबर पेशेंट को पता है कि सेंसलेस थॉट्स हैं. अगर पेशेंट को पता है इरेशनल थॉट्स हैं एंड इज ट्राइंग टू रेजिस्ट इट, देन यू आर थिंकिंग ऑफ सेक्सुअल ओसीडी. And multiple obsession मतलब patient can have a combination of these. In compulsion, one is checking, most common बेटा C से compulsion, C से checking है. Patient में है washing, patient में भी counting things, बेटा patient में having symmetry और precision, patient सब कुछ symmetrically कर रहा है. A 16-year-old female is cutting food in equal sizes, taking longer time to eat. तो ये क्या है, ये eating disorder नहीं है. This is what? This is OCD of symmetry and precision. And multiple का मतलब patient में भी doing, having a combination of these. बेटा most common obsession is contamination, most common compulsion is checking. अगर पूछते हैं most common pattern of OCD, then what you will say? Then you will say it is contamination and washing. Okay, so please remember all these are important MCQs. Okay, and they also can give you such clinical picture which I have tried to explain. So let's come back to this question. देखो again, let me say many of the times, especially in INI-CET, you will see these data. Lifetime prevalence of MDD in patient with OCD is 67%. In fact, we know that depression is the most common comorbidity with OCD. Even if you don't know this, let's see the other options. Incorrect statement बताना बेटा. Pathological doubt checking is the most common pattern. नहीं, this absolutely is wrong. We know this is a wrong statement. In the management beta, yes, SSRIs are the drug of choice. So one is we have drugs, and one more drug which we have is which TCA? Remember, it is clomipramine. So two drugs are approved for the management. So SSRIs and clomipramine, which is one of the TCAs. And also remember beta, risperidone, aripiprazole, they are also used, but as a augmenting agent. Okay, not as the primary drug. And in the management, also tell me, we also have therapy na. In therapy, we have CBT, especially remember ERP, exposure and response prevention. तो patient को हम expose करते हैं. This exposure can be a real exposure or even can be, so we are exposing the patient to stressful stimuli, like मैंने patient के सामने dirt रख दिया, or it can even be imaginal exposure. I am asking the patient to imagine the stimuli around and we are trying to prevent the response. So exposure and response prevention, that is the therapy of choice. And अगर आपसे पूछते हैं treatment of choice क्या होगा बेटा, remember it will be combination. Okay, so यहाँ पे correct answer क्या है? The correct answer is option B, which is the incorrect statement. Okay, now let's talk about this question. Miss K, a 25-year-old female, a 25-year-old present with bald patch on her scalp. She reports of having persistent urges to pull the hair, which initially was less, but now it has become more severe. At times she reports that it occurs even without her noticing. But now sometimes patient says automatically bhi ho raha hai while reading a book, watching a movie. She reports of feeling anxious when she tries to control it. So she is not able to control, she develops anxiety. What is the next step in the management? But first tell me the diagnosis. Then we'll talk about the management. Very good. All of you are marking correctly. Very good. So please remember, beta यहाँ पे diagnosis है trichotillomania or hair pulling disorder. Patient is having recurrent urges to pull the hair. Patient starts pulling the hair, causing a lot of distress. It can involve any area, but most common area कौन सा है बेटा? Scalp. देखो, in the management, one of the strategies is we can use CBT technique, which is habit reversal therapy, HRT. So we are trying to reverse this habit of pulling the hair. In drugs, remember, N-acetylcysteine is one of the drugs which is used in the adults. It's a glutaminergic modulator. SSRI may also be useful, but N-acetylcysteine is shown to have good results in the management. But sometimes patient may present with such complication, but such images can also be given. ये क्या है? Such mass of hair is taken out from the stomach. What is this known as? This is trichobezoar. Why? Because of trichophagy, because of trichotillomania. Many patients who pull the hair, they may just throw the hair, but some may even swallow, and that can lead to such complications. So patient may land up into emergency with such complication. There may be obstruction. So again, such question may be framed clinically. So please remember here the answer is, it is habit reversal therapy or HRT. I hope this is clear to everyone now. In fact, remember that both DSM-5 and ICD-11, they have now made this new diagnosis of obsessive, compulsive and related disorders. So they have combined certain disorders in this category together. One is OCD, another is BDD, body dysmorphic disorder. Patient को thoughts हैं बार बार, preoccupation है that there is something abnormal in her appearance, like my nose is large, my ears are large, ears are small. Hoarding disorder, patient is collecting things and not ready to discard them. Trichotillomania we have discussed, and also excoriation disorder, the patient may start even picking the skin. In DSM-5 we have discussed these are the 5 categories, but ICD-11 has also made a similar category. So one is OCD, BDD, hoarding disorder, but this question was asked in INI-CET before, it's a PYQ. So they have made one new category, body focused. So body भी focus करता हुआ repetitive behavior disorder. In this category, beta they have added trichotillomania and excoriation disorder. In fact, you can remember this new term which has been added, beta olfactory reference syndrome. नाम से ही पता चल रहा है. Patient has repeated thoughts or preoccupation that some bad smell is coming from the body. So olfactory reference to the reference of the patient. क्या patient को बेटा वो smell आ रही है? Yes or no? नहीं. Please remember, because अगर smell भी आ रही है तो that is olfactory hallucination. This is just a preoccupation, a thought. So this is olfactory reference syndrome, and also remember hypochondriasis, which we will discuss elsewhere. So these are some headings which have been added in ICD-11 in this category. I hope this is clear to everyone, but you will be able to make the diagnosis and answer such questions now. Let's now see this question. A 35-year-old woman feels her social media handle is being hacked. She finds pictures of herself with other people on the Instagram, appearing she is enjoying in those pictures, but doesn't remember any of those events and those people. Her husband also recollects that at times she behaves in a different way than usual, talks in a very different accent, as if she is completely different person, and doesn't appear to remember such instances later. Her brother also reports there is a child abuse history. Patient has no recollection of it, but tell me the diagnosis. Very good. Now we are entering the domain of dissociative disorder and somatoform and related disorders. But in disorders में क्या होगा? Patient has some physical or some bodily symptoms, but remember there is no bodily cause. Very very important. देखो आपको questions ऐसे मिलेंगे. Patient is having some symptoms, but there is no bodily cause. For example, patient is having pain abdomen. Patient is not able to move the hand. So how would you know that you are dealing with these disorders? देखो तो symptoms are not produced by the body, but symptoms are produced by the unconscious mind. Very good. Symptoms are produced by the unconscious mind. But how would you know in the question कि symptoms are produced by the unconscious mind? So somewhere in the question they will tell you that patient we are examining, everything is coming out to be normal. We have investigated, everything is coming out to be normal, and sometimes they may also give you some stressor, plus minus, like in this question they have given. But the important point is that there is so much stress To decrease the stress, the mind is converting the stress into these symptoms. So this is the important point to remember. So in the question they may tell you everything appears to be normal. So then you are thinking of these disorders. So here the answer is very good, dissociative identity disorder. Very good, yes, the movie which you have mentioned, yes, in this movie, yes. So dissociative identity disorder or multiple personality disorder. I am very happy you are able to correlate with the movies also, because many times you will see such phenomena. But अगर नहीं देखी movie तो अभी मत देखना, don't watch it now, watch it after the exam, okay. So here, as the name suggests, patient has two or more personalities which exist in one individual. All of us have one personality, but यहाँ पे patient has more than one identity in oneself, and one personality is evident at one time only. And usually the personality is not aware of the other personality. Like in this case, at one instance the person is behaving in a different personality, and another time there is a different personality. So this is dissociative identity disorder. Very, very important. Let's discuss some other dissociative disorder. Beta, one is dissociative amnesia. As the name suggests, patient has amnesia. Patient is not able to remember some personal event or information which is usually of traumatic event. Like patient was kidnapped. For 2 days patient was tortured. Beta, 2 दिन के बाद patient was rescued. Police asked what happened in those 2 days. Patient says, I don't remember anything. Patient remembers everything before that and after that, but he is not able to explain or not able to remember those 2 days. So it was so much stressful. To decrease the stress, the mind erase that or remove that memory. Of course, it is not permanent. With therapy, it may be brought back. So this is dissociative amnesia. No medical condition is able to justify this condition. Dissociative fugue, beta fugue का मतलब है wander. Stressful situation के बाद there is a sudden unexpected travel. Patient को financial loss हुआ. He lives in Delhi. He went to Chennai. He does not remember his past and may assume a new identity. This is dissociative fugue. And patient may even have depersonalization, derealization disorder. As the name suggests, D means detachment. So patient says, I am having recurrent feelings of detachment from self, and derealization, detachment from the real world or from the world around. So patient may say, as if, I feel as if I am in a dream, as if I am watching myself in a movie. So this is depersonalization, derealization disorder. I hope this is clear to everyone now. And treatment of all these disorder is therapy. Right, now let's discuss the next question. Mr. M, a 35-year-old man, is chronically preoccupied with health. For many years he feared that his irregular bowel functions meant he had cancer. He feels relieved for some time when the test results come negative, but then again he starts worrying beta. Now he is preoccupied about having a serious heart disease. His cardiologist is reassuring that these are just occasional heartbeats he detects, are completely benign, nothing to worry about. But he continuously searches for any signs of serious illness on internet. Can you tell me the diagnosis? Very good. Tell me the answer beta. देखो, in the somatoform and related disorder, one is somatization disorder or somatic symptom disorder, and another is illness anxiety disorder. This is a new term for hypochondriasis in DSM-5. Beta, somatization या somatic symptom disorder में ना patient is preoccupied with the symptoms, that I am having this symptom, I am having that symptom. Although he has been reassured by the doctor, but patient is still worried about the symptom. जबकि illness anxiety disorder में बेटा, as the name suggests, anxiety of having a serious illness. So here the patient is preoccupied of having a serious illness. Symptoms may be mentioned, may not be mentioned, but patient को लगता है मुझे गंभीर serious बीमारी हो गई है. If he is only worried about the symptoms, it is somatization. If he is worried of having a serious illness, then it is hypochondriasis or illness anxiety disorder. But I hope this is now clear to everyone now. It is not OCD, it is not somatization disorder, it is hypochondriasis or illness anxiety disorder. What is conversion disorder? देखो, conversion disorder DSM-5 में now it is known as functional neurological symptom disorder. Here the patient is having neurological symptoms which are functional, but that means they are not produced by the brain, they are produced by the mind. Remember, it is more common in females than male. This question has been asked. So many questions have been asked in your INI-CET exam about conversion disorder, even in other exams also. So patient may come to us with sensory symptom like hemianesthesia. Beta, we know person cannot have complete hemianesthesia. Anatomically, medically it is not possible. But patient aa jata hai emergency mein with this. So again, it is produced by the mind. Patient is reporting of blindness. Suddenly, after hearing the parents fight, 7-year-old girl, she says, I am not able to see anything. But examination mein sab kuch normal aa raha hai. So again, it could be conversion disorder. Or patient may have pseudo seizures. Patient is having abnormal jerky movement for half an hour, 1 hour. They are not true seizure, they are pseudo seizure. Also remember la bella indifference. बेटा what is the meaning of indifference ना? Indifference का मतलब है फर्क ना पड़ना. La bella indifference means careless attitude towards serious illness. Patient is not able to see anything, but patient is not concerned about this serious problem. Patient is sitting comfortably. So ये क्या है? La bella indifference, which can be seen in conversion disorder. So many exams they have asked this la bella indifference. I hope this is clear to everyone na? Very very important. Okay. Now let's talk about some MCQs. So we have talked about the topic of neurotic disorders. Let's now discuss some questions on child psychiatry. A 4-year-old male child is brought to the child psychiatry clinic with complaints from the parents that the child doesn't interact with the classmates, prefers to sit alone, and is often doing repetitive behaviors like waving hands in front of the eyes. His speech often appears monotonous with pronoun reversal is there. Which of the following is the treatment modality? But first tell me the diagnosis, then I'll come to the treatment. Very good. What is the diagnosis here beta? Can anybody tell me first the diagnosis? Beta ek baar I'm very happy you're able to tell me the answer also. Correct answer is option A. Very good. Diagnosis kya hai beta? It is autism spectrum disorder. This is a new term added both in DSM-5 and ICD-11. देखो, it is now considered as a neurodevelopmental disorder. बच्चे के neurological development में there is some problem which is causing autism spectrum disorder. There are two core features. One is deficit in social communication, like this child is not communicating with others. Also the child may have some repetitive patterns of behavior. But earlier there was a third core criteria, that is language impairment, जो इस patient में है, but now it is not necessary to make the diagnosis. What all is included here beta? Autism, Rett syndrome, Heller syndrome, Asperger syndrome, all these now are called autism spectrum disorder. All these are more common in males than females beta, except remember Rett syndrome is very important. Rett syndrome, remember, is more common in females than males. One important known genetic risk factor is MECP2 gene on chromosome XQ28. देखो, in Rett syndrome, other than these two core features, you will see that child appears normal till 5 months of birth. Problem शुरू हो रही है 6 months से 2 years में. Patient is having hand wringing movement, so there is loss of the movements, acquired movements, and patient may start having stereotypic movements like such, hand wringing movements. Also microcephaly. Question: microcephaly in Rett syndrome is seen at birth. Tell me true or false. Let me see if you can answer this question. But a microcephaly is seen in Rett syndrome at birth. It is a false statement because at birth the child appears normal. Also remember this drug which has been approved for Rett syndrome twice. This drug has been asked in INI-CET exam. For Rett syndrome, there is one drug, trofinetide. But a tide means it's a tripeptide. It's a peptide drug. Very good. In the management, beta psychosocial interventions, we use behavioral intervention to manage the behavior using techniques of ABA, applied behavioral analysis. So we try to increase certain behavior, decrease some undesired behavior. We target social communication, behavioral skills, and other therapies can also be used. Also remember, drugs can be used for targeted symptom. For example, the child is very irritable, very aggressive. There is extreme agitation. In such scenarios, beta, we can use antipsychotics like risperidone, aripiprazole. Okay, patient is having ADHD symptom, we can also use some drugs which we'll discuss. We manage for ADHD. So targeted symptoms के लिए we can also use some drugs. But remember, usually therapy can be used. And remember, one drug approved for Rett syndrome, it is trofinetide. So the right answer here is, it is applied behavioral analysis. Very good. Let's answer this question now. A 3-year-old child is diagnosed with beta Rett syndrome. Which of the following is false about Rett syndrome? आपको false statement बताना है. So more in females, this is true. Trofinetide, a drug approved for Rett syndrome, is a tripeptide. Correct. Microcephaly, hand wringing seen at birth, beta, it's an incorrect statement. Don't get confused. Read the question carefully. है ना? They will just twist the language. And gene involved we have discussed, yes. So these are correct. Option C is incorrect statement. Let's see the next question. Very good. A 6.5-year-old boy presents with difficulty to pay attention to details, makes careless mistakes, doesn't sit at one place for long, disturbs others, and is not able to wait for the turn. Which of the following drug is incorrect about, which of the following statement is incorrect about the drugs used for the management? But first tell me the diagnosis. Very good. Diagnosis आपने बनाया ADHD. Very good. Child को attention deficit है और hyperactivity impulsivity है. So let's talk about ADHD. Remember, ADHD में inattention and hyperactivity impulsivity है. ADHD is also remember neurodevelopmental disorder. This is also very important term. remember it is also a neurodevelopmental disorder. And in the management, remember the first line treatment, beta, first line treatment is drugs. So we can use drugs, and we have two categories, one is CNS stimulants and another is non-stimulants. So let's discuss some of these drugs. So the drug of choice, in fact, remember is beta methylphenidate. Also remember few points, beta CNS stimulants, they are contraindicated in cardiac illness. If a child is having a cardiac illness, suppose somewhere in the question they tell you that there is a history of sudden death in the family. So they are trying to tell you there may be some cardiac risk involved, don't start CNS stimulants. So in the CNS stimulants, you can remember it with the mnemonic MAM, M-A-M. So we are talking about child. So MAM teaches the child, we'll discuss. So MAM say we will remember CNS stimulants. Methylphenidate, it is the drug of choice. It increases dopamine and norepinephrine. So many of these drugs, they are acting on dopamine, norepinephrine. In fact, questions have been asked from this table also. We'll discuss some questions. So methylphenidate may remember some side effects. Beta, one is child can develop growth suppression. So parents may complain that after this drug, the weight and height are not increasing. So what you will do, should I stop the drug? No, you can use a strategy known as drug holiday. Give holiday from drugs. Also, parents may complain of tics. So child is having some abnormal movements like this or vocalization like this. In fact, all these CNS stimulants can cause tics. So then we have to choose some non-stimulants, which we will discuss. But A for amphetamine, it is not available in India for the management of ADHD. It also is affecting dopamine and norepinephrine. And modafinil is also used in the management of narcolepsy. It is a CNS stimulant. So remember, it is a alpha-1 agonist. So remember, MAM teaches the child A to B. So one is, remember, A for remember atomoxetin. And what is atomoxetin? Beta, it is a selective. It is selective NRI, है ना, not SNRI. SNRI antidepressant में क्या है? Serotonin, norepinephrine. ये selective NRI, norepinephrine reuptake inhibitor. Also remember, this question was asked in NEET PG exam, beta. So FDA has approved atomoxetin for the management of ADHD. Also there is another drug with similar mechanism, riboxetin. देखो उन्होंने क्वेश्चन रिपॉक्सिटिन पे पूछा था, तो नाम में ही देखो बोथ आर सिमिलर नेम्स ना. सो रिपॉक्सिटिन इज यूज्ड इन सम यूरोपियन कंट्रीज फॉर द मैनेजमेंट ऑफ ADHD, and again the mechanism is the same, it is also selective NRI. So A2, so then remember next are alpha-2 agonist, guanfacine and clonidine. Beta, can you tell me some side effects of clonidine, guanfacine? In pharma, usually when we talk about guanfacine, clonidine, you read in which category we talk about anti-hypertensive drugs. So hypotension is one of the side effects. Hypotension can occur, and also remember they can cause sedation. See, I will not give CNS stimulants in the night time. Don't give CNS stimulants in the night time. The child will develop insomnia because these are stimulants. So in night time, if you have to give the drug, the child is having insomnia, then we can use drugs like clonidine, guanfacine because they can cause sedation. Also remember one more important use, they are also used as first line drug for what? For tics. Very good. But so child having ADHD and tics, I will avoid giving the stimulants. So what drugs I can use? I can use these non-stimulants, but out of the non-stimulants we can use clonidine, guanfacine. Of course we can also give atomoxetin, but the tics will also be taken care by these drugs. So clonidine, guanfacine may be preferred. So A to B, B for bupropion. Beta, again bupropion is a NDRI, it is an antidepressant which can also be used in the management of ADHD. I hope this table is clear to everyone. Such questions, clinical question may be asked. Beta, now let's try to answer this question. Clonidine, you have to tell me the incorrect statement. Clonidine is useful for comorbid tics, this is a correct statement. Transdermal methylphenidate, but methylphenidate is also available as transdermal patches. It is useful for children who have difficulty to swallow the pill. Atomoxetin is a selective NRI, that is also correct. Amphetamine is preferred in children with cardiac risk. No, it is a stimulant, it should be avoided in such cases. See, this is the question which was asked in the INI-CET, previous INI-CET exam. So sometimes they will ask such questions, but please try to read the question, see the names and answer the question. A 7-year-old child frequently shows anger outbursts that are disproportionate to the situation or developmental age, and they persist over 1 year time, and the mood is irritable most of the time in between these episodes. What is the likely diagnosis? But we know it is not ADHD na. In ODD, oppositional defiant disorder and conduct disorder, but these are disruptive disorders of childhood. So there are disruptive behaviors. Remember in ODD it is, you can remember it's a milder version. Here the child is argumentative. The child is very argumentative. The child is having opposition. He is opposing the authority figure, the parents, the teachers, the guardians, and is defiant. उनकी बात नहीं मान रहा. He is very negativistic. Negativistic, is disobedient. But there is no physical aggression. Beta. Then you are thinking of ODD. Conduct disorder में the child has physical aggression. He is violating the rights of others, beating others, stealing things, hurting others, hurting animals, and a truancy is there. So then you are thinking of conduct disorder. See the name, disruptive mood dysregulation disorder. See here, the child is having disruptive episodes like in the scenario, and also between these episodes, beta, is the mood normal? No, it is irritable. There is also mood dysregulation. Remember it is. So in the question they have mentioned DMDD. Now suppose they just tell you that there are anger outbursts and in between the mood is normal. Then remember there is another category, that is intermittent explosive disorder. So sometimes just seeing the name you can answer the question. See I hope this is clear to everyone now. So answer यहाँ पे क्या था? Even if you don't know the answer, try to rule out the option, try to match the clinical scenario with the condition mentioned, and you will be able to solve such question. I hope this is clear now. So please be very careful. Very good. But now let's talk about a very important topic. Usually this is one of the topics, but they definitely ask question, that is substance use disorder. So let's discuss some important points. So this is a very important topic. In all the exams, also including INI-CET, you will see question from this topic. So answer this question. A 45-year-old male presented with complaints of tremors, sweating, confusion, auditory hallucinations, altered sensorium, anxiety for 2 days. On taking a history, patient is taking alcohol for 13 years, but past 2 days he is not consumed because of religious reasons. Examination में he has hepatomegaly, LFTs are deranged. Beta condition क्या है? So can I say ये alcohol withdrawal है? So let's talk about alcohol withdrawal. Before discussing alcohol withdrawal, beta tell me, alcohol is a CNS depressant, suppressant है, CNS stimulants है, या फिर stimulant at low dose and depressant at higher dose. Remember, alcohol at all the doses is a CNS depressant. Please remember this point. This question also was asked in the exam. At all the dose. So patient is taking a depressant, suddenly he stops taking. So can I say now in the withdrawal state the brain will go in a hyperexcited state? So let's match the symptoms with this concept. So after stopping alcohol, in the next 6 to 8 hours, patient may report of tremors. So patient is having tremors, patient may also have other symptoms like there is anxiety, there is sweating, patient even may have if you look in the eyes there is mydriasis. So patient is having these withdrawal symptoms. Most common if it is asked, then it is tremors. If this withdrawal state continues beta, in 8 to 12 hours patient may develop alcoholic hallucinosis. So patient is having hallucination, remember auditory hallucination more common, but other hallucinations can also be seen. If this withdrawal state continues in 12 to 24 hours, but a patient may develop seizures, and these are, see, alcohol is devoid of the entire brain, so these are generalized tonic-clonic seizures, also known as rum fits. Fits due to rum, it is rum fits. And remember, up to 72 hours, peak in 48 to 72 hours, but a patient may develop delirium tremens. So remember, delirium may we discussed now, there is impairment of consciousness. So remember all those points we discussed, A, C, D, C, any of these points mentioned, then you are thinking of delirium tremens. But here also in delirium tremens also there may be hallucination. कौन सी ज़्यादा common मिल सकती है? Remember it is delirium. Visual hallucination may be more common, but other may also be seen. Now just tell me again, beta, how will you differentiate alcoholic hallucinosis with delirium tremens? Just answer this question so that I am reassured that you have understood the concept. Beta बताओ कैसे differentiate करोगे? How will you differentiate alcoholic hallucinosis को? देखो दोनों withdrawal state है ना, कैसे differentiate करोगे? Not by the duration, very good, not by the hallucination, but very good, by checking whether the patient is having impairment of consciousness. यहाँ पे consciousness impaired नहीं है alcoholic hallucinosis में, delirium tremens में होगा. Remember, delirium tremens is a medical emergency. It's a medical emergency. Okay, if not treated, patient can die also. There is a risk of mortality also. So please be very careful. But also remember that every patient who is having withdrawal state may not develop delirium tremens. Delirium tremens seizures usually would occur in severe withdrawal state. Now if I ask you, in fact this question was asked twice in AIMS, बेटा 2 बार AIMS में क्वेश्चन आया था, risk of delirium tremens. One option was gradual withdrawal and one option was acute infection. Can you tell me the answer here? देखो ग्रेजुअल विड्रॉल का मतलब है सपोज पेशेंट इज कंज्यूमिंग 750 ml एवरी डे, देन नेक्स्ट डे यू हैव डिक्रीज टू 700, देन नेक्स्ट डे यू हैव डिक्रीज टू 650, सो ग्रेजुअली डिक्रीज कर रहा है. और एक्यूट इन्फेक्शन, वेरी गुड. देखो ग्रेजुअल विड्रॉल से पेशेंट में नॉट डेवलप सच सिवियर सिम्टम्स, बट वी हैव डिस्कस दिस पॉइंट ना कि डिलीरियम में देयर में भी सम रिस्क फैक्टर्स लाइक इन्फेक्शन. मान लो पेशेंट को अल्कोहल विड्रॉल है, कम्स विद ट्रेमर्स, बट ही ऑल्सो डेवलप्स इन्फेक्शन, देन पेशेंट में इवन लैंड इन डिलीरियम ट्रेमेंस. सो प्लीज रिमेंबर दिस पॉइंट, दिस वाज आस्क्ड इन द एग्जाम. ठीक है. नाउ कमिंग टू द मैनेजमेंट, देखो इन मैनेजमेंट में वी विल मैनेज द पेशेंट इन 2 phases. वन इज द डिटॉक्सिफिकेशन फेज जहाँ पे हम पेशेंट के विड्रॉल सिम्टम वी विल मैनेज, एंड सेकेंड इज मेंटेनेंस फेज. सो पेशेंट हैज कम टू अस विद विड्रॉल सिम्टम. सो कैन यू टेल मी व्हाट इज द ड्रग ऑफ चॉइस? रिमेंबर बेटा अल्कोहल विड्रॉल में द ड्रग ऑफ चॉइस इज बेंजोडाइजेपिन. So remember drugs like lorazepam, diazepam, oxazepam, diazepoxide, such drugs can be used. देखो a lot of times ना, like in this question also they've mentioned that LFTs are deranged. So please remember if such situation is given, hepatomegaly is there, cirrhosis is there, then you will use, remember, liver okay drugs, lorazepam, oxazepam. This has been asked many times. So in such scenario you will use drugs which are relatively safe in liver disease. Also remember liver okay treatment, even temazepam can be used, but usually these are the drugs which are used. देखो along with benzodiazepine, so I'll start benzodiazepine according to the symptoms and gradually I'll taper and stop. Along with benzodiazepine we can also add thiamine because patient may have deficiency. देखो अगर क्वेश्चन आता है, प्लीज सी दिस, इफ वन ऑप्शन इज बेंजोडाइजेपिन एंड वन ऑप्शन इज बेंजोडाइजेपिन प्लस थाइमीन, वो बेटर है. बट अगर एक ऑप्शन बेंजोडाइजेपिन है और एक ऑप्शन थाइमीन है, दोनों अलग अलग ऑप्शन है बेटा, देन आंसर वुड बी benzodiazepine. I hope this is making sense now. So one should be very careful when to choose benzodiazepine, when to choose thiamine. Better answer would be benzodiazepine plus thiamine. So patient का withdrawal symptoms I have taken care. Now let's talk about maintenance. बेटा maintenance में ना please highlight this drug disulfiram. It's a aversive agent. Remember the mechanism. It inhibits aldehyde dehydrogenase enzyme. देखो व्हेन अ पेशेंट इज ऑन डाइसल्फिराम बेटा, उसके बाद अगर पेशेंट कंज्यूम्स अल्कोहल ना, तो पेशेंट स्टार्ट्स हैविंग नोजिया, वॉमिटिंग, फ्लशिंग. तो पेशेंट को क्या मैसेज मिल रहा है, जब भी मैं अल्कोहल ले रहा हूँ मुझे तो बड़े टॉक्सिक या अनप्लेजेंट सिम्टम्स हो रहे हैं. सो दिस इज नोन एज डाइसल्फिराम इथेनॉल रिएक्शन. So please remember this. So disulfiram is a aversive agent. It inhibits aldehyde, not alcohol, aldehyde dehydrogenase enzyme. Then we also have anti-craving agents. बेटा patient says सर मुझे craving हो रही है. So one is naltrexone, which is a opioid mu antagonist, and a camprosate, which is a NMDA antagonist. So we have discussed so many NMDA antagonists today. We have talked about memantine in dementia. We have discussed about ketamine, S-ketamine, and also remember a camprosate. It's a NMDA antagonist. So try to remember things like this, and you will never make any error in the exam. So let's now answer this question. Beta, we know patient is having, देखो patient has altered sensorium. Patient has confusion now, so patient has delirium tremens. So it is withdrawal, but better answer is it is not Wernicke's, it is not Korsakoff, and then answer would be lorazepam. अगर ऑप्शन में delirium tremens और diazepam होता बेटा, तब क्या आंसर होता? Suppose there is option E also. Now choose the answer. Still the answer remains very good C, because patient has hepatomegaly, LFTs are deranged. Very happy that you are answering it well. But let's also discuss this table. Sometimes questions are asked from alcohol from this table also. Chronic use of alcohol beta can lead to alcohol induced neurocognitive disorders. One is Wernicke's encephalopathy and another is Korsakoff syndrome. Wernicke's, all of us know, it has sudden onset ना, acute onset होता है. And symptoms क्या होते हैं? Remember ना, Goa वाले symptoms. So Goa is very famous for Feni. Remember Goa वाले symptoms. So patient consuming alcohol comes to us with global confusion. Comes to us with ophthalmoplegia. Beta, patient comes like this. My eyes are deviated to one side. I am not able to move my eyes. Remember, 6th cranial nerve is affected more than 3rd cranial nerve. Okay. And patient is trying to walk, he falls again and again. So patient with a history of alcohol, Goa wale symptoms, I am thinking of Wernicke's encephalopathy. You will say, sir, यहाँ पे भी there is confusion. Delirium tremens also there was confusion. Such a big confusion. No big confusion. Remember, in delirium tremens वाला question, they will tell you there is a history of withdrawal. patient has stopped taking alcohol. Here the patient may be continuously consuming and he has developed some symptoms suddenly. So this is Wernicke's encephalopathy. But the cause is what? The cause is deficiency of vitamin B1 or thiamine. Also remember one biochemistry point which I will correlate again. देखो, actually the question is that these neurocognitive disorders are not occurring per se because of alcohol, but because alcohol की वजह से patient is developing thiamine deficiency. See, in biochemistry we read TPP, thiamine pyrophosphate. In the metabolism of glucose, you will read many enzymes, remember, with the mnemonic ATP, alpha ketoglutarate dehydrogenase, trans ketolase, pyruvate dehydrogenase. Thiamine is required. It is required as a cofactor even for branch chain keto acid dehydrogenase also. So remember this point and we'll correlate this point in the management. So remember the actual cause is beta thiamine deficiency. So you will say, sir, thiamine deficient है तो treatment में thiamine दे देते हैं. Symptoms are reversible or irreversible? Remember they are reversible. Let's now come to Korsakoff syndrome. Beta, it is a chronic sequelae. Symptoms develop slowly, gradually, and we have talked about this ना. Korsakoff syndrome में main important symptom कौन सा है? Remember amnesia. Which amnesia mode? So remember we discussed ना amnestic disorder में it is anterograde more than retrograde. Patient may even have confabulation. Sometimes they just ask what is confabulation. Confabulation का मतलब क्या है बेटा? Filling of the memory gaps with false stories. So patient is not able to remember things, but he will make stories. Please remember, he is not deliberately making these stories. He also thinks he has done all those things. So this is confabulation. Beta, again remember cause remains the same. Deficiency of thiamine. So treatment कैसे करोगे बेटा? Remember treatment is again thiamine. Some of the symptoms may remain. So it is partially reversible, or you can remember it is irreversible. Okay. So these are the questions which they have asked. Now let's discuss some additional points beta. One of the additional points we always discuss has been asked recently in the NEET PG exam. देखो, whenever a patient with history of alcohol, you are planning to give glucose to that patient, beta, please remember always give thiamine. So we should give either thiamine followed by glucose, or you also add thiamine, because we know beta glucose दे रहे हैं because of hypoglycemia, but patient का thiamine नहीं है. So can you appreciate many of those enzymes which are required in the glucose metabolism, conventional metabolism में जो enzymes हैं, they will not act ना. So always give thiamine. So whenever you are giving a patient having history of alcohol, you are giving glucose, also give thiamine. But a second, this can come as a new question now. First has already been asked. Suppose patient comes with alcohol ki history, Goa wala symptoms. So what diagnosis you are making? You are making Wernicke's encephalopathy. You gave thiamine, but somewhere in the question they tell you no response to thiamine. So बेटा अभी आप क्या suspect कर रहे हो? Goa वाले symptoms हैं, patient not showing response to thiamine. That means it is not Wernicke's. It could be even because of pellagra encephalopathy. So now in the treatment what you will add? You will give niacin. I hope this is clear, and this can also come as a new question. So please remember this table. But please be very careful, sometimes such questions are asked, and in fact in the INI-CET recently in one exam 2 such questions were asked. So please see which of the following statement is, you have to see which of the following statement is true, or in fact you have to tell me which of the following statement is false. So the question is which of the following statement is false, tell me. You have to tell me the false statement. Now I am sure it is very simple, we have discussed this point already. Alcohol, देखो, you have to tell me the false statement, or also in fact नहीं, बल्कि let's make it true only. हाँ, true ही है. Question is which of the following is true? हाँ, so you have to tell me the true statement. देखो, alcohol is a low dose is CNS stimulant and high dose में CNS depressant. ये false statement है because we have discussed it is a CNS depressant in all the doses. देखो, cannabis use can cause self-driven repetitive behavior. Sometimes you will see a patient who has taken cannabis, and in cannabis effect you will see the patient is just laughing and doing certain behaviors again and again. Stimulants, stimulants, remember they can cause, we will talk about stimulant like cocaine, but a stimulant hai na, they can increase the sympathetic activity, so MI, grand mal seizures can occur. But a caffeine, now remember even caffeine is considered a substance use disorder. It can, देखो, normally the amount of caffeine we take, it is not very severe, but suppose patient has consumed 10 gram of caffeine, that can also cause GTCAs, respiratory depression, even death can occur, but at a very high dose, which usually we don't consume. So the correct answer is beta options 2, 3 and 4, they are correct answer. Also remember beta what is the most common substance. Beta अगर मैं आपसे पूछूं most common substance India में, remember it is tobacco followed by alcohol. World में if it is asked beta, then it would be alcohol followed by tobacco. But these are licit substances, these are legal substances. But if I ask you what is the most common illicit substances, most common illicit substance क्या आप पूछेंगे तो बेटा क्या होगा आंसर? Then remember it is cannabis. But please remember, if now they ask you most common substance beta and this is given in the option that is caffeine, then you will mark caffeine, because we have discussed na caffeine also now is considered as a substance use disorder. So ICD-11 clearly says it is now the most common psychoactive agent. So please remember this. If caffeine is not mentioned, then for India remember it is tobacco. And अगर alcohol, tobacco, caffeine is नहीं दिया हुआ option में, then remember most common illicit substance is cannabis. I hope this is clear. हाँ, cannabis different forms are there ना, ganja, hash is there, bhang is there, okay, marijuana, all these are different forms. Let's now see this question. Again, such questions are asked in the exams beta. In fact, INI-CET में match the following question have also been asked. So in one question you will see they're trying to test your knowledge of different substances. Okay, so please be very careful with such questions. Match the column 1 with the drug used in the management. देखो alcohol withdrawal में बेटा क्या drug दोगे? We have discussed ना, we can give benzodiazepine, lorazepam is given. Opioid intoxication, बेटा see this very important topic. Opioid intoxication में classical clinical triad में क्या क्या मिलता है? Respiratory depression. If you see in the eyes, what you will see? Please remember pinpoint pupil meiosis and patient may even have coma. Opioid intoxication may the drug of choice is, please remember this has been asked so many times, IV naloxone, opioid antagonist, short acting drug. Please remember this point, very very important. Okay, also remember this, they may just ask you patient with opioid intoxication comes to you, what symptom he may be having. So patient को क्या होगा? tachypnea होगा, bradypnea होगा? Tell me. In opioid intoxication, this is how they are asking questions. Tachypnea, bradypnea, respiratory depression हो रहा है ना, bradypnea. Okay. Also remember in tobacco, remember tobacco में in the management one is nicotine replacement therapy beta. So we can use, so patient is taking, let us say, smoking cigarette. It has so many other compounds also. But what is the compound or what is the active agent which is causing the effects? Remember it is nicotine. So we are giving patient pure nicotine replacement therapy like gums, lozenges, they are like toffees, patches are there, inhalers are there. So NRT and one is anti-craving agent में बेटा दो anti-craving agent approved by FDA for alcohol. यहाँ पे भी remember दो, one is varenicline, बीच में निक आ रहा है ना, so what is the mechanism? It is a partial agonist of alpha 4, 4 पहले है 2 बाद में, beta 2 and nicotinic acetylcholine receptor, and another is bupropion. बेटा please remember bupropion is a NDRI. Antidepressant used for smoking cessation, again bupropion. बेटा varenicline and bupropion दोनों दिए हुए हैं, then remember it is varenicline which is most effective. Okay, all these are questions which have been asked in different exams. So please be very careful. But a patient, this is a new question which can be asked. A 25-year-old male has depression. Okay, patient has depression. Patient is also having ADHD. Patient is also smoking. Which drug can you use? Can anybody tell me, beta, patient ko depression hai, ADHD bhi hai and smoke cigarette also. Which drug can be used, beta? Please tell me the answer of this question, then you can use drug like bupropion. So this is how the newer questions may be framed. So let's come back to this table. Now answer this. Opioid intoxication में we know it is A, that is naloxone. देखो nicotine dependence में ना again we can use nicotine gums, and one of the methods in fact for using nicotine gums is chew and park method. So when we are prescribing patient nicotine gum, we tell them don't chew like the normal chewing gum. Okay, so gradually we want it to be released. So patient chews it for few minutes, then we ask the patient. So after chewing few minutes, then he has to park it between the gums and the teeth here in the buccal mucosa after 1 to 2. So when he's chewing, after some time there will be a peppery or a tingling sensation on the tongue he will experience. So at that time he has to park it between the gums and the teeth, and after that, after 1 or 2 minutes again he has to chew. So he has to do this for 20-30 minutes and then he can spit it out. So this is the chew and park method. Remember, this is the method used for using nicotine gums. Okay, yes, avoid liquid because before it and even after using it, and acidic any drink he's drinking, again that can decrease the absorption. So please remember this. Now heroin is a opioid. Opioid withdrawal में बेटा which drugs we use? So remember, in the opioid withdrawal, देखो opioid withdrawal है तो patient को we can use drugs like methadone and even buprenorphine. We can use methadone and buprenorphine. These drugs can be used. Methadone is a opioid mu agonist and buprenorphine is a partial agonist. So this is one way of managing the opioid withdrawals. Another way of managing beta opioid withdrawal is also symptomatic management. Patient says don't give me opioid, symptomatic treatment can be done. For example, in opioid withdrawal, patient is having diarrhea, a lot of autonomic activities increased. So please remember, for autonomic symptoms we can give drugs like clonidine, which will decrease the sympathetic symptoms. For diarrhea we can use drugs like loperamide. So patient is having a lot of pain, we can use painkiller. So these are two ways by which we can manage opioid withdrawal. Also let's discuss the management of opioid maintenance. But after managing the withdrawal symptom, then what all treatment we can do in the maintenance? Remember, in the maintenance one strategy is opioid substitution therapy. हम patient को बोलते हैं don't use impure opioids, we can give you again, we give pure opioids like methadone, buprenorphine again in the management. And one more drug beta is naltrexone. We can also use naltrexone. यहाँ पे we are using the antagonist property of naltrexone. So it will block the opioid receptors ना. So patient बाहर से अगर opioids consume कर रहे हैं तो patient will not have that effect. So patient may stop taking the opioid. So please remember, nowadays questions on opioid is also being asked. So we have also discussed opioid intoxication B and opioid withdrawals B. I hope this is clear to everyone na? Very good. So answer is 1 is D, 2 is A, 3 is B and 4 is C. So the right answer is option C. I hope this is clear to everyone na? Let's discuss about cocaine, but again cocaine is a small topic, but so many times you will see the questions on cocaine have been asked in the exam. So please remember, cocaine is a stimulant. Also even amphetamine beta is a stimulant. So amphetamine will also have a lot of these effects which are seen with cocaine. So it is derived from the leaves of the plant Erythroxylum coca. देखो ये stimulant है ना, just remember, always understand the concept. It will increase the sympathetic activity. So patient may develop hypertension, tachypnea, tachycardia, cardiac arrhythmia, seizure. Better tell me, it will cause meiosis or mydriasis? This question is asked again and again. Meiosis or mydriasis? Better please remember mydriasis. In fact, remember TCA, tricyclic antidepressant, cocaine and amphetamine. These are associated with mydriasis. In pharma also, in forensic also, you will read a lot of substances related with meiosis and mydriasis. Please be very careful. Remember, opioid intoxication will cause meiosis. Opioid withdrawal may again it will be mydriasis. But we have already discussed na, cocaine bugs. Patient comes to us with tachycardia, tachypnea, scratch marks. Which substance he is consuming? Now you can correlate na. Cocaine is a stimulant, so tachypnea, tachycardia के साथ साथ patient may even have scratch marks because of this. But what are speedballs? When sometimes people combine cocaine with heroin, opioids like heroin, then patient may, then this combination is known as speedballs. But a patient cocaine consume करता है, may use cocaine by snorting, it causes vasoconstriction. Repeated use of cocaine से nose में क्या finding हो सकती है? बेटा, can anybody tell me? This can come again as a ENT psychiatry का integrated question. So can you appreciate this finding? There is a nasal septal perforation and tongue में क्या मिल सकता है बेटा? Please see, jet black pigmentation. So such images or such integrated question may be asked also. So please be very careful with cocaine. Okay, I hope this is clear na? Very good. But now let's discuss few more smaller topics. 23-year-old female brought to the psychiatrist with history of irritable mood since 8 months. Since some years her mother has noticed changes in her food habits and there are also changes in the size of her clothes. She reports of eating large amount of food followed by induced vomiting. Her oral examination shows caries and there is callus on her knuckles. BP is 110/70. Pulse rate is 90, temperature is 98.5, BMI is 17 kgs per meter square. You have to tell me the incorrect statement. बेटा पहले मुझे diagnosis बताओ, then answer this question. Very interesting. So let us first make the diagnosis of this question beta now and then you will tell me the correct answer. बेटा देखो फिर से देखो क्वेश्चन को, आंसर डायग्नोसिस क्या है बेटा? बुलिमिया है या एनोरेक्सिया है? वेरी गुड. देखो क्वेश्चन में ऐसा लग रहा है कि डायग्नोसिस बुलिमिया हो सकता है, बट कहीं पे बहुत इंपॉर्टेंट चीज मेंशन की गई है. सी दिस. हाँ, वेरी गुड बेटा, लेट्स ट्राई टू अंडरस्टैंड दिस. देखो इन ईटिंग डिसऑर्डर वन इज एनोरेक्सिया नर्वोसा, वन इज बुलिमिया नर्वोसा एंड अनदर इज बिंज ईटिंग डिसऑर्डर. ये तीनों डिसऑर्डर्स रिमेंबर आर मोर कॉमन इन फीमेल्स दैन मेल्स. देखो एनोरेक्सिया नर्वोसा में ना पेशेंट इज ईटिंग वेरी लेस बिकॉज ऑफ फियर ऑफ गेनिंग वेट, बिकॉज there is a disturbance in body image. So remember, there is low body weight, very important, or remember BMI is less than 18.5 kg per meter square. To make the diagnosis of anorexia nervosa, it should be mentioned that the weight is low or the BMI is reduced. Remember, anorexia nervosa is also of two types, but the most common is restricting type, patient is eating less, but even binge eating, purging type can also be seen. So patient may have episodes of binge eating, eating large amount of food in less time, and then using purging behavior. But remember, patient का जो weight या BMI is less. So please be very careful. Binge eating, purging यहाँ पे भी मिल सकती है. Should we admit all the patient? No, admission may be required in some patients. For example, there is complication like electrolyte imbalance is there is dehydration, or the weight by height is reduced by 20%. Then you are thinking of admitting the patient. So we don't admit all the patient, but yes, many times hospitalization may be required. Now please remember, in the management, if it is asked, CBT is the preferred treatment, and also we can use drugs like SSRI. But let's discuss 2 points in the management. One is, suppose for 1 week, देखो patient का weight less है, तो one of the goal is to restoration of the weight. I am giving adequate calories for 1 week, but there is no increase in weight. बेटा तो next step क्या होना चाहिए? Increase calorie, add antidepressant, or observe the patient 2 hours after each meal. Please remember, we will observe the patient 2 hours after each meal. What if the patient is using self-induced vomiting, purging? Also, now this can come as a new question, but this question in fact was asked in the AIIMS exam. This may come as a new question. Patient after being started on treatment, started, feeding is started, patient presents with decreased potassium, phosphate, magnesium, patient has cardiac arrhythmia, rhabdomyolysis, thiamine deficiency, seizures have occurred. So what are you thinking? What is this beta complication? So if we start feeding this patient with very high calorie, देखो patient is in a state of starvation and we start giving very high calories, patient may land up into this, which is known as, remember, feeding syndrome. So this is also a clinical picture which may be asked in the exam. So please be very careful. But let's come to this question now. Now see, many options may be there which you may not be able to remember. See now, metabolic alkalosis can occur as a complication. We will discuss this can occur because it is one of the complications with purging which can occur, self-induced vomiting. Supervised feeding and start CBT, yes, that can be. देखो, is hospitalization required in all the cases? No. Here they have not mentioned much complication. Remember, suicide rate is higher in binge eating. This is also true. So here the incorrect statement is option C. Very good. But let's now answer this question. A 21-year-old female brought to the clinic by mother whose symptoms are consistent with depression. She also has irresistible urge to eat followed by episodes of self-induced vomiting. Patient is on appetite suppressant. On examination, following clinical sign is seen. So beta ये clinical sign मिल रहा है यहाँ पे. You have to again tell me which is the correct statement. You have to tell me which is the correct statement. Let's answer this question. Very good. Beta diagnosis, if you are able to make, you are able to answer the question correctly. ये anorexia है या bulimia? It could be either, but have they mentioned weight beta? नहीं ना, तो weight low should be given, then I am thinking of anorexia. So here the answer is, it is bulimia nervosa. See, Russell sign is seen in all the cases, not necessarily na, because every patient may not use self-induced vomiting. They can use other methods of compensation. Please be very careful. क्या bupropion इस patient को देना चाहिए? Bupropion is an antidepressant ना. Should I give this antidepressant? Patient को तो depression है बेटा. देंगे या नहीं देंगे? बेटा हमने discuss किया ना, it is contraindicated ना, because risk of seizure बढ़ जाएगा. So here the answer is option C. So remember, bulimia nervosa again more common in females than male. Patient को binge eating है. देखो compensatory behavior में ना, don't always think it is self-induced vomiting. Yes, it can be purging behaviors like self-induced vomiting can be there beta, but other methods can also be used. For example, patient is using emetics, patient is using laxatives, okay, patient is using drugs, and also sometimes patient is dieting, patient is exercising. So please be very careful. Patient after binge eating is dieting or is exercising for some time. So these are also compensatory behavior. बेटा कैसे डिफ्रेंशिएट करोगे? रिमेंबर यहाँ पे जो वेट और BMI है, it is either normal or it may be increased. Also remember, there may be some complication because of purging. Patient is doing self-induced vomiting. बेटा please remember, जो acidic content है stomach का, it is repeatedly coming in the oral cavity and going out ना. So can I say बेटा dental caries होगा, oral hygiene would be poor. Parotitis can occur because of inflammation, infection. This is Russell sign na. In the hands, this is Russell sign. There is callus on the knuckles because of repeated trauma. देखो HCl is going out. There is decrease in potassium, magnesium and hypochloremic. HCl is going out. Remember, it is metabolic alkalosis. देखो पेशेंट को डेंटल कैरीज है, पेरोटाइटिस है, रसल साइन है, मेटाबॉलिक एल्कलोसिस है. टेल मी द डायग्नोसिस, टेल मी द डायग्नोसिस बेटा. पेशेंट को डेंटल कैरीज है, पेरोटाइटिस है, रसल साइन है, मेटाबॉलिक एल्कलोसिस है. डायग्नोसिस यू मे थिंक ऑफ बुलिमिया नर्वोसा बट नॉट गिवन इन दी ऑप्शन. तो फिर क्या डायग्नोस करोगे बेटा? अगर ये ऑप्शन में नहीं दिया, देखो एक्चुअली ये जो कॉम्प्लिकेशन है पर से दे नॉट बिकॉज ऑफ बुलिमिया नर्वोसा बट दे आर बिकॉज ऑफ पर्जिंग. सो रिमेंबर दीज कॉम्प्लिकेशंस बेटा कैन ऑल्सो अकर इन एनोरेक्सिया नर्वोसा का बिंज ईटिंग पर्जिंग वाला सब टाइप. ओके, बिंज ईटिंग पर्जिंग में हाउ विल यू डिफरेंशिएट? टेल मी हाउ विल यू डिफरेंशिएट? कैसे करोगे? यू विल डिफरेंशिएट सी द वेट और द BMI. अगर डिक्रीज है देन इट इज एनोरेक्सिया, इफ इट इज नॉर्मल और इंक्रीज्ड देन यू आर थिंकिंग ऑफ बुलिमिया. वेरी गुड. ओके, आई होप दिस इज क्लियर ना. तो ये क्वेश्चन क्लियर है सबको? इन दिस I've just twisted the option. This question was asked in fact in one of the exam. तो ऑप्शन वहाँ पे बुलिमिया नर्वोसा था, but I've just changed some of the options so that you are able to answer those questions also. Let's now discuss this question. Which of the following is not true about the EEG findings? बेटा this is again a very important topic. देखो in fact जो sleep पे questions आते हैं ना, more questions again last exam में भी PYQ था in the sleep physiology. So please be very careful with the sleep physiology. Tell me what is the incorrect statement about the EEG finding. देखो बेटा we have NREM sleep and REM sleep है ना. NREM is N1, N2, N3 and then we have REM. So in N2 remember N2 में ना दो findings होती हैं बेटा. N2 में one is you can see these are sleep spindle sudden burst of activity and these are K complexes है ना, sharp positive negative wave, these are K complexes. देखो REM में very interesting. देखो please remember this concept first. When we do EEG, so we are talking about EEG findings ना. When we do EEG normally बेटा, when we do EEG, बीटा वेव और अल्फा वेव कहाँ मिलते हैं? See, when you are awake, suppose we are awake right now, I hope all of us are awake right now. So see the findings. In the awake state, when you are awake, beta waves and alpha waves are seen. Beta waves कब मिलती हैं? When you are awake and the eyes are open. Alpha waves कब मिलते हैं? You are awake but the eyes are closed. This question was asked in the INI-CET कि patient is awake, closed eyes, now opens the eyes. Which is lost? So I'll say alpha is lost. So this is awake state. So when we are awake, can I say the brain is active, is working fast? So these are high frequency waves. Very interestingly, beta, when we sleep in REM also now, these waves are seen, beta and alpha. So can I say we are sleeping but brain is behaving as if we are active? So that is why this is known as paradoxical sleep. So please remember REM sleep is known as paradoxical sleep. So these high frequency waves, these are alpha, beta, alpha waves. But can you appreciate, देखो frequency तो fast है but amplitude या height बहुत कम है. So इस appearance को बेटा क्या कहते हैं? Can हाँ, very good. So you are also telling me the year in which this question was asked है ना, तो very good. So that is why I am saying this is known as sawtooth appearance. देखो very interesting point you can also remember. So REM में we remember the dreams, NREM में we don't remember the dreams. Suppose we are in REM, बेटा brain active है. What if we start acting out our dreams है ना, हमें इंजरी हो सकती है, आसपास के लोगों को इंजरी कैन अकर. So what nature has done, when we are in REM usually the muscle tone is in a state of paralysis, there is atonia. तो अगर स्लीप डिसऑर्डर में बेटा देयर इज सम मूवमेंट, देन आई एम थिंकिंग ऑफ इट एज एनआरईएम डिसऑर्डर, बिकॉज आरईएम डिसऑर्डर में यूजुअली द मसल टोन इज इन अ स्टेट ऑफ पैरालिसिस. बट एक आरईएम डिसऑर्डर हमने डिस्कस किया जहाँ पे मूवमेंट्स हो सकती हैं. कैन एनीबडी टेल मी विच डिसऑर्डर आई एम टॉकिंग अबाउट? लेट मी सी इफ यू रिमेंबर. मैंने कहा था पोटेंशियल न्यू क्वेश्चन भी है. इन विच आरईएम डिसऑर्डर देयर कैन बी मूवमेंट सीन? वन ऑफ द इंपॉर्टेंट डिसऑर्डर्स. आंसर दिस क्वेश्चन ना, एक डिमेंशिया के साथ हमने डिस्कस किया था. So I'll give you one more hint. Lewy body dementia. Remember the core features show your CVMR. R क्या था? REM sleep behavior disorder है ना? Very good. Yes. So please be very careful. Such questions can be asked. Let's now answer this question बेटा. In stage N2 EEG shows sleep spindles and K complexes. ये correct है. Loss of alpha wave when a awake person opens the, ये correct है. This was the question asked. देखो delta waves, remember D for delta, D for deep sleep. Delta waves are slow waves. These are 0.5 to 4 hertz frequency. You will see 3 hertz frequency, 0.5 से 3 hertz frequency. These are slow waves. एंड रिमेंबर डीप स्लीप किसे कहते हैं, N3 को, N3 इज नॉट, सो दिस इज अ इनकरेक्ट स्टेटमेंट. REM shows sawtooth appearance, ये करेक्ट है. तो राइट आंसर क्या है बेटा यहाँ पे, दैट ऑप्शन डेल्टा वेव्स इज नॉट सीन इन N1, इट इज सीन इन N3. आई होप दिस इज क्लियर ना. चलो इसको भी आंसर कर दो. टेल मी व्हाट इज दिस स्टेज डिपिक्टिंग. देखो जब भी हम स्लीप असेस करते हैं बेटा, वी यूज 3 पैरामीटर्स, EEG, EMG, EOG. EEG is electroencephalogram, EMG muscle activity, electromyogram and EOG ocular activity. देखो नाम ही हमने NREM, REM रखा है ना, rapid eye movement, non rapid eye movement. Let us see these. This is, let us say 1, this is 2 and this is 3. You have to tell me what is this 2. देखो EEG in 1 can I say ये fast है. EMG में again I can see movement and also EOG you can see there is movement. So this is in fact awake state. Very good बेटा. अब सेकंड पे आते हैं, EEG again is showing fast activity but EMG is showing negligible activity as if it is in a state of paralysis, and yes EOG में you can see activity. This is REM. Very good. And 3 में again बेटा you can see slow waves. EMG में you can see movements are present and it is decreased, it is less. So ये क्या है, this is NREM and NREM में भी ये कौन सा हो सकता है, this could be N3 है ना, you can see the delta waves. So please remember this. Very good. So ये this 2 is depicting what, it is depicting REM. Very good. So please be very careful. Such questions have been asked, will be asked again and again. Okay. Now answer this question. A male patient comes with history of marital conflicts and complains of early ejaculation. First make the diagnosis. So there is early ejaculation. So can I say this is premature ejaculation? आपको incorrect statement बताना है. So please see this. In fact, let's first talk about बेटा erectile dysfunction and PME. Erectile dysfunction में क्या हो रहा है, that the person is not able to obtain या maintain erection, and PME the ejaculation is occurring early. In the treatment बेटा ED की treatment में one therapy, again and again question on therapy are asked. The therapy is sensate focus technique and drugs we can use PDE5 inhibitors है ना. All these drugs ending with phil, sildenafil, tadalafil, vardenafil, avanafil. In PME, very important, remember the therapies beta, one is squeeze technique, another is stop start technique. Can you tell me the drug? Beta we use SSRIs. SSRIs का side effect होता है that they can cause delayed ejaculation, and this is what is required here. So we are using the side effect of SSRI in the management of PME. So let's now come back to this. Squeeze technique can be used in the management of PME, ये correct है. देखो there are 4 phases of sexual response cycle बेटा, डियोर से याद कर सकते हैं, desire, excitement, orgasm and resolution. So remember ejaculation is occurring, ejaculation कहाँ आकर होती है, in the orgasm phase. So yes, PME is a disorder of orgasm phase. Ejaculation occurs within 2 minutes of vaginal penetration. देखो this is very interesting. You are saying option D. Option D may occur. This is a new option which I have added. You might not have heard about it because in the exam you will see some questions like this. You don't know about it. Appears to be more common among college educated men than among men with less education. You don't know it is true or false. You first tell me option C correct है या incorrect है. This you definitely would know. Because बेटा whenever we talk about PME we say DSM-5 का क्या criteria है बेटा? DSM-5 का criteria if it occurs in less than 1 minute, very important. और severe cases में तो it says if it occurs within 15 seconds. So please remember बेटा this is definitely incorrect. So please see the question you may, so that means this is also correct statement. This is a correct statement which has been shown in the studies. Even if you don't know some of these statements, but the right one you would definitely know. So please remember this. यहाँ पे correct answer is option C. Very good. So please be very careful when you are ruling out the options. This is again a very important topic. Nowadays you will see many questions that have come from this topic. So I'll just discuss personality disorders another 10 minutes. Then we will stop. A 25-year-old male is brought with symptoms of suspiciousness towards people around. Beta, he seems to lack trusting others, feels it difficult to confide in others. He often gets into arguments with friends, hold grudges. बहुत time तक grudges hold करके रखते हैं. Examination में scanning the room. Remember, there are no delusions, hallucination. There is no psychotic disorder they are trying to tell you. So option में it is telling you it's a personality disorder, na? Can you tell me which personality disorder we are dealing with here? See, personality disorders may usually they have a onset in the late adolescence, 17, 18, 19 years, and the symptoms will remain stable with time. So symptoms of a long duration is given. But this is a very important table. Let's try to understand some of these personality disorders. Cluster A, remember 1W is weird. Cluster B, remember wild. And cluster C, remember worried. So let me just quickly discuss these personality disorder. In paranoid personality disorder, remember the name is paranoid, but there is no delusion, hallucination. Patient is having a long standing passion of suspiciousness. Patient थोड़े शकी हैं, is not able to trust others, like in that question. But schizoid में, please remember, S से schizoid, there is a pattern of social withdrawal. Patient does not want to engage in group activities. Patient wants to stay alone. So there is social withdrawal. Schizotypal में O is coming in between. Now remember, patient has odd beliefs, like patient is very superstitious, belief in telepathy, sixth sense. Patient may also be suspicious. So this is paranoid, schizoid and schizotypal. Next is cluster B. There are 4 personality disorder, but antisocial है ना, against society. Patient is violating rights of others. Patient is beating others, lying to others, is manipulating others, is having impulsivity. Remember, antisocial personality disorder के लिए the age should be 18 or above. If such symptoms are present but less than 18 years, then which disorder you are thinking? You are thinking of conduct disorder. Borderline personality disorder, a very important topic, but here it is, remember, more common in females than males. So borderline personality disorder more common in females than males. Patient has unstable interpersonal relationship. Patient may say one day you are the best person I know. Second day you not given up and oh, you are the worst person I know. So unstable relationships. Recurrent suicidal behavior may be there. Patient may report of chronic feeling of emptiness. Impulsivity may be there. Remember, for managing all these personality disorders, beta, we use therapy, and for borderline personality disorder, one of the therapies is dialectical behavior therapy. Histrionic may patient wants to be the center of attention. So patient may talk in a very loud manner, dramatic manner, may wear very colorful clothes, may behave very colorfully. So patient wants to be the center of attention. But a narcissistic may patient thinks I am the most important person. So there is a heightened sense of self-importance, even if there are not much achievements. Next is cluster C. Cluster C में anxious avoidant, as the name suggests, patient बड़ा sensitive है to rejection. Patient is thinking, patient is socially withdrawn. Patient feels I am socially inept. He is not socially inept, but उसको लगता है. So he is very sensitive to rejection. Dependent personality में patient is dependent on small decision, everyday decision. What should I eat today? Let me ask my mother. What should I wear today? Let me ask my friend. So patient छोटी-छोटी चीज़ों पे dependent है on others. Lastly, obsessive compulsive personality disorder. Beta, please remember, the name is obsessive compulsive, remember, but no obsession, no compulsions are seen. यहाँ पे the person is preoccupied with details. सब कुछ patient को perfectly करना है. So if the patient wants to read, I want red pen, blue pen, pink pen, yellow pen, orange pen, magenta pen, violet pen, all the books, all the notes. Beta 2 घंटे हो गए. Patient has not read even a single page. So patient wants to do everything with perfectionism. Patient is very stubborn. But please remember, OCD में ना we say that patient is having ego dystonic. Patient को पता है ना, remember Rosie में patient को these are senseless thought. But यहाँ पे in OCPD patient is ego syntonic. Patient को नहीं लगता कि वो जो कर रहा है वो गलत है. Okay, so please remember, very good. Also known as anancastic. Very good. Also known as anancastic. Previously in ICD-10 it was known as anancastic personality disorder. Very good. So now answer this question, beta, ये क्या है? यहाँ पे patient is suspicious, not able to trust people easily, having symptoms for a long duration. So this is what? This is paranoid personality disorder. Very good. Please be very careful, beta. Let's answer this question now. A patient is having bipolar disorder, history of multiple suicide attempt. Which of the following mood stabilizer has strongest evidence of reducing the risk of suicide? So finally, we've talked about clozapine has anti-suicidal property. We have also talked about ketamine, S-ketamine, and also remember lithium. Lithium again is a very important topic. Please revise lithium in the exam. Let's discuss some adverse effects of lithium, which you can remember with the mnemonic lithium only. So one is loss of hair. Patient can have alopecia, even other dermatological side effects like acne, psoriasis, rash can occur, and also loss of appetite. But please remember, although it is causing decrease of appetite, but ultimately lithium is associated with weight gain or weight loss. Remember, it can cause weight gain because of so many other factors like hypothyroidism, increase in liquid intake. Because of all those factors, lithium can cause weight gain. Increase in the leukocyte. Remember, we discussed clozapine decrease करता है counts को, यहाँ पे it can increase the counts. Patient may develop fine tremors may occur with lithium. Tell me, beta, ट्रीटमेंट क्या होगा लिथियम इंड्यूस्ड ट्रेमर्स की? रिमेंबर यू विल गिव ड्रग ऑफ चॉइस क्या है यहाँ पे? प्रोप्रानोलॉल. रिमेंबर दिस, प्रोप्रानोलॉल. H for remember endocrine effect. 1 hypo है, hypothyroidism, and 2 hyper है, hyperthyroidism, and also remember it is hyperparathyroidism. So please remember hyperthyroidism and hyperparathyroidism can also occur. Increase in the urine, so it can also cause diabetes insipidus. What is the treatment? We can use drugs like thiazide diuretics, potassium sparing diuretics, but a very important interaction of thiazide diuretics with lithium. Thiazides decrease lithium clearance, very important point, so they can increase the lithium levels. Lithium toxicity हो सकता है, so please remember. So we read a lot of interactions of lithium. Remember, thiazide diuretic, they can decrease lithium clearance and can cause lithium toxicity. M say 1 is maternal beta abstinent anomaly. One more M, remember in miscellaneous, it can cause benign T wave changes. T wave inversion can occur and even flattening can occur. Okay, so benign ECG changes can also occur with lithium. Okay, so very important point, please remember this point. I hope this is clear na. So please revise lithium, lithium toxicity revise karna hai, lithium, all those points on lithiums are very important. Okay, let's now discuss this question. Also MHCA, sometimes questions are asked, but a Mental Health Care Act, you have to tell me which of the following is incorrect statement. Let us see if you can answer the incorrect statement about what is MHCA, Mental Health Care Act 2017. Now this is the new act for patients with mental illness. You have to tell me the incorrect statement. But the decriminalization of suicide is correct or incorrect? ये correct है. Section 115 of the MHCA. Beta earlier there was IPC 309. Anybody who has attempted suicide, he survived, then it was punishable under IPC 309. But now we know that IPC has been replaced by Bharatiya Nyaya Sanhita and there is no corresponding section of IPC 309 in the BNS because there is no decriminalization of suicide. But advance directed, very important term, remember, any person who is 18 and above, they can write in advance, they can give a directive. So beforehand person can write ki agar he develops mental illness and he does not has the capacity to take treatment related decisions, so in advance they can write their advance directive. But please remember, supported admission maximum duration initially it is not 40 days, it is 30 days. Please remember this. Okay, so please remember in section 89, supported admission means that patient does not have the capacity to take the decision, then the patient is admitted as supported admission. And also remember mental health establishment, this is the term now used for hospitals in which patient is admitted for treatment of mental illness. So remember the incorrect statement is option C. So please remember few important points about MHCA. Also there are certain prohibited procedures. One of the procedure is, remember, in India now direct ECT is now prohibited. So whenever we are giving ECT, remember we are always using indirect. We are always using indirect or modified ECT. Okay, modified ECT. But again, देखो advance directive में again if there is an emergency like the patient is having risk or harm to self or to other, then the doctor can treat the patient even if it is not mentioned in the advance directive. Then the patient can be treated even if it is not mentioned in the advance directive. In such scenarios, the doctor can treat the patients accordingly to the situation. So please remember this. Okay, I hope this is clear to everyone. Let's discuss few more points. So these were some important points. Let's talk about some terms. Can you tell me what is transference? Beta, transference का मतलब क्या है? These are feelings, maybe conscious or unconscious feelings of the patient towards the therapist. And what is counter transference, beta? What is counter transference? These are feelings of the therapist. Sometimes the therapist can also develop feeling towards the patient. So that is counter transference. So they may just give you clinical situation like this. Also remember, beta, let's discuss one point about the community medicine or PSM. Now we have the National Tele Mental Health Program, that is Telemanas. What is Telemanas? They may just ask you the full form also. It is Tele Mental Health Assistance and Networking across state. Remember this number 14416. You know, Telemanas, also remember the logo. So now in India we have the National Tele Mental Health Program. So person can take treatment through call or through the app. It was launched on the World Mental Health Day, 10th of October 2022 by the Government of India. So please remember this. In fact, there are certain updates in 2025. There is a celebrity who has been now appointed as the mental health ambassador in India? Who is the famous celebrity beta? Ambassador in India. Who is the famous actress? Very good. Deepika Padukone. She has been appointed. Very good. Ms. Deepika Padukone, she has been appointed as the mental health ambassador to spread awareness related to mental health. Very good. So please remember Telemanas. It's a national tele mental health program in India. But also let's talk about this point, gender identity disorder. But a gender identity disorder, as the name suggests, there is problem in the gender identity. So all of us know, usually corresponding to the anatomical, sexual organs. So one who is having male sex organ, no, they are male. A person having female sex organ, no, they are female. So this is gender identity. Sometimes there may be problem in this. So one of the important disorders is transsexualism. But transsexualism, as the name suggests, trans का मतलब क्या है? Opposite. Sexualism means gender. यहाँ पे patient को desire है to live and be accepted as member of opposite gender. For example, a 25-year-old female says, sir, I, biologically, genetically, I am a female, but I want to live like a male. So she has a desire to live like a male. So this is gender identity disorder. This is transsexualism. But in the management, we can help the person to be as close as possible to the desired gender. So hormonal therapy दे सकते हैं. Even, one of the treatment is we can also do surgical treatment, gender affirming surgeries, that is GAS. Also let's compare one paraphilia, beta transvestism, which is also known as eonism. देखो, they may give you question which may confuse you. देखो, in gender identity disorder transsexualism, patient is wearing clothes of opposite gender. Trans का मतलब opposite, again beta vestism means clothes. Here also patient is wearing clothes of opposite gender. How will you differentiate? Can you tell me? Can you tell me how will you differentiate beta? Transvestism और transsexualism दोनों में patient में wear clothes of opposite gender, but यहाँ पे बेटा it's a paraphilia. Patient is wearing clothes of opposite gender to get sexual gratification, है ना? Please remember this. Fetishism में patient is getting sexual gratification by inanimate objects like clothes, feet, shoes, gloves, or even the non-genital body parts. देखो, frotturism में double T आ रहा है ना, patient is getting sexual gratification by touching या rubbing hands on the opposite gender. Exhibitionism, as the name suggests, patient is exhibiting the genitals to another person and getting sexual desire. Pedophilia, again remember better, the person is getting sexual desire by having sexual acts on the child. Masochism, M for myself. Patient is getting sexual desire or sexual gratification by hurting self. Sadism, S for remember, second person. Person is getting sexual gratification by hurting the other person. So please try to remember these paraphilias. Many times in INI-CET they have asked questions on these paraphilias. Okay, also remember how to differentiate transsexualism and transvestism. We have also discussed differentiating OCD, sexual OCD with frotturism also. So such questions may also be asked. So let's just rapidly discuss few more rapid fire round questions and then we'll stop. See some of these data. Remember percentage of patients with schizophrenia committing suicide, remember 5 to 6%. Most common cause of premature death among patients with schizophrenia is suicide. Then there are other factors also like cardiovascular disease. Many patients having schizophrenia may also have premature death because of cardiovascular disease, because of physical illness, because of accidents. Lifetime prevalence of schizophrenia कितना है बेटा? If you remember, one data 0.7. Earlier data, if 0.7 is not given, then earlier it was 1%. Remember, schizophrenia is equally prevalent in males and females. Rate of suicide in India, beta, the latest data which we have is now of 2023. It is 12.3 per 1 lakh population. Percentage reversible causes of dementia we have already discussed, 10 to 15%, very important table. Mean age of onset of depression, beta, it is 40 years, remember. So we can say this question was asked, in one of the exams. Depression is more common in young male, young female, middle-aged male, middle-aged female. So remember it is middle-aged female. And mean age of bipolar disorder, remember it is 30 years. Depression is more common in females than males. And bipolar 1 disorder, remember it is equally prevalent. And bipolar 2 disorder, remember it is more in females than males. So 3 important disorders which I have covered which are equally prevalent in males and females. कौन सा? Schizophrenia, one is bipolar 1 disorder and also one anxiety disorder. Can anybody tell me? बेटा anxiety disorder बता सकते हैं कोई मुझे? कौन सा anxiety disorder? Remember, social anxiety disorder. Lifetime prevalence of OCD बेटा in general population क्या है? 2 to 3%. Remember, this question has been asked, this data has been asked in INI-CET. Mean age of onset of OCD is 19 years and prevalence is more common in females, slightly more common in females than males. Remember this. Also, when we talk about beta most common comorbidities, agoraphobia mein most common comorbidity is panic disorder. OCD and anorexia mein you can remember it is depression. OCD we have already discussed na, even anorexia nervosa mein patient may also have depression. Very good. But let's discuss some of these scales which we use, some of these assessment tool. Very simple, remember confusion assessment method we have discussed na, this is used in delirium. MMSE, mini mental state examination, but see, this is used to assess cognitive function and we say, so it can be used both in even dementia we use, even in delirium it can be used. So remember, it is assessing cognitive function and score less than 24 is suggestive of dementia. HAM-D we have discussed, Hamilton rating scale of depression. But see, HAM-D na clinician rated scale hai. So clinician expertise is required, it is clinician rated. जबकि BDI Beck depression inventory ये patient rated है. So if I ask you in a community I have to use a scale, which would I prefer, HAM-D या BDI? So Beck depression inventory patient rated है, patient himself can use the scale and get a score. तो tell me social settings में बेटा कौन सा scale ज़्यादा effective होगा? In the community setting where I may not have expertise with me. So then BDI. PAN-SS देखो positive and negative syndrome scale. Tell me where it can be used ना. Positive negative symptoms बेटा कहाँ मिलते हैं? Remember schizophrenia. Cage criteria and audit. देखो cage criteria, it is a screening tool. Here we ask the patient, do you feel the need to cut down on your alcohol? Do you feel annoyed when asked about your alcohol? Do you feel guilt of consuming alcohol, or do you use alcohol as an eye opener in the morning? So cage question here. And again, audit is alcohol use disorder identification test. These are used for alcohol. But a very good, can anybody tell me SCOF criteria is used for what? This is again a PYQ in INI-CET exam. SCOF criteria हम use करते हैं for, remember, for eating disorder. But again, tell me heads assessment. In heads assessment, when we are assessing what age group, we use heads assessment. This is used for which age? Remember, heads assessment is used for adolescents. Very good. For adolescents beta, remember heads assessment is used for adolescents. Let me discuss few acronyms. This question was asked beta in your, again in the INI-CET, that when you're breaking a bad news to a person, what is the protocol used? That is the spikes protocol. So please remember what is spikes. You see the setting, you ask what is the perception of the person, you invite the patient for any question, assess the knowledge, you see the emotion and what is the strategy one can follow later on. So this is spikes protocol, and when you're building rapport with the person, remember the acronym PEARLS. So when I'm building a rapport, partnership, E for empathy, A for apology, respect, legitimization and support. So just remember, for building a rapport, this is PEARLS approach. So this question, sometimes they ask these acronyms. So please be very careful. Now 6 elements, the active ingredients of brief intervention shown to induce change. Suppose a patient is consuming alcohol, so there is an addictive behavior or addictive substance he is consuming. So we can use brief intervention which includes 6 elements. Beta, what are the 6 elements? You can remember with this acronym beta, frames. What is frame? Remember, first is feedback. You give a feedback like consuming alcohol may be harmful. You place the responsibility on the person that it is your responsibility. You give advice, what the person can do. You don't pick up one treatment modality. You give a menu that these are the options available. Very important, be empathetic towards the patient and self-efficacy. Promote self-efficacy. That patient himself should take the decision, should himself try to stop the substance or that behavior. So please be very careful. But while having motivational interviewing, so when you are interviewing a patient, remember the acronym for strategies for motivational interviewing. So I am dealing with a patient who is consuming alcohol. Develop discrepancy that your behavior, what you're doing may be harmful for you. Don't argue with the patient, avoid argumentation. If there is resistance, roll with the resistance. And again, ENS are the same, empathy and self-efficacy. But especially for INI-CET, please be very careful. Remember some of these acronyms. And the last slide is stages of change. Again, this question has been asked previously. So let's discuss anybody who is going through the changes. Suppose the person is consuming alcohol and now he's stopping. So they may pass through these stages of change which was given by Prochaska and D. Clemente, which you can remember better with the acronym PCPAM. पहला फेज है प्री कंटेम्पलेशन। बेटा प्री कंटेम्पलेशन का मतलब है पेशेंट डज नॉट कंसिडर कि कोई प्रॉब्लम भी है। सर हु कंज्यूम्स अल्कोहल, देयर इज नो प्रॉब्लम। सेकेंड इज कंटेम्पलेशन, पेशेंट रियलाइज की प्रॉब्लम तो है एंड पेशेंट इज कंटेम्पलेटिंग बट अभी देयर इज नो कमिटमेंट फॉर एक्शन। पीसी पैम, बेटा पी फॉर अगेन प्रिपरेशन, नाउ द पेशेंट हैज अ इंटेंट, अब मुझे छोड़ना है, ही स्टार्ट्स मेकिंग अ प्लान, सो ही इज प्रिपेयरिंग। A for action, now he has stopped the behavior, so he is making a change, so he is having action. And M for maintenance, now he has continued this behavior for a long duration, maybe for more than 6 months he has not consumed alcohol. And remember, patient may have relapse, may again start consuming from any of these stages. So this is very important, remember the stage of change. They may just ask you, the patient is having this behavior, so which stage of change the patient is in. So please remember the mnemonic is PCPAM. So these were some important points about the psychiatry discussion, but again this is a slide which I always show and we all are eagerly waiting to listen to your success story. Please remember, anything is still possible, you have time, so focus on important areas, try to revise, solve MCQs, try to see what mistakes you are doing when you are solving questions. Very important to practice MCQs beta, and when you are practicing MCQ solving MCQs, always see what mistakes you are making, because so many times I see, especially in INI-CET exam, students would know the concept, know the right answer, but in the exam they have marked incorrect statement. So please be very careful with this, and again as I always say, take one day at a time, take one session at a time, and keep smiling, keep moving forward. Very important to keep a smile, and whenever you are studying, don't be serious होके पढ़ना है, बहुत serious होना नहीं है. So please be very careful, smile a few times every day and keep moving forward, and you can reach to your goal. And always I say, keep the hustle on, and keep hustling and you will reach your destination. So with this we will end the session today. Thank you so much. But a defense mechanism, chalo I'll briefly discuss defense mechanism. Defense mechanism, basically these are the tools used by the ego. So beta defense mechanism mein these are the tools which are used by the ego. So ego tries to balance the conflict between id and superego, and it uses some tools. And remember, these tools used by the ego, are they used by the conscious mind? No, they are in the unconscious mind. So many of us may also be using some of these defense mechanisms. So when you are seeing questions on defense mechanism, but I always say, see the names. Like there is a defense mechanism projection. But always try to remember, when you read defense mechanism, see the name projection. Projection mein what happens? Patient is projecting his own inner conflicts, inner emotions onto other. For example, a husband is having an extramarital affair. बेटा पेशेंट का, पर्सन का खुद का extramarital affair चल रहा है, बट वो क्या करता है, वो अपने इमोशंस को अपनी वाइफ पे प्रोजेक्ट करता है. ही स्टार्ट्स बिलीविंग दैट माई वाइफ इज एक्चुअली हैविंग एन extramarital affair. So always see the example, see the name, and you will be able to understand these defense mechanism. Then there is one defense mechanism, बेटा displacement. देखो displacement में क्या हो रहा है, person is displacing, so there is conflict which on one person or situation, and he is displacing that conflict onto the other person. For example, the husband is angry on the boss, but beta boss को तो नहीं डांट सकता. He comes home and scolds the wife. So he is displacing his conflict from one person or one situation to another person. So this is how you can remember the defense mechanisms. Okay. Right. So again, thank you so much. Please revise, solve MCQs, and you will clear the exam. So all the very best to all of you.